But without delaying any further, I think we're going to start. I'm going to invite Dr. Valdes up, who's going to moderate the first section.
Well, welcome again. This is going to be the contemporary understanding of sudden death disease. And next, we'll do the first 4 talks, Q&A, and then we'll have the keynote talk after the Q&A with a question answer following that one. Our first speaker needs no real introduction in this kind of meeting, but it was going to be Dr. Michael Ackerman from Mayo Clinic, who's going to be talking to us about long QT syndrome, update and cutting edge treatment and approaches. So everybody welcome Dr. Ackerman.
Well, while this is getting put up, actually, I want us to put a big hands together for Dr. Kim, Dr. Miyake, and the Texas team for putting an incredible program together and enduring try, and try again. So thanks, Jeff.
Just close that out. Yeah, there you go.
So before my counter officially starts, I just want to welcome everybody on behalf of the SADS Foundation, and Alice Laura is our CEO, and I've had the privilege of serving as president of the board of SADS for now a while. And we're really, really excited about this program. If you look at the program, obviously you did because you chose to come, it's legit. I mean, it's serious. And I'm just the warm-up act for the next talk. Did anybody get that? Prince? Warm-up band? Okay, I tried. I just thought of that back there. It didn't work. So this is Texas, but I am really grateful also for our 3 key speakers, especially who made the 2-hour flight from Bangkok. So, and where's Dr. Nada? Yeah, my dear friend so thanks for doing this. Cutting edge. Let's get to some cutting edge things. And it's really going to be new and futuristic. I'm conflicted. These are my conflicts of interest to disclose. I don't think they're going to affect my ability adversely in any way, but you can be judge and jury of that. And the slides have been reviewed and vetted. So, but I'll mention some things for which there's a relationship that's relevant with Pfizer and with Thrive Therapeutics. It's going to be 5 vignettes in the 15 minutes or so. And that is to detail the discovery of new long QT syndrome causative genes or substrates. We keep searching. And then 3 little stories on some of the progress with potential new therapeutics for long QT syndrome, not for today, but for tomorrow, that are advancing along. So I don't think we need to tell us about long QT syndrome. And I have to use a slide that I made probably 20 years ago, and it still serves the purpose. The most common cardiac channelopathy may or may not show QT prolongation, may or may not do sudden death. In fact, it mostly doesn't, for which most of it is due to loss of function mutations in one of 2 voltage-gated potassium channels. We know the mechanism. We know a lot about pathobiology of it as it sort of confers to a final common pathway, Jeff Tobin's term, final common pathway, to these various critical ion channels of the heart. And we know the names of the gene. In fact, when you discover a gene 30 years ago called Mark Keating 1995, that gets in Cell, as in the journal Cell, CELL. And they did. The first 3 genes were all published in there. And then over the years, there have been minor long QT syndrome susceptibility genes that have been discovered, and our program has provided many of these minor long QT susceptibility genes. And so you might say, why keep searching for new? A new gene is sort of so yesterday, doesn't get in nature, never will. It's at best gets into circulation genomics, and precision medicine, great journals. But if your goal is Nature paper, don't look for new genes anymore. But we look for new genes because that's what our patients who have genetically elusive substrate need. They need somebody to keep searching and not give up on them. It's said that 20% of long QT syndrome is genetically elusive. I'm not sure I buy that anymore. I think the genetic remnant of elusive disease is probably 10%. Those other cases, they're pretty weak cases. And so we've been offering to do new discovery for a long, long time. And the number of calls we have of somebody say, we've got an autosomal dominant pedigree of genetically elusive long QT syndrome, hardly happens anymore. Hardly happens anymore. But I'll give you a couple stories. This is the newest gene. Excited about it, but it's never going to matter probably to anybody else on the planet except for this family. That's how rare the new disease genes are. But this is a collaboration, and a point being, if you have a family and you want to keep searching, tap into programs like ours, like our colleagues at University of Wisconsin-Madison did with a family under their watch. The strategy is not a secret. You take the family with phenotype of interest. You hopefully have enough of them who are phenotype positive, and then you do genome sequencing and you triangulate and you see if something emerges. And as in this case, a missense variant emerges in ALG10B. Anybody ever hear of it? I didn't. It wouldn't have been on our strategy a decade ago, where a decade ago we did what was called hypothesis-driven candidate disease gene research, where we said that protein interacts with that pore-forming alpha subunit. I bet you that chip or channel interacting protein is a candidate. And we said, that's a good idea. Let's go look then at calmodulin. Let's go look then at syntrophin. But now you do it in a hypothesis-free matter, and you say, we're going to let the family bring us to the truth. And so that's what sort of the strategy of gene discovery involves. So I had no idea of what alpha-1,2 glucosyl transferase B was, didn't care, just thought, oh, that's interesting, let's figure it out. Then the way you prove it is now with the world of iPS re-engineered heart cells. So we create the cells from the patient who clearly has the phenotype called my QT is too long. Look at, ask the cells, are the cells, her cells, their cells, do they show the cellular surrogate for QT prolongation, a prolonged APD? And you see they do. And then you CRISPR-Cas9 gene cure her cells, and you make one single nucleotide switch back to normal out of the 3 billion nucleotides of information, and voila, her cells are cured in terms of the APD. That's proof positive that that missense variant is self-sufficient for this family's cause of their long QT syndrome. And you can do it by patch clamp, you can do it by MEA, you can do it by LEAP, different ways of showing that that single missense variant in that gene that encodes that protein, ALG10B, is this family's cause. No doubt about it. Now, we'll never find it again, probably. We've looked at our remnant of elusive families. Nobody else has a mutation in ALG10B. And then you can, if you're curious, you can ask the why. What's the pathobiology? And here's the why. Everybody see it? Make sense? No, it doesn't make any sense. So that missense variant causes a decrease of that protein. The decrease of that protein results in, oh, interesting. You see the y-axis, what the name of that protein is? hERG. So this is a protein that controls the trafficking of the hERG potassium channel. The net effect of this family is it's essentially an LQT2 phenocopy, if you will, or genocopy. And so all things converge, again, back to the big three channels. So far, everything seems to be converging back to the big three. And like I said, this will come out soon, just got accepted as the newest gene. So the point, if you have a family with genetically elusive long QT syndrome, keep searching. Keep searching. You might not be able to do the searching, but partner with somebody who's willing to spend the money for something that will never end up in Nature, Science, and Cell, again, because the families deserve for us to keep searching. Here's a second family and a great case from Katie Tolbert, who's now a first-year medical student in Milwaukee, of an autosomal dominant pedigree. You and I would have bet the ranch from this ECG that this family should have been or should be what? You had to pick one of the big three, LQT2. The LQT2, some people don't realize that one of the common characteristics of LQT2, besides the notch and the flat T waves, is T wave inversion in V1, V2, and V3. You almost never see T wave inversions in LQT1 and LQT3. You do often in LQT2. So we bet it should have been LQT2. Commercial test number one, negative. Commercial test number 2, negative. We said, it's gotta be LQT2. So we said, okay, maybe it's not, maybe it's gonna be something that converges to LQT2 pathway. And so let's do what we know how to do in our program. Interesting. And what we did was the same strategy, but now look at what happens. The story of a deep, deep dark space intronic variant in the LQT2 causative gene KCNH2. And so, but we don't know, the commercial tests don't canvas that area of the intron. And so we then can ask of the model cells, what is the RNA look like? What is being generated? And what's being generated is an insertion of 89 additional nucleotides as a new exon, net effect, creating a frame shift mutation in the LQT2 causative KV11.1 potassium channel. So here, if you think your family has LQT2, phenotype looks like it, it must be it. You think your family has LQT1, phenotype feels like it, it must be it. It might be, it just might be in the dark spaces of their respective genes that the tests don't canvas yet. And so look again, do genome sequencing, again, stare at all of that gene and see if by chance there's something deeply intronic. And we're currently doing that with our remnant of negative cases to say how many of these might actually be still LQT1 and LQT2. It's kind of like a paper we wrote long ago. Let's keep looking where the light stand or the lamp standeth or shineth or whatever that expression is. So 2 vignettes of new discoveries and treatment. What do we do for treatment? I'm not going to talk about current treatment because Charlie Berul is going to mention and talk a lot about defibrillators. He's also going to discuss denervation. I'd love to chat about those. We don't do the most defibrillators in the world for long QT because most people with long QT syndrome do not need and should not receive an ICD. We do a lot of denervation, and as you know, we probably do more denervations at Mayo Clinic than anywhere in the world, and we love that treatment option, but it's not a perfect option. We still need to keep searching for new therapies. Why search for new therapies when we're pretty good overall? If you look, when we tailor therapy, we don't have death. Death just should not happen from long QT syndrome. So we might need to be moving the goalpost from preventing death to living and thriving despite the diagnosis. And how well are we living and thriving? Well, this is the reason why we keep searching. And a soon-to-be medical student and one of my MD PhD students, Sahej, we put together this summary, very sort of, it's one of those reveal your dirty laundry summaries of all of the side effects that have been shared by my nearly 2,000 patients with long QT syndrome that are under our watch. It does not, our current strategies are not completely satisfying, even denervation. And the biggest single thing that slows down excitement or too much excitement of denervation is post-denervation neuropathic pain, which we need to get a better handle on. And so we try to individualize more, and we have other, I would say, unconventional therapies, including intentional non-treatment or INT. Making the decision not to treat a patient who you know has the disease is actually very, very hard. But I think it's really important, and we need to become more confident in non-treatment. And then we have monotherapy and so forth. But can we do even better? And one of the betters might be gene therapy. And I'm going to give you a brief ARV work of 4 slides and then 2 newest therapies. I'm not going to talk in detail about gene therapy because later after the break, Dominic, Dr. Abrams is going to be talking about the state of gene therapy. But this is what we've developed at Mayo is suppression replacement gene therapy. And the beauty of this idea is you have a single therapeutic per gene. It's mutation independent. You just have to have a mutation in that gene of interest. And then what we do is we silence out with the old, in with the new. We silence the mutant copy, we silence the normal copy, we don't care. And we silence it with a specific shRNA that is in a 29 nucleotide stretch, say, of an area that is completely void of genetic variation, a one-size-fits-all silencer. And then remember the wobble? That's what we do, is we wobble the third nucleotide in that 29 stretch to create a new cDNA construct that would not be recognized by your silencer, but builds the exact same protein. And we've shown this already for LQT1, published this last year in Circulation, and then just published it this year for LQT2 in Chris Semsarian's journal. And again, this is the work of my MD PhD student, Sahej, who just left yesterday for Bern, University of Bern in Bern, Switzerland, and you'll see the why. And here, we show the yin and the yang of it. Whether you're too long, we can shorten your APD. If you're too short, called short QT, we can lengthen your APD. And this brings us to the latest, where we've moved it out of the dish, and thanks to Katja Odening, to her program with her Wasco wabbits and the LQT2 rabbits of hers, and we injected the first rabbit around Valentine's Day of this year. We've done several rabbits, too early to reveal. You'll know in 6 to 12 months, we'll know in 6 to 12 months whether we're moving towards an IND or whether the program gets killed. So we'll see whether in the rabbit we can normalize and cure their ECG and their QT phenotype. So we'll see. Stay tuned. I hope to give you an update in about a year. Now, I'll share with you, leaving the gene therapy, the newest kid on the block as a potential target. It's new as in 5 years, and that is targeting serum and glucocorticoid regulated kinase 1, SGK1. Discovery was made that this kinase is involved in generation of late sodium current. And so an SGK1 inhibitor might have a QT shortening effect. Proof of principle was demonstrated for LQT3 in this paper. We have been testing a variety of newly synthesized compounds, SGK1 inhibitors, for the company in our various re-engineered heart cell models of LQT1, 2, and 3. We have a good LQT3 model shown here. We cure that model with the isogenic control so that you know what a curative level of APD shortening can be for that person's cells. That's one of the beauties of the CRISPR-Cas9 model system, if you will, is you know what cure would equal when you do that for that patient's cell line. It's interesting that that LQT3 mutant line has activation of the SGK1 system, which is showing the validity of it. And then we see here the shortening effect of this novel SGK1 inhibitor, and what, again, here would be curative level of shortening with the CRISPR-Cas9 correction, and what the SGK1 inhibitor, and over again in all of our models of LQT3 and 2 is performing better than mexilotine at therapeutic doses would. And so this inhibitor is making its way to, it's already done, it's been developed, it's druggable now, it's in a phase 1 trial that's been completed in healthy volunteers, and the phase 2 trial in patients with long QT syndrome will likely start in the next 6 to 12 months. And for some of the programs who we're making eye contact with, I'll be calling you about enrolling LQT3 and LQT2 adults. So it'll be starting with adults and so this will be the first drug study for long QT syndrome that's new since, anybody remember? Eleclazine. So eleclazine is the failed drug, but that failed for non-long QT3 reasons, which we could comment. Last slide on a sneak peek of new, as in, so we've been working on gene therapy for 5 years. We've been working on this drug now for the last 3 years. And then we have this compound for the last year. So compound MC in the dish in every re-engineered heart cell of LQT1, 2, and 3 that we've tested to date does that kind of APD shortening, whether you're LQT1, 2, 3, 3, and 3, and we have others not shown here. So that's all I can show you is compound MC, and MC is not for one of my most favorite musical artists of all time, That's MC Hammer. That's a true statement. I do like him, full confession. But that's for Mayo Clinic. So hopefully I can tell you more about that. So wrapping up, I leave you with these 5 take-home points. 1, if you have a patient with genetically elusive long QT syndrome, keep searching. These families deserve us to keep searching and serving them. And I'm delighted to partner with you. 2nd, if you would bet the ranch phenotypically that your family is an LQT1 or 2 family, keep looking and look at those genes again. And eventually the companies will be including intronic exploration of the major genes. That's just around the corner. So that's going to start happening. 3rd, we turn to novel therapeutics. And I would say our proof of principle exercise for subrep gene therapy has been fully completed. Next up are the long QT rabbits. And hopefully we'll have an update in a year as to whether it works or whether we're on to something else. Keep an eye, number 4, on the SGK1 inhibitors as a novel drug for long QT syndrome. Likely LQT2 and 3, I don't think is going to work for LQT1. And those phase 2 clinical trials in humans, patients with long QT is going to probably start summer, fall of 2023. And then hopefully maybe next time we'll see if compound MC has advanced out of the dish. The issue is whether we can take what we've discovered and make it into a druggable solution. And so if we can, maybe we have something. If we can't, that was we did good in the dish, but did terrible everywhere else. And so with that, I just want to thank those entities that have partnered with us in our program, and especially the philanthropic support from Wendy's family. And I'm looking forward to the rest of the speakers and our questions and conversation after we're all done. Thanks, everyone.
Thank you. Our next speaker, Dr. Prince Kannankeril from Vanderbilt University, will be talking to us about what's new in CPVT. So welcome, Prince.
Thank you, and thanks, Mike, for loading my slides for me. I was asked to talk about what's new in CPVT, so I'm going to go over some recent studies that I find interesting, as well as a couple of illustrative cases. I have no disclosures. So CPVT, as most of you know, it's a channelopathy characterized by a structurally normal heart with a normal resting ECG. We typically make the diagnosis by eliciting bidirectional VT on exercise testing. It's most commonly caused by variants in RYR2 in the heterozygous state, and classically in calsequestrin 2 in the homozygous state. And we treat this with nadolol, flecainide, and with left cardiac sympathetic denervation. And this is all what's old in CPVT, right? There's nothing really new on here. And this also is an old slide, but it's an oldie but a goodie, if you will. This is from Bjorn Nolman's classic paper characterizing the calsequestrin knockout mouse. And you see a really nice recapitulation of the human phenotype when these mice are exercised or undergo adrenaline stress. They have PVCs and bigeminy and really nice polymorphic and bidirectional VT. But he also made the heterozygous calsequestrin mouse. And let me see if I can get my pointer to work here. Oops, uh-oh. It's not going to work for me. Oh, do you guys see it? Excellent. Okay, great. So here is the heterozygous calsequestrin knockout mouse. And as you can see, it actually has a pretty normal level of calsequestrin. The homozygous has very low, actually no calsequestrin at all, also very low levels of triaden and junctin, whereas the heterozygous mouse actually has pretty normal levels. So no big surprise that many of the early families, the heterozygous patients appeared to have no phenotype at all. That is until this paper from Chris Semsarian's group, this was back in 2016, demonstrating that a family with the K180R calsequestrin variant had pretty classic CPVT when they exercised, and these are all heterozygous patients, all right? And there have been other families and case reports of similar calsequestrin heterozygous patients who have the full-fledged CPVT phenotype. And so now we get to some stuff that's new in CPVT. So this is a paper from Matt Wilclency working in Bjorn Nolman's lab. And so they engineered the K180R calsequestrin mutant mouse. And in the heterozygous state, this mouse had just as much VT as the homozygous mouse did. All right, so just like the families. If you look at the cellular CPVT phenotype, the calcium sparks and calcium waves here, again, you see the heterozygote has just about as much abnormality as the homozygous mouse. And so if you look at the calsequestrin protein or calsequestrin polymers, it's actually not significantly reduced compared to wild type. Similar amounts of triaden and junctin compared to the wild type. So what's going on here in these heterozygous mice? Well, here we've got traces of cytosolic and intra-SR calcium. And so you can see in diastole, the K180R heterozygous mouse has this excessive cytosolic calcium here. And so the mechanism is depicted here on this cartoon. So in diastole, when calcium is being taken back up into the SR, the K180R mutant has decreased calcium binding affinity. That results in a lot of free calcium near the RYR2, resulting in calcium leak and therefore delayed after depolarizations, as well as triggered beats and then ventricular tachycardia. All right. So enough science for now. Let's get to a clinical case. All right. So this is a case some of you may have seen before. This is an 11-year-old boy who had a cardiac arrest while standing in line after his first day at a new school. So kind of a bad first impression there. He wasn't exercising, but he was nervous. So somewhat of an emotional trigger. He gets CPR and an AED is applied. He gets shocks delivered, taken to his local hospital where he recovers well. He has a totally normal echocardiogram, but his QT is pretty significantly prolonged, about 500 to 550. So that's more than we typically see in the post-arrest period. And it actually persisted for a couple days afterwards. So we also did a treadmill test, and he had PVCs in bigeminy, so not really a fully fledged CPVT phenotype, and maybe he's long QT. But then we take a look at his AED tracings, and so as soon as the pads are placed, he's in ventricular fibrillation. A shock is advised, a shock is delivered, the shock successfully defibrillates. I'm going to skip ahead here. He's continuing to go into this polymorphic ventricular tachycardia, for which a shock is advised, a shock is delivered, and this shock is completely unsuccessful. All right. Now he gets CPR, and eventually he goes back to sinus rhythm and he regains spontaneous circulation. But now we're really suspicious for CPVT, right? So Christina Miyake showed us that shocks are very ineffective for the polymorphic VT we see in CPVT. And so with this AED tracing, we're much more suspicious. And so I said on his Bruce treadmill, he just had PVCs and bigeminy. But we have this paper to look at. This is a paper from Shu Sanatane's group in Vancouver, where they had patients who were family members of patients with CPVT who had RYR2 mutations. But on their standard Bruce protocol, they had suspicious but not diagnostic treadmills. All right. And so they brought them back for what they call this burst exercise test. So this is a very elegant system here. Basically, just take the final stage that the patient reached on their standard exercise test and start them there and just have them stay there. So they go from standing to running uphill really quickly in this burst of exercise. And by doing that, they could actually elicit the fully penetrant CPVT phenotype on treadmill. And so we brought our patient back. We had him on Nadolol, but on the burst treadmill test, he actually has couplets. And I know there's a lot of artifact here. It's kind of hard to see. But here you see a sinus beat, a PVC, and then a PVC of a different morphology. And so, again, this is on Nadolol. His initial Bruce treadmill on no medications, he only had bigeminy. So we're treating him like CPVT. And so, of course, you're wondering, well, what did the genetics show, right? Well, when we looked at the big three long QT syndrome genes, he had no variants. RYR2, also he had no variants. Calsequestrin 2, no variants. He did have this heterozygous variant in TECRL, and so TECRL in the homozygous state can cause a CPVT-like disease, but to date, there have been no heterozygous patients, so we sort of left that one alone, particularly because he had two variants in calmodulin 2. Now, both of these were novel variants. They had not been described before, so we really couldn't say anything about their pathogenicity. And calmodulin 2, you know, can cause long QT, it can cause CPVT, it can cause this overlap syndrome. This is a figure from Naomasa Makita's paper published back in 2014. And this is the same patient here. You can see they got a long QT, they've got non-sustained VT on their exercise test, and they have a calmodulin 2 variant. And so we've got this patient that looks like they have CPVT. They've also got a long QT. They have novel variants in calmodulin. In the old days, and by the old days, I mean like a year or two ago, you know, you could call Mike Ackerman and say, hey, can you look at this in your dish? And he has to decide if he wants to spend the time and money to do that. But now we don't have to wait, right? Because every possible calmodulin mutation already has in vitro data available. All right, so calmodulin, of course, there's 3 different calmodulin genes in the human genome, 1, 2, and 3, but they all encode this exact same amino acid structure, 149 amino acids here on the x-axis, every possible amino acid substitution here on the y-axis. And so you can just look up your variant, and here's our 2 variants. And so you can see they're indicated with a dark blue, meaning that they're likely pathogenic. So again, this is not perfect by any means, but we don't have to wait anymore for someone to make these variants in the lab. We can look at them, and this will be coming for all of our favorite genes at some point. So this is something that I think is really exciting on the horizon. All right, on to another illustrative case, and this is a girl that I didn't personally see, so I don't have all the details, but I'll give you everything that I was given. This is a 12-year-old girl who also had a VF arrest while standing in line at PE class. She got some AED shocks. She had an SICD placed, and she has a variant of uncertain significance in RYR2. And I was contacted after she had 3 shocks for VF in 4 months, despite being on Nadolol plus flecainide. And so they were asking, you know, does this patient need a sympathectomy? What do we think is going on? And so they sent me her treadmill tests, and I'll show them to you here. And actually, they just sent these strips, so you're seeing everything I saw. Very first treadmill on Nadolol. She actually had no ectopy at all during exercise, and Bigemini here during recovery. Second treadmill test on Nadolol plus flecainide, very similar. No ectopy at all during exercise, just Bigemini during recovery. And the third and the last exercise test that they performed, this is on Nadolol plus flecainide. She does have this couplet in recovery, but again, nothing at all during exercise. And they sent this SICD tracing, and they said that this was typical. And so what you see here is a mild sinus tachycardia. There's a premature beat, and then a relative pause, and then a PVC that then starts this run of ventricular fibrillation. And they said this was typical, and so I said, oh well, let's look at all of her events. And so they pulled all of her SICD tracings, and they all had this really remarkable, consistent pattern: premature beat, relative pause, PVC that then starts ventricular fibrillation. So this made us think not of CPVT, but of a different disease entirely. And that disease is, anybody got a guess? I think I heard something. Yell it out. There it is. Yes, yes. Calcium release deficiency syndrome. Okay, so this is a phenomenal paper. If you haven't seen it, you need to go read it. It's amazing. They define a new phenotype. They characterize the variants. They make a mouse model. They actually make some important clinical observations that I'll get into. But these are patients that all have RYR2 mutations. They present with VF, aborted sudden death, often during exercise or emotional start. So they kind of act like CPVT. But in this initial paper, all the patients actually had a completely negative treadmill test. And subsequent papers have shown that some patients have mild ectopy, kind of like this 12-year-old girl does. And here's the mutations that are in this initial paper. And as you know, RYR2 mutations that cause CPVT result in excessive calcium leak. These mutations all result in the so-called loss of function, that is deficient calcium release, which is, I guess, why they called it the calcium release deficiency syndrome. But they made this really important clinical observation here. So this is a dot plot from an ICD tracing from an affected patient. And they saw this relative sinus tachycardia, followed by a relative pause, and then a short coupled PVC that then begins ventricular fibrillation. Now, since many of these patients did not have a clear-cut clinical diagnosis, they'd undergone kind of traditional V-stim studies and did not have inducible VT. But in 2 patients, they performed this novel V-stim strategy. They call it the long burst long pause, short coupled sequence. So this is a burst of 15 beats at a relatively fast drive frame, then a relative pause, and then a short coupled PVC. And in the initial paper, in 2 of their patients who were mutation carriers, they both had inducible ventricular fibrillation with this new protocol. Now, this protocol has been studied in this paper in 9 different mutation carriers, and it's not perfect. You can see not everybody actually is positive with this, and in this paper, 1+ means they had at least non-sustained VT. 2+ means they actually had arrhythmias that required cardioversion. But what's really interesting is flecainide seems to be effective, at least in this series of 9 patients. 8 of them were completely non-inducible by this protocol. And metoprolol might actually make some things worse. All right. Now, obviously, the numbers are far too small to make any definite conclusions now, but it looks like we should be treating these patients differently than we treat our CPVT patients. And so I think it's important for all of us to sort of be aware of this syndrome, kind of look back at our patients that we've been treating like CPVT, but maybe they didn't have the full phenotype, and then consider this entity. All right, I'm going to finish up with this one last paper, which again I think is really cool, and it has some implications. So for a long time, people have hypothesized that the origin of the ventricular ectopic beats in CPVT is from the Purkinje cells, right? And so that has some important implications. So if Nademanee is going to talk about ablation of CPVT, he's probably targeting Purkinje cells. If we talk about gene therapy, some people think, well, maybe we can just we can just deliver the gene product to just the Purkinje cells. And so in this paper, this is led by Dan Blackwell in Bjorn's lab. He actually made a Purkinje cell specific calsequestrin knockout and a ventricular myocardiocyte specific calsequestrin knockout. So here's the wild type mouse. So this red stain is for the Purkinje cells, green is for calsequestrin. And so here you see you've got calsequestrin in both ventricular myocytes and Purkinje cells. And of course, when you subject these mice to stress, you just see sinus tachycardia. Here's the calsequestrin knockout. So no calsequestrin in either the myocytes or the Purkinje cells, and you see CPVT. Here we have the Purkinje cell specific calsequestrin knockout. So there's no calsequestrin in the Purkinje cells, but you've got normal calsequestrin in the ventricular myocytes, and lo and behold, no CPVT. Here in this ventricular myocyte specific knockout, where you have normal calsequestrin in the Purkinje cells, you have a CPVT phenotype. All right. So what's going on here? Well, here's a model where you've got a Purkinje cell fiber in a sheet of myocardial cells. And when the myocardial cells are abnormal, a delayed after depolarization in the myocardial cell can propagate to an action potential in the Purkinje cell. But you don't see that in the opposite situation. Here, when you have a delayed after depolarization in the Purkinje cell, it does not propagate into the myocardial cells when the myocardial cells have normal levels of calsequestrin. And so this mechanism here is sort of depicted in this cartoon. So because you have a favorable source sink relationship here, you can get propagation of DADs from myocardial cells to Purkinje cells, but not vice versa. So when you're ablating these, you're probably ablating the peri-Purkinje cell myocardial cells if you're actually eliminating the PVCs. So with that last bit of exciting science, I will conclude the talk and be happy to take questions in the panel discussion. I'll let you run this.
Thank you, Prince, for that great talk. Our next talk, Dr. Molly Shaw was unable to come, unfortunately. So Dr. Jeff Kim here from Texas Children will be talking to us about hypertrophic cardiomyopathy, outcomes and risk assessment, and approach to exercise in the modern era. So welcome, Dr. Kim.
Thank you, Santiago. Yes, I'm not Molly, but this is an area of interest for me, so I'm going to try to pinch hit the best I can. And I do hope to focus on modern understanding of outcomes and risk, but also on how we approach balance. How do we encourage our patients to continue to engage life the best that they can? And I want to start with a quick case vignette. It's a patient that I took care of about 20 years ago. Some people from Texas Children's might remember, but he was a previously healthy 16-year-old male who presented for evaluation because he had some palpitations during football. He was really active. He was a starting running back in his high school team, and he had A's and B's. And this was his ECG. It showed pre-excitation, so WPW, but also showed very large voltages. And when he got his echo, this is what it showed. And so he had significant asymmetric septal hypertrophy, and he was given a diagnosis of HCM. So we took him to the cath lab, we ablated him, got rid of his WPW, and his palpitations resolved, but he still had high voltage. We weren't able to ablate his HCM. And so he immediately asked, when can I play football again? And due to his diagnosis, concern regarding risk, he remained restricted. At 1 year follow-up, he was morbidly obese, was struggling with grades, was clinically depressed, but I told myself he was alive. And the question I've asked myself since then is, was that the best that we could really do for him? So what is hypertrophic cardiomyopathy? For the people in this room, I don't really need to spend a lot of time on this, but quickly we know that it's a very common form of cardiomyopathy that we see relatively frequently in children. And it's characterized by unexplained cardiac hypertrophy, myocyte disarray, fibrosis, and often diastolic dysfunction. Clinically can result in outflow tract obstruction, impaired cardiac output, ischemia, heart failure, arrhythmias, and sudden death. And here you can see some of the classic representations of the pathology and the histology showing massive hypertrophy, fibrosis, and disarray. Genetically, we know that HCM is oftentimes a disease of the sarcomere, so the contractile apparatus of the heart. And there are over 900 mutations identified to date in over 20 genes. And usually it's inherited in an autosomal dominant fashion, but still the main players in this disease continue to be myosin binding protein C, beta myosin heavy chain, alpha tropomyosin, and the troponin complex. And genetic testing really is an important part of diagnosis and management today. In regards to mechanisms of disease, there's really a lot of proposed pathways. People talk about disturbed biomechanical stress sensing and maladaptation, impaired calcium cycling and sensitivity, altered energy homeostasis, so this advancing inefficiency, and increased and progressive fibrotic changes. And all these pathways combine and interplay to really contribute to the pathogenesis that we looked at. Very briefly, in regards to treatment, it's really supportive to date, which means we want to reduce symptoms and ultimately prolong survival. And this includes pharmacotherapy. In general, we talk about keeping the heart slow and full, and antiarrhythmics if those are needed. Non-pharmacologic therapy like a surgical septal myectomy can be very helpful in reducing gradients and symptoms. And then lastly, in high-risk patients for sudden death, we talk about ICDs, which can be life-saving, and we'll talk about this more a little bit later. Before we move on from therapy, however, I do want to point out that although classically therapy is supportive, not really aimed at altering evolution of disease, there are several studies ongoing, this one in valsartan, that are aiming at early intervention, seeing if we can attenuate disease progression. And so you'll hear more about this as time goes on. So given that background, what do we know about outcomes in pediatric HCM? And there are a lot of new data points, but grossly, when you talk about outcomes, you're really talking about the development of heart failure, arrhythmias, sudden cardiac arrest, and death or transplantation. And several studies have looked at this recently. This one is a longitudinal cohort study from Australia. They looked at 80 children with pediatric HCM over a period of 15 years. And the primary endpoint was time to death or cardiac transplantation. And they found that the overall freedom from death or transplantation was 86% at 1 year after presentation and 80% at 15 years. So the highest risk is really in that first year after they present. Subsequent to that, if you look just at those that made it beyond a year, the attrition rate is really quite low at about 0.4% per year. Outcomes are worse in infants. And if you look just at those over the age of 1, survival's better, 15-year survival about 90%. And in all cohorts, sudden death really was the most common mode of death. This is a newer multi-center study. It's just from a few months ago. and looked at outcomes in an international cohort of 639 pre-adolescents and then compared them to the older age cohort. The primary outcome, again, was death and transplantation. Secondary outcome was life-threatening arrhythmic events. And in this study, there was really no long-term difference between those under 12 and those older. Transplant-free survival was pretty similar to the study that we looked at, and the annual incidence of life-threatening arrhythmic events was a little more than 1% per year, which was, again, the main driver of mortality. Lastly, this larger multi-center observational study evaluated over 7,000 children. The primary endpoint was expanded beyond death, looked at heart failure and arrhythmias. And they found that childhood onset HCM had about a 2% overall event rate. So any of those outcomes, about 2%. Ventricular arrhythmias were the most common event, especially in the pediatric age group. Heart failure and AFib became more common in adults. And lastly, when compared to adult onset HCM, childhood HCM was more likely to develop ventricular arrhythmias and twice as likely to ultimately require either transplant or VAD. And here you can see that cumulative incidence of cardiac events over time. By 10 years, 18% had met one of the composite outcomes, most being ventricular arrhythmias. Interestingly, the risk of ventricular arrhythmias remained pretty constant over time, about 0.7% per year, while heart failure and AFib became more common as you got older. So in general, when you look at those studies, about a 2% per year, something happening, around a 1% per year risk of ventricular arrhythmias. And as we'll see, mortality that is lower and continuing to decline. So in that light, the main focus in terms of primary outcome is arrhythmias, sudden death, and risk protection. And the predominant arrhythmia we know we're talking about is ventricular tachycardia, which can lead to sudden death. And there are mechanistically many causes why HCM will give you VT. And several reasons include myocyte hypertrophy, results in action potential prolongation due to a decrease in transient outward potassium current. Developing fibrosis, which results in dispersion of conduction and delay in electrical propagation. Intercalated discs are disrupted and cell-to-cell transmission is disturbed. There's abnormal calcium handling, resulting in shorter effective refractory periods, and then ongoing ischemia, which result in further dispersion of electrical activity. And all these in concert promote reentry in ventricular tachycardia. So most of the VT we see in HCM is really reentrant, and we'll see how we can intervene on that. Now, these ventricular arrhythmias are the primary reason for cardiac arrest, and the estimated rate of cardiac arrest do correspond to that. In adults, the largest contemporary studies show a rate of about 0.5 to 1%, and in children, it's likely a little bit higher when you look at studies somewhere between 0.7 to 1.8%. Now, having said that, many isolated centers, including our own, are finding lower rates with current management strategies. So I do think this is evolving and not completely defined. But we know that an ICD is a life-saving therapy for this, and it's been proven effective in real life. Overarchingly, real world outcomes are good. And in this patient of ours, it was life-saving, where you can see got an appropriate shock for VTBF back into sinus rhythm. However, we know that long-term complications exist, especially for children. And so much of the literature in HCM in the last decade is really looking at risk prediction. How do we know who's at highest risk and who needs an ICD? In adults, there are well-evaluated risk factors. We've all seen these. 5 major risk factors canonically have been non-sustained VT, severe LVH, abnormal blood pressure response, unexplained syncope, and a family history of sudden death. Several additional factors that have been identified since, including systolic dysfunction, LGE, LV aneurysm, LVOT obstruction, LA dilation, ECG findings, they all now do play a role. And with that, many of us have moved to looking at these, and you can go online and there are risk assessment models, scoring systems, where you can enter data about your patient. It'll give you a 5-year risk prediction and a recommendation. Although it's imperfect, it has proven helpful, especially in adults. Now, what about kids? In younger children, the association of risk has been a little bit less vigorously defined, but recent meta-analysis did find 4 major risk factors as a starting point that have since been expanded. They include previous adverse events, which makes sense, Those have the highest hazard ratio, followed by unexplained syncope, non-sustained VT, and extreme LVH. Subsequently, there has been a movement to make risk assessment models in childhood HCM, and everyone in this room has probably seen those. There's a couple in play. The most recent one is this one, which is a multi-center study called Primacy. They evaluated 572 children with HCM, followed for almost 3,000 total patient years. And the risk factors that were found to be associated with sudden death were history of syncope, history of non-sustained VT, LV wall thickness, age at diagnosis, and LA diameter. When you look at validation for this, there is reasonable predictive accuracy. The concordance statistic was 0.75. It's a little bit better if you include some genetics. And when you look at low risk, medium risk, and high risk, there's consistent and significant increases in predicted risk, which correlate to observed events. So they do match up pretty well. And when you divide them into tertiles of risk, there is a prominent difference in cumulative rates of events. The low risk group really having very, very low events, and the high risk group surpassing 15% at 5 years. Again, not a perfect model, but we're starting to gather some of these tools that make it easier for us. But there's an issue I want to point out, and something that we've seen many times. And so if you look at these models, for example, a 16-year-old, and this is a 16-year-old we follow, and you put him through the models he qualifies for. This is the AHA1, which if you're over 16, you qualify for. This one gives him a risk in 5 years of 3.5%, 3.6% or so. If you put that same patient in the primacy model, same exact measurements, same exact factors, it gives you a sudden death risk in 5 years of 29%. So that's almost a tenfold difference. To me, that points out that although risk prediction is advancing, there's still a lot of refinement we need to do before these completely take off. But there is good news. And if you look at contemporary young studies, even with admitted limitations in our risk prediction, with current management strategies, the rates of mortality are dropping. And current studies push them less than 0.3% per year. And more recent studies have shown that current paradigms, mainly related to sudden death prevention, ICDs, and medications, have resulted in a greater than tenfold reduction in historical mortality. So although we do need to stay vigilant, we do need to monitor for risk, I don't think the message to our patients should be overarchingly grim. So how do we shift that focus a little bit? How do we help our patients engage life? In particular, what should we be doing in regards to our approach to exercise? And first, I think we need to be aware that the diagnosis of HCM is associated with poor adjustment and psychiatric disorders. In adults, half of patients with HCM meet a DSM criteria for a mental disorder, 37% have anxiety, 23% have major depressive disorder, and these diagnoses were related to impaired quality of life and sociability early when they were children. In children, those with HCM also have significantly reduced quality of life, poor psychosocial adjustment in comparison to peers, and surveys show poor adjustment in childhood is primarily related to anxiety and inability to be involved in activities and sports. So where are we headed in this regard? Well, here's the most recent management guideline from 2020. Some in this room were actually on this. They say that for most patients with HCM, participation in low intensity competitive sports is reasonable, and participation in high intensity activities, moderate or high intensity competitive sports, can be considered after comprehensive evaluation and shared discussion. And so this is an important shift in paradigm, moving along with shared decision making, which is something you're going to hear about more a little bit later from Dr. Cannon. But it's also important to note newer understanding of physiologic adaptation with exercise. This has really evolved based on growing data. And when you look at athletes with HCM that have been involved in high-level exercise, they have milder LVH, larger, more normal LV dimensions, superior indices of diastolic function, less obstruction, no increased fibrosis, all pointing towards what authors suggest is favorable adaptation. And in some animal studies, in transgenic mice, even with a short period of training, there's decreased hypertrophy, decreased myofibrillar disarray, and decreased collagen content and fibrosis, pointing towards favorable remodeling and hypertrophy with exercise. And this brings us to the question of acute risk with sports. So what is the risk for hypertrophs when they participate in sports? Have we been able to define this? We're not talking about general population data that we've seen, but athletes during the activity of sports. And recent data suggests that maybe the rates aren't as high as that we all have learned. The Rescue Cardiac Arrest database looked at competitive athletes over 18.5 million athlete years, and they found the incidence of cardiac arrest during sports was 0.76 per 100,000 athlete years, and there were 2 deaths attributed to HCM in 10 years. Looking at recent observational data in athletes with HCM, the estimated risk of cardiac arrest during competitive sports continues to push lower. And if you look at focus studies, and there are several of these, and this is one of them, recent publication looking at athletes with HCM, comparing those who stopped sports participation, that bottom dash line, to those who continued, the solid line. There was no statistical difference. If anything, those who continued sports did better with less events. Additionally, if you look at timing of events, most sudden death in children and young adults occurs at sleep or rest, not during sports or exercise. And in young hypertrophs, 65% occurred at rest, 20% during light activity, and only 15% occurred with exercise of sports, suggesting maybe focusing on sports alone is a little misguided. Lastly, outside of acute risk, I do want to show that several studies have continued to show benefits of exercise in hypertrophic cardiomyopathy. Moderate exercise consistently results in improved functional parameters, improved quality of life, decreased arrhythmia burden, and no increase in adverse events. Even in high intensity exercise and sports, there's improved LV dimensions, decreased LV wall thickness, improved cardiac function, VO2 max, stroke volume, and no increase in fibrosis or worsening of phenotype. So the long-term effects of cardiovascular fitness in hypertrophs may be beneficial. So I do think when you assess the balance in your approach, that the current guidelines do make sense. And I personally would advocate that if a patient has HCM, they could participate in light and moderate exercise with guided approach. Even vigorous and competitive athletics should be considered in select patients after assessment and in that model of shared decision making. And in contrast to the patient at the beginning, I apologize that this doesn't play, but this is another patient which HCM was discovered based on ECG screening in high school, and she was initially restricted from sports. After this shared decision-making model and discussions related to sports, she was allowed to continue, and she was a swimmer. She placed third in state in Texas, and then she signed on with Arkansas, where she's on scholarship, and she's continuing to do quite well. So I do think we need to maintain balance when we look at these kids and try to help them to continue to engage life. Thank you.
Thank you, Jeff. Our next speaker, also here from Texas Children's and Baylor College of Medicine, Dr. Christina Miyake, is going to be talking to us about unusual cardiac arrhythmias, including Tango 2, neurocardiac arrhythmias, and more. So welcome, Christina.
All right. So today I'm going to discuss 3 different syndromes, and all of them are associated with cardiac arrhythmias, but also neurodevelopmental delays. One of the cases is very rare. One's rare, but I bet you will see one in your lifetime. And one is a common heritable syndrome. I want to highlight the importance of recognizing the neurocardiac connection, some of the challenges and the potentially more difficult to control arrhythmias in this group. And then I want to highlight some of the treatments and, sorry, actually, this is the wrong one. Hold on. Sorry, guys, this is the wrong version. I apologize. There we go. Okay, we'll start over. Okay. And know this because I wanted to point out this last point, that when I'm talking about this, I'm going to bring up some clinical data, but I'm also going to bring out some points for those of you that are basic scientists working in the lab to consider in terms of basic research. These are modern theories of where do you go? All right, so we're going to do this as a mystery case. This is mystery case number 1. So this is a patient that got referred to me, young girl. All pictures are by permission by parents. She has a history of esotropia. She was undergoing eye surgery, and the surgery got aborted because she developed marked bradycardia and PVCs. So she came, referred to my clinic, and her history she had developmental and cognitive, as well as speech delays and difficulty walking. Her receptive language skills were much better than her expressive. And this was her EKG. Honestly, I thought it was just going to be some PVCs. But when I looked at her baseline EKG, you can see there's marked conduction delay, and there's also some AV block. So I thought, well, this is interesting. Went back to her history. She's got 4 siblings. Some are normal, but she has one brother who had cerebral palsy and was diagnosed with Joubert syndrome. I asked the mom to bring him in, and so she did. Turns out he has optic atrophy, a history of difficulty walking, developmental and cognitive delays, and all of this progressed over time. He's in his young 20s. Joubert syndrome is not associated with cardiac arrhythmias. And so when I looked a little bit more closely, they actually both demonstrated progressive cerebellar atrophy. So this is a degenerative disease. They also, when we looked at them closely, both had microcephaly, both had these long tapering fingers. Most interestingly, they're arrhythmias. So both had baseline conduction deficits, both demonstrated AV block, sinus node dysfunction, periods of atrial quiescence, meaning we couldn't see the P waves, at least on surface ECGs. Both demonstrated episodes of high grade and even complete heart block. Both had atrial non-sustained and slow non-sustained VT. Not knowing exactly what to do or what I was dealing with, I admitted them and tried them on a beta blocker for safety. And actually, when I did that, their arrhythmias got worse. So after talking to the family and hearing, there's actually some literature, and I'll discuss this a little bit, of sudden death and some patients needing pacemakers. We decided on a pacemaker. The family, because of the delays, actually, when we talked about the potential need to upgrade in the future with an ICD, they actually asked that I do the ICD first, given that they didn't want to have to come back and try to manage that. We brought them to the lab during the case, and I mapped the atrium. And you can see that there's quite heterogeneous voltages throughout the atrium, and even periods where in the AV node there really was very decreased voltage. So unfortunately, the older boy, he had an event. I think he was ill. He had increased seizures, got admitted to an outside hospital, had sustained atrial and ventricular arrhythmias, had a cardiac arrest, and unfortunately died. Any guesses? This is the rare one. This is not, even though this is rare, this is not unique just to this family. This is part of my K grant. My mentor is Jim Lupsky, and we did genetic whole exome, and they've both had biallelic variants in XOSC5. And so we reported this, and it is now in OMIM as a disease. What is XOSC5? XOSC5 encodes one component of an RNA exosome. You can see there's 9 different components to this. You can see that it's relatively ubiquitously expressed. So why does it cause the cardiac arrhythmias? I'm not entirely sure, but subunit 5 can cause these arrhythmias. Subunit 9 has been associated with 2 sudden cardiac deaths. So a little bit unclear whether there's more as part of this XOSC exosome or whether there are other RNA exosomes. So those of you that are studying it, what does this do? RNA exosomes are involved in RNA processing, but again, not sure how that involves the cardiac arrhythmias. All right, we're going to go on to, and that's the one that is very rare, but is definitely out there. I think you might see it if you have a patient, for example, that is undergoing neurologic evaluation and might have some arrhythmias, so pay attention. Mystery case number 2. So we're going to start out. I'm going to show you some of the baseline symptoms of this disease. You can see this is actually my patient, all shown by permission. She has some kind of gait abnormality. She's very stiff. In addition, there's difficulty with speech. These patients have better receptive rather than expressive language. It's difficult. They're dysarthric. And as they get older, this can actually progress. This is my patient. You can hardly understand her. She is understanding what I'm saying. She's answering my questions, but she's pretty wheelchair bound. Many common misdiagnoses for this condition you can see, but for your purposes, they are often misdiagnosed with long QT syndrome. The patient ages, we currently have patients ranging from newborns all the way to the 40s. So whether you're an adult or pediatrics, you might see this. In addition to their baseline symptoms, the patients also have these sudden onset, very unusual symptoms. You can see this young girl, she's ataxic. She almost, the parents will describe a drunk sailor. They'll often fall down and start crawling. They'll also be lethargic. This girl can't get off the ground. If they take a rest or they take a nap, they'll be back to themselves again, and you'll see her get up, and there she goes. She's back to normal. So this is a difficult diagnosis to make unless you're aware of these symptoms. If they don't eat, if they're ill, if they're fasting, then they don't get better. They can actually evolve into a life-threatening event called a metabolic crisis, these events that you often think about with metabolic disorders. During a metabolic crisis, what's different about this group is they all have cardiac involvement. They will all have prolonged QTC on their EKG. It can be quite marked. In our group, the median value was 550 and went some over 600. In addition, you might see a concomitant type 1 Brugada pattern that comes and goes. And I know many of you in there have seen this before. So this is what you'll see, and this is the concerning part, is that these patients will then go on to have recurrent polymorphic VT and torsade de pointe that is hemodynamically unstable and is the highest risk of sudden death or death. Mortality, if they develop, is at least 30%, maybe more. But a bunch of you in this room contributed. We published this in Heart Rhythm. So if you want more details about this, you can read it. I don't have time to go into all the details today, but I do want to point out that of the 71 patients in our registry, 65% of them developed one of these metabolic crises. Of those, 63% went on to have cardiac arrhythmias or cardiomyopathy. 69% of those had a cardiac arrest. 38% died. You can see the high percentage of VT, cardiomyopathy, and both. 6 required ECMO. Those are the ones that survived. There were 11 deaths. These are all the different treatments that have been tried. You can see none of them have been successful at treating all patients. But of these, the ones that seem to be the best, and keep this in mind if you come across this, is magnesium, isoproterenol boluses, and atrial pacing. Okay, any guesses? I know you. Anyone want to? What is this disease? All right. This is Tango 2 deficiency disorder. If you haven't heard of it, please, please, please keep this in mind. You will see it. We are the Baylor team, and as part of my case, we described this in 2016, the same time the German group described the same findings in the same journal. We currently have a natural history study that's ongoing. We have 80 participants over 18 countries. Tango 2, what does it stand for? It stands for Transport and Golgi Organization 2 homolog. The exact functional role remains unknown in humans. It's thought to be involved in ER or endoplasmic reticulum or Golgi processing, or the transportation or trafficking of proteins. Most recently, a Nature paper came out 2 weeks ago that it is involved in heme, at least in the nematode. Tango 2 deficient cells are thought to have secondary mitochondrial dysfunction. So we worked with the Broad Institute to determine prevalence or frequency of this. We think it is estimated to affect at least 6,000 to 8,000 worldwide. It is an autosomal recessive disease, and the carrier frequency is 1 in about 500 in the general population, highest in non-Finnish Europeans, about 1 in 300, and also Latinos. We think that this is an underestimate, however, because it doesn't take into account the 22q11.2 population. This affects 1 in 4,000. Many of you I know have seen this population. The TANGO2 gene resides in this region, and so if you've got a 22q11, you're already missing one TANGO2. If you are a carrier, then in your non-deleted allele, then your patient, in addition to 22q11.2, has TANGO2 deficiency. So I wanted to point out something just in terms of the modern era, where are we going? This is unique for the arrhythmia standpoint. I'm going to show you, remember my patient, she's quite significantly affected, but I'm going to show you another patient in our natural history study. She can walk, she can move, she goes to school, she can talk, she's completely normal. So we went to our natural history study database and we said, well, what's the difference between these kids who are doing better to those kids who are not? And what we identified is that those kids in the blue bar, these are the number of metabolic crisis events that they had when they were not on the vitamin or supplement shown below. And the green bars represent whether they continue to have crisis if they were started on that supplement. And you can see that the number of events is significantly decreased with the multivitamin or B complex. So patients that were taking a Flintstones vitamin were doing much better. We do have some studies. We are working with humans, so induced pluripotent stem cells you've heard a lot about. We took these, differentiated them into cardiomyocytes. I'm working with Dr. Lily Zhang in her lab and her post Wei, who's done a lot of work on this. And we created an isogenic control using CRISPR. So we have 3 different models of this. This is just one of the patients. I'm just showing you that here you can see that there is the cells demonstrate some pauses after depolarizations, kind of consistent with PVCs. And then if we administer some B vitamins, it resolves. So we have the basic data that also corroborates what we're seeing in the clinical, but I also want to show you, if you do have a patient and your colleagues come to you, not only do you want to consider vitamins, but also initiate them early. So this is my patient again. Remember, she can't talk, she can't walk. She got started on low dose vitamins as a teenager after she had multiple cardiac arrests. Next to her is a sibling pair. The older sibling is now in her 20s, but she got started in her mid-teens. She no longer has at a crisis, but she walks better than my patient does, you can see, and she also talks better.
I'm Taylor. Can you spell that for us? M-A-K-A-Y-L-A.
So Michaela can't say her phone number. She can't tell you her address, but her speech, as you can see, is much clearer and she can talk better. This is her younger brother. He was diagnosed at 9 months and got started on a high dose B complex at 9 months. You can see he walks completely normally. He is he can play sports. When I met him, I had no idea he had TANGO2. And then you can see he goes to school. He's in 7th grade. And you can
Seth,
see.
Can you skip count 5s for me?
5, 10, 15, 20, 25, 30, 35, 40.
So he can do, he does have some difficulty with higher executive function algebra, but he's much better than his sister. So again, as an arrhythmia, as an EP, I would never think about vitamins as a treatment or management for arrhythmias. But hey, modern era, maybe we need to think about not only alternative treatments, but what's the mechanism here? What do we not know about what's causing arrhythmias in our patient population? All right, so moving on, that was TANGO2. Mystery arrhythmia case number 3. This is a common one. You all should know it, so pay attention. We've got several patients here, but this is a representative case. 7-year-old girl comes with a history of early developmental, cognitive, and speech delays. Her metabolic workup, she was assessed by our metabolic team, completely negative. Couldn't find an answer. Proband trio whole exome sequencing was sent due to her developmental delays that were persistent and was negative. She was diagnosed with atrial tachycardia at the age of 3 years due to an irregular heartbeat at a well child exam, seen by EP at an outside center and treated with propranolol with some moderate improvement, but not complete suppression of her arrhythmia burden. This is her baseline EKG. You can see some ectopy there. But even this is her telemetry when she's just sitting in bed. You can see there's some ventricular and atrial arrhythmias at rest. We also ran her on a treadmill And you can see she's got both ventricular, polyventricular, and atrial tach. So stimulated both at rest and during treadmill testing. This is not this patient, this is a different patient, but also has arrhythmias without adrenergic stimulation. This was after going to the bathroom. Echocardiograms, this is the echo, often demonstrate dilation, trabeculation, systolic dysfunction can be there, although not in all patients. All right, any guesses? Common, all of you have seen this. All right. I asked for a reanalysis of her whole exome sequencing because I was convinced that this patient had a disease or a syndrome in a specific gene. And so this is the actual report, August of 2022. So they went back in. The next day, they said we did find a rare variant, and it was in RYR2. So I asked them to only look at RYR2. Okay, so this is CPVT. If you haven't seen this, well, you definitely want to recognize this. Also, if you have patients who are undergoing whole exome sequencing for developmental disorders, they can have incidental findings in RYR2. We've had at least 2 now that have come through our clinic because of this. And if they just get an EKG and an echo, you might not know that this is CPVT. So you got to be really aware of this. And this, we put together this report. This was just my cover from HRS. Many people contributed to phenotyping these patients, and this should be coming out hopefully soon. We're not the first. The adults also described intellectual and neurodevelopmental delays in the adult population. They noted, and this is Dr. Ackerman, Arthur Valdes on this paper, many more malignant cardiac phenotype in these adults with these delays, and also marked supraventricular and ventricular arrhythmias. They noted that the variants were in certain locations that was consistent with our data. So what's the difference between the two? We have 8 patients right now that are in our center. I want you to focus on the red. It's the arrhythmias at rest, a predominance of atrial arrhythmias, but arrhythmias both at rest and during exercise stress tests that differentiates them from CRDS. They also have more cardiomyopathy, atrial and biventricular dilation, trabeculations, and systolic dysfunction. And even though our statistical analysis did not show that there was a higher risk of malignant cardiac events, I actually do think there is. These are 3 of our patients. One at 19 has been treated fully, had a cardiac arrest just sitting in a parking lot. She continues to have recurrent ICD discharges. Another one is deceased now in her 20s. It wasn't recognized prior to her death. She had recurrent VT, and we suspect maybe there was a lead failure. And the last one I really want you to pay attention to, he had a resuscitated arrest while in the bathroom. That's the one I showed you. He had severe biventricular systolic failure and underwent a transplant at age 17. Explanted heart, actually on pathology, was consistent with arrhythmogenic cardiomyopathy. So what about, in summary, these neurocardiac arrhythmias? I think it's important that we're aware of this and recognize these atypical neurocardiac arrhythmia phenotypes, particularly if you've got a patient who has baseline cognitive and developmental delays. I gave you 3 examples. There are more. Phenotypes can include AV block, atrial and ventricular arrhythmias, and cardiomyopathy, and I think they worsen more with metabolic and adrenergic stress. I think Greg Webster and I have been looking at these potentially metabolically driven arrhythmia disorders. Arrhythmias tend to be more resistant to antiarrhythmic treatment, and patients may be at higher risk for life-threatening events. I think particularly for the neurocardiac CPVT, which you will see, they may warrant a different approach, maybe to clinical care and with more frequent echocardiograms than we're used to doing, and maybe more aggressive arrhythmia suppression. All right, so with that, I leave it. Thank you very much.
Thanks, Christina. We can invite all our first 4 speakers. We have about 10 minutes for questions. Dr. Kim, Dr. Kannankeril, Dr. Ackerman. If you guys want to have a seat, we can have questions. Since we're recording, if you, we'll have Dr. Connell bring a microphone to you if you have a question, and Dr. Bruno.
You guys, if you have questions, if you're young, if you're training, don't be shy. If you have questions, someone probably else does. Come up, say your name so we can hear where you're from, and come ask away. You've got an opportunity with really experts.
I'll get us started while people are getting ready. So Christina, one of the questions for you, we get a lot of patients in our clinic that we're seeing in neurology and get whole exome sequencing and come in with some type of VUS. Any clues as to when you should start thinking more that they might be one of those neurocardiogenic arrhythmia syndromes? Anything that will clue you in that, and this one I have to pay more attention versus all the other ones are like, why do we even get a whole exome sequencing on this patient?
Yeah, I think it really comes down to clinical phenotype and recognizing what the clinical symptoms or clinical findings are for that particular. So you don't want to go on there's going to be a multitude of different incidental findings. I think for this in particular to pay attention to is the ranitidine receptor. I think you will get incidental findings in this. Just a few months ago, just as an example, we had a patient who had an incidental finding of a VUS in ranitidine receptor. He got referred, seen by cardiology, did an EKG echo. It was normal. He's 3 years old. But as soon as, if you know that you see this, you've got a VUS in the ranitidine receptor, now you really have to look into this. So what we did is we put a Holter on him, and then I brought him back, and lo and behold, on that Holter, he had runs and runs and runs of atrial tachycardia. So I think it starts with knowing what the clinical phenotypes are. I don't think you should chase after every single one, but particular for ranitidine receptor, it's important that we definitely work up that one differently because the 3-year-olds aren't going to run on a treadmill.
The only cautionary note on that, though, is we have to, especially if it's an incidentaloma, and I think you're going to probably be talking about that, Andrew, also in yours, is 3% of the planet has a super rare variant in the ranitidine receptor. So just because it comes as a VUS, you want to make sure you're prepping the family that this does not mean we've stumbled into CPVT or the rarer calcium release channel deficiency syndrome. It needs to be worked up. But where this has caused a lot of problems is you are suddenly dead. You get a molecular autopsy. It comes back with an RYR2 variant, and immediately people conclude that that was a CPVT death. And that may or may not have been a CPVT death. That may have been an unexplained death with just a rare RYR2 variant that doesn't matter. So RYR2 VUS, especially in the neuro whole odyssey cases, we've seen a lot of people commit families to a premature diagnosis of RYR2 heart disease. So you have to be really careful with RYR2 rare variant assessment.
Yeah, that is an excellent point, Mike. I absolutely agree because you're going to get yourself down a rabbit hole if you go down with ranitidine receptor. And I think what I didn't mention with this patient is that it was de novo. So you got to really take that variant because if this is real and it's inherited. So in other words, it's maternal. Find out, is that from the mom? Is that from the dad? Because if the mom has it and it's completely normal, then there's your answer, right? So making sure that you not only take the VUS, but you also identify what are the chances that this is actually a real putative variant, and that's very critical. Absolutely, very good point. Thanks for raising that.
So I think we have a question here.
So great talk, Christina. So I'm very interested in this a few cases. So my lab is also working on the Tango 2 narcolepsy, and for those neurologic related disorder, cardiac arrhythmias, do you think the focus should be in the brain or should be focused in the heart? Just want to have your thoughts.
Personally, I think it's both, right? So for the Tango 2 and for the RYR2, and I'm not just talking about, I know Dominic Abrams and Vasilios Bezaritas and others, and our lab has also shown it, but that the ranitidine receptor is expressed in the brain. So making iPSC neurons, I think is important. For Tango 2, we are actually, I don't know if you knew, I work with Dr. Nali, but we are actually making the IPS neurons now. So I think that we need to look at it in both models.
Dr. Cantor?
Ron Cantor from Nicholas in Miami. Phenomenal session, guys. Really amazing. Mike, questions for you. Is there a threshold above which the triangulation method that you spoke of in terms of genetic diagnosis is required in terms of the number of affected family members with a long QT phenotype, in terms of number of affected family members and numbers of generations?
Yeah, that's a great question. It's a moving target. So it used to be in the old days, you needed 10. So you needed 10 phenotype positive affected individuals and an autosomal dominant pedigree to generate a LOD score of 3 to get you to potential truth. Now you don't need anywhere near that. So I think that was old. I think the triangulation method is a great way when there's 0 family history and you are looking for de novo. So having mom, dad, patient trio, you can get to the truth really fast if you have a de novo variant that looks intriguing. Not every de novo variant is a pathogenic disease, you're done, but you're pretty close if you're de novo real estate in a territory that makes intuitive sense. For autosomal dominant pedigree, where there is familial disease, the more the better. But if you have 3 phenotype positives and they're concordant in a ultra rare variant and it's intriguing into where that heritable co-segregating variant resides, you can then quickly move it to the dish to see if it is what it is, which is if that single variant, when you remove and restore order, and you can do it in 2 directions, remove it in your patient, does it go normal? Introduce it into a normal person, does it go abnormal? You're done. I mean, from a practical standpoint, you've shown that that single variant is the self-sufficient, sufficient and necessary reason for that patient's prolonged QT or APD phenotype, and so forth.
Okay, we have one right here.
Yeah, Mario Delmar from NYU. So I find it fascinating that specific variants of RYR2 would give a neurological disorder, even though there are many other variants on RYR2 that only give a cardiac disorder. So I would like to reverse the possibility, and that is that it is the other isotypes of RYR that are more populated in the brain, that, or IP3 receptors that are also very mildly expressed, particularly in the atrium, that could be either concurrently affecting the phenotype or that actually may be the responsible ones of the phenotype rather than a potentially VUS of RYR2.
I'll start and then I'll have Prince add to that. I think there's 2 potential explanations. First, I would say the majority of the CPVT patients are neurologically normal, but I think we've totally underestimated the minority who have a measurable cognitive defect. And, you know, in Arthur Wilden, our paper, which was adult and children, that 7 to 10% signal, that was from us, community of cardiologists assessing neurologic phenotype. We are not systematically having patients with RYR2 mediated disease undergo a careful, methodical neurologic, neurocognitive developmental assessment. And I have no doubt that our 7 to 10% number is an underestimate. But we don't want the pendulum to swing to have every CPVT patient thinking, when's my autism going to start? Right. So most are cognitively normal, but I think we've underestimated the neurologic impact of RYR2 mediated disease.
Yeah, no, I agree. There's patients that, you know, function totally normally that you wouldn't necessarily call abnormal, but if you send them to a neurologist, they do have some mild deficits. And I would just push back a little bit. So we think of RYR3 as the brain isotope, but that's because if you look for RYR3, you see it more in the brain than anywhere else. But RYR2 is actually more highly expressed in the brain than RYR3 is. So it's not too surprising that RYR2 mutations can cause brain abnormalities. I don't know why your actual question is why there's so many people with RYR2 abnormalities that appear to have totally normal brains, whereas you have some that get very severely affected. That's a question I don't think we know the answer to yet.
It feels more like the gain of function, doesn't it? I mean, I know calcium release channel is early, but at least the early word is the loss of function side doesn't seem to have as good of a, or as likely of a neurologic signal. Would you?
I think it's hard because you only diagnose those patients after they've had an arrest, right? So they don't have a phenotype otherwise. So many of them were skewed a little bit because we don't know if their neurodevelopmental phenotype is post-arrest or not.
It may also be a case of complex genetics.
I think we have time for one more question, Dr. Orcutt.
Jeff Orcutt from University of Arkansas. My question is for Dr. Miyake. These patients with this RYR2 neurocardiac phenotype with significant cardiomyopathy, and you presented one patient that had a heart transplant and the heart was explanted. To me, it sounds like a cardiomyopathy patient with intractable ventricular arrhythmias. These are patients who are very frequently referred early for heart transplant. Are these patients that you found yourself thinking more and more about transplant earlier on in their course, or have you found that their neurocardiac phenotype, their other medical comorbidities have limited their transplant candidacy?
No, I mean, I definitely think that he's on the extreme. I don't think that he's probably representative of the vast majority of even this small cohort, but I do think it's important that we recognize that there can be that severe of a phenotype, that there probably is a crossover in terms of arrhythmogenic cardiomyopathy, calcium, and CPVT and the arrhythmias. So I think our thought was really to try to control the arrhythmias all through. It's just when he had the cardiac arrest and with persistent failure, that's where he ended up there, but definitely not my first choice or things that I'm thinking as an initial approach. I just want to mention one other thing, guys. I'm sorry. The reason I talked about that whole proband trail whole exome sequencing, many of you should have asked, well, why didn't that pick it up? Because it was a de novo variant, right? But if you have a proband trail whole exome, the way that at least at Baylor BGL, they're going to look for the variants in that phenotype for that patient, which was developmental delay, and only then sequence the parents if they find a variant in that phenotype. So the arrhythmia phenotype wasn't there at that time, and they didn't sequence. Now, if they had to sequence the parents, then they would have reported the de novo variant, but they didn't do that. So don't look at your whole exome sequencing report and say, oh, it's not there. Think about how did they do that sequencing? Could they have missed the ranitidine receptor if you do have a patient like this?
I want to add one thing, just Christina reminded me. So the Tango 2 patients, they can actually be missed on whole exome sequencing. The patient that we collaborated with, whole exomes were negative. We had to specifically go back and say, we think this is Tango 2 because there are a lot of deletions that can be easily missed on whole exomes.
Well, thank you very much.
It goes down to the phenotype.
Well, thanks very much for those great questions from the audience. We'll move on to our first keynote speaker of the day, Dr. Mario Delmar from New York University. He's going to be coming to talk to us about beyond the one gene disease, complex genetics, and sudden arrest death syndromes. Welcome, Dr. Delmar. Trying to find your talk. Sorry, I'm trying to. Seeing his. Oh, there it is. Sorry. Your first name.
Thank you very much. I am very honored to be here. I want to start by thanking the organizers of the meeting and also the leadership of SADS for having me. It is truly an honor to be here and to be speaking to this audience. I also want to thank them for their resilience and the fact that they had 3 years to reconsider inviting me and they still invited me. So thank you so much. That was really nice of you. My laboratory is concerned with cases like this. This is the heart of a 16-year-old boy. He was playing soccer with his friends. So when I give this talk in Europe, I say that he was playing football with his friends. And all of a sudden, he collapses. Efforts to resuscitate him are unsuccessful. And short time after he has been just a normal teenager running around, he is declared dead. And what you see here is the MRI postmortem. Are you seeing my arrow? Is the MRI postmortem, and you can identify that the septum, the left ventricular free wall are rather normal, but there is this complete loss of muscle integrity in the free wall of the right ventricle. Histological sections in trichrome show that there is a little bit of muscle left in the free wall of the RV, but is mostly collagen, which is in blue, and fatty deposition, which is marking in white. The left, on the other hand, still has quite a bit of muscle, although there are some collagen infiltrates already. So this kid is diagnosed with arrhythmogenic right ventricular cardiomyopathy. This is an inheritable heart muscle disease that may result in arrhythmia, heart failure, and sudden cardiac death. Now, the important point here is that this is not arrhythmias and cardiomyopathy walking hand in hand. There are two different components of the disease, and we have been studying mostly the arrhythmia component, but also the cardiomyopathy as being the result of two different phenomena that are occurring, and very often it is the malignant arrhythmias that occur first, even in the absence of a major structural disease. And together with Dr. Ackerman, actually, we some time ago were he was able to show, and then he was kind enough to include us, that that there are indeed cases that are plakophilin 2 mutations that are, on the other hand, on a structurally normal heart in deceased patients. So ARVC is linked to mutations in desmosomal proteins. For those of you that may not remember your cell biology, the desmosome is basically the Velcro between cardiac cells and between other cells. Best example of what the desmosome does, which is to form intercellular adhesions, is the skin. If I take my skin and I pinch it and I pull it, the cells don't rip away from each other. The cells stay next to each other, attached to each other, because they are bound to each other by desmosomes. And inside the desmosome is connected to the intermediate filament, keratin in the case of the skin, desmin in the case of the heart. So when I pull, the cells don't rip apart. When I let go, the cells come back to their normal position because the intermediate filaments are very elastic and they can be stretched and then come back to their original position. The heart is a very flexible organ. It's a very strong muscle, but it's a very flexible organ that has to expand and contract over and over again. So desmosomes have a very important function in the mechanical function of the heart. But the question that really bothered us since the beginning is why mutations in genes that are supposed to be making Velcro between cells can be so arrhythmogenic. And we have developed a whole project on that story. But about estimated 50% of the cases of familial ARVC where there is a link to a gene, this gene is a plakophilin 2. So most of the work that we have done is with this particular gene, plakophilin 2. The penetrance is low, and this is a case of complex genetics. I think that it would apply to the conversation that we were having earlier. And but the other important thing is that we have come to the conclusion that plakophilin 2 is a pleiotropic gene. That means it has more than one function. And this makes perfect sense, that genes don't produce proteins that can only do one thing. Connexin 43, if I ask you what does connexin 43 do, you're going to tell me they make gap junctions. And that is true. Connexin 43 is essential for the formation of gap junctions in the heart, but that's not the only thing it does. It does other things. It does other things that affect sodium current. It does other things that affect cell adhesion. It does a bunch of other things at the intercalated disc and in the transcriptional regulation. And so does plakophilin 2. It's a pleiotropic gene. Now, with that context, we got very interested in this observation. So there are a number of cases of something that looks like ARVC that have been reported in athletes. And there has been then this possibility of plakophilin 2, of the athlete's heart being something that is kind of similar to the heart of a patient with ARVC of known genetic mutation. This was first pointed out by André Lagrèche in a paper that is not the journal that you read every night, but it is there and it was published. And then also reviewed in JCE by the Brugada family. And then we added a little bit a few years ago. That is just the principle is that there is something about exercise that at the end leads you into something that looks like ARVC. So what could that be? So this is, on the other hand, what happens with exercise, or as it was described now 9 years ago by Cindy James in Hugh Calkins' group, what happens with exercise in patients that do have the diagnosis of ARVC. So this is a survival from the first sustained VTVF as a function of time. And you can see that the survival drops in the population that was classified as athletes when compared to the population that was classified as non-athletes. In terms of the development of heart failure, athletes do progress towards heart failure in this series, whereas the non-athletes do not. So there is a negative effect of exercise on the particular specific population of ARVC patients. So we asked ourselves whether exercise and plakophilin-2 deficiency have a common molecular pathway to the disease, whether there is something that happens with exercise that is also present when you don't have plakophilin-2 that actually leads into a common pathway. And we published then this paper just earlier this year. This study was led by Marina Cerrone, Grecia Marron Linares, and Chantal Van Oppelgren. They all share first authorship, and it came from my lab, but it was really an international collaboration with André Lagerge, with Hugh Calkins and Cindy James, with Anneline Terriel in Utah, and myself. So what did we do? Well, we do what we know what to do, and that is to take mice and to make them do things. And in this case, what we did is we made them run. So you put mice on a treadmill, and you have two kinds of mice: the ones that like to run and the ones that don't like to run. So these are actually difficult experiments because you can spend, a lot of time trying to train a mouse to run, and it would rather commit suicide than run. Whereas there are others that actually like it. So anyway, we put the running protocol where we run mice for an hour. We let them run for 6 days of the week, and we do this for 6 weeks. And we then first characterize the cardiac phenotype of control normal mice. These are just your regular mice. And happens what is supposed to happen. There is a cardiac remodeling that gives you an increased LVEF, and also an increase in anterior wall and posterior wall thickness, particularly during systole, as you would expect in an animal or in a human that has been trained. So we take these hearts and we did whole transcriptome to see what are the genes that are modified by exercise in mice. What we were surprised is to see, this is the volcano plot. I don't think I need to explain much. Do you see? Yeah, you do. What a volcano plot is, but this is the magnitude of the change, and this is the significance of the change in a particular transcript abundance. And what you can see is that there is a bunch of downregulated transcripts by exercise alone that are for coding for proteins that are in the intercalated disc. And that includes plakophilin-2, that includes desmoglein, and then some mystery intercalated disc residents, like NOS1AP, which those of you who have followed the GWAS stories in long QT, is a huge peak in long QT, even though we still don't know what it does, but it's a resident of the intercalated disc. But particularly the desmosomal genes were significantly downregulated. Okay, so how does this compare to the transcriptome of a mouse in which we purposely affect the integrity of the desmosome? So, first of all, let me say that when you do pathways on these mice, what you obtain is that ARVC is actually the most abundant, the most significant pathway in the mice that only did exercise. Otherwise, they are normal. And I mentioned that there are some pathways that are increased as expected, particularly those in metabolism. They are overrepresented. Okay, so what we did is then to take a mouse and knock out the plakophilin-2 gene. And this is something that we have been doing for a while. This mouse is a cardiac-specific, tamoxifen-activated model of plakophilin-2. So without going into the genetics of it, you take a mouse, you flux the gene, and then you're going to have a CRE that is going to cut that gene, but only when you inject the mouse with tamoxifen. So we let them be 3-4 months of age. Then we inject the tamoxifen. At that point, Only in cardiac myocytes, the plakophilin-2 gene is going to be knocked out. And now we can follow the time course of the progression of the phenotype from an animal that has normal PKP2 to an animal that has no PKP2. What happens is if you do a Kaplan-Meier curve, these are days post-tamoxifen, so day 0 is a mouse 3-4 months of age, you see that the mice up until day 21 are pretty okay. But then you start to see death, and by day 50, all of them have died, and they die in end-stage heart failure. So we took 2 points, and most of the study that we will show you was done at this time point, 21 days. At 14 days, nothing happens. These mice have a perfectly normal structural heart as before we injected them with tamoxifen. A week later, though, you can see that the free wall of the right ventricle has thinned, that it has quite a bit of fibrosis. Here we are exaggerating the contrast of the blue to show you collagen in blue, and it is mostly in the free wall of the right ventricle. Just for comparative purposes, I put this next to the postmortem MRI that I showed you earlier on, and you can see that there is indeed quite a compromise of the free wall of the right ventricle in the mouse as in the human. So we have cardiomyopathy of right ventricular predominance in the mouse. Are they arrhythmogenic? Yes, they are. So we did a transcriptome of these mice. And this is the heat map just to show you that we have very strong consistency between one mouse and the other in terms of both those downregulated genes and those upregulated genes, giving us a very strong transcriptome signal. When we do the pathway analysis on these mice, we do see that there is increase in the an overrepresentation of ARVC in these mice as one we would expect. Now, we say, okay, so how does the transcriptome of a mouse that exercises compares to the transcriptome of a mouse that just does not have plakophilin-2? So what we did here is to take every single gene, which is represented by 1 point. So each point in this plot is one gene. And we say, how much did that gene changed by the exercise alone? Versus how much did this gene changed in sedentary animals that lost their plakophilin-2? Well, this one gene increased a lot with exercise. So it was overrepresented by a lot by exercise. And also overrepresented by a lot in the PKP2 knockout. This over here does the opposite. Overall, though, what you see is that there is a very strong correlation between the changes in the transcriptome that result from exercise with the changes in the transcriptome that result from the deficiency of plakophilin-2. And indeed, when you combine both things and you put these mice to exercise, the knockout mice, you observe that the purple are the changes in the LVEF that happens with a sedentary mice. The LVEF decreases after 3 weeks. But if you train these animals, these are weeks now of training, of running, then the drop in the LVEF is more. So if you combine both the exercise and the deficiency in plakophilin-2, you have an even more drastic effect. So what we consider here is this concept that there is something that we called, for lack of a better name, perhaps the desmosomal reserve. And that is, if you take this diagram, imagine that we have this much desmosomal proteins, transcriptomes. And imagine that here is the threshold for disease. So just in the same way that we have 2 kidneys, even though we don't need them in normal health, or 2 lungs, or we may not need all of the desmosomal transcripts that we express. And so we have a reserve for that. And if we exercise, we may lose a little bit of the transcriptome of the intercalated disc, but it is good enough to keep us alive and healthy. Now, if your desmosomal abundance is such that you have less of a reserve, of a desmosomal reserve, then when you exercise, you may fall under the threshold for disease, and that drop in the crossing the threshold for disease would lead to the cellular and then clinical phenotype that reminds you of ARVC, even though this is not specifically a single gene mutation. This is a complex genetics, a constellation of genes that have been modified. And perhaps the best way to elaborate on this is on the concept of the good enough solution. And I love this experiment in part because it was so simple and yet so informative. These investigators some years ago took lobsters, and after eating the tails, they recorded from the ganglia where there are only 3 channels. So there is a channel that has is a potassium channel, another potassium, the 3 channels for repolarization. And these 3 channels, when you measure the current of each one of these 3 currents in a number of lobsters, ganglia, you see that the amplitude of the current is different in each one of them. If you measure the abundance of the transcript in each one of these is different. But when you record the action potentials are identical. And that makes sense. If you think about it right now, I don't think I am solving my repolarization of my heart in the exact same way in which each one of you is. I think that right now, if we were to do a transcriptome, we're not going to try it. If we were to do a transcriptome of each one of our hearts at one particular snapshot, we are all going to be solving our repolarization in a different way. But the majority of us are within the same range of QT interval. This actually was tried in a computer simulation some years ago by Jim Weiss. So what he did is to say, okay, I am going to take the typical action potential of the heart, but I am going to look at how many good enough solutions do I find. And he takes here 2 of them. He found many, as you would expect, but here are 2 of them. One with an action potential that is resolved with an IKR component that is relatively high. Another one of the exact same morphology with the exact same calcium transient, but with an IKR component that is relatively unimportant for that particular solution. So now what happens if I take a blocker of IKR, or if I have a mutation in IKR? Well, what happens is that this one that relies a lot on its IKR is going to develop an arrhythmia. This one that doesn't, when it takes the IKR blocker, does not develop an arrhythmia because it doesn't rely on it anyway. So we are constantly modifying our transcriptomes. And we are at one particular point or another, or in general through our lives, solving our action potential, not with one particular gene, but with a constellation of genes that eventually give us an action potential duration, a QT interval, that for the vast majority of people remains within a certain standards. This is what I have tried to convey here, that we, in the case of exercise, we all probably are transforming our transcriptome in different ways as we exercise. But there is perhaps this consistent effect, which is that the desmosomal reserve is different for each one of us. And when you cross that threshold, then you fall into the threshold of a clinically significant event. Now, I do want to finish with this quote. I love this quote because it's so true. All models are wrong. Some of them are useful. And that applies for animal experimentation, that applies for iPS cells, that applies also for statistical models to study significance in clinical research. All the models are wrong, but in some of them, we learn something. So what I have shown you are data obtained under very unreal conditions. You knock out the plakophilin 2 gene completely. Only in cardiac cells, and only once the animal is an adult. So is this a recapitulation of ARVC? No. But with all due respect to my friends and colleagues that I have recapitulated ARVC in their papers or talks, nobody has recapitulated ARVC. And the reason is we do not reproduce the conditions of the human heart in the mouse. And we do not reproduce the conditions of a living human heart in a dish. We do select a specific variable, and we study that variable as it is manifested by its absence in the case of a knockout model, or as it is manifested in the cardiac myocytes, an incredibly powerful tool when you take those cells and you derive them towards the cardiac phenotype. But the model, all of those models have been very useful. There is at present quite a bit of excitement on the possibility that ARVC could be a good target for ARVC for gene therapy. There are a number of organizations that remain under confidentiality, but one of them has actually made their results public, which was Tenaya, and they have shown using this model, using the PKP2 knockout model that we have generated, that indeed gene replacement works. There are others that are doing similar work. And also, us in the laboratory are trying to see whether we need to silence the original plakophilin 2 in order to replace the gene, and whether we need the entire plakophilin 2 gene to replace the function. So these models are giving us a lead toward which could potentially and hopefully sometime later next year be clinically applicable experimentation in trying to find finally a solution to patients with ARVC. And with that, I finish my talk, and I thank you very much for the invitation and for your attention.
We'll open up for some questions for Dr. Delmar. Let me pass out the microphones. Dr. Ackerman?
Mario, that was awesome. Thank you very much. And again, thanks for coming even with the 3-year delay. Thought or curious your comments. We had a fairly eye-opening experience recently with the work from HCM myectomy specimens, where we did their transcriptome, and had we published just on the transcriptome without the proteome, we would have made sort of sometimes 180-degree opposite interpretations. And that might be unique because you certainly have concordance with the PKP2 knockout and exercise. But I wonder, have you had a chance to look at the proteome of these tissues or the phosphoproteome and see in which direction is the transcriptome trying to compensate and counter what's going on in the proteome versus where is the transcriptome actually the problem and it's driving the proteome?
That's an excellent point. And indeed, we have shown in other models that there is a poor concurrence between transcriptome and proteome. So what may be happening is that you are losing transcript abundance, but that may be because you are producing more protein because you have made the protein synthesis pathway more efficient. So what I am showing is only at the transcript level. And we just recently published a paper where we were able to obtain samples from endomyocardial biopsies from 5 patients with ARVC and from 5 patients that were their healthy relatives. They are their healthy relatives. So we were able to do differential transcriptome and differential proteome in there. And what we show is that there are a lot of very interesting observations in there. But one thing that we did is to try to see if there is a good correlation. And there is probably a 50 to 60% correlation in change in transcript versus change in protein. And then there are quite a bit of it that does not.
If we have a question over on this side.
Oh, it's a really simple one. Mario, we used to use water bath for the exercise instead of treadmill, and they all swim. So I was wondering why you switched. You can tell me later if you want.
No. I tell you now. We had when we started doing these experiments, we had a colleague that was visiting us from Spain that has done a lot of exercise research, and his model was treadmill. And so we had someone that had done it before, and we just decided to go that way. I know there are colleagues that prefer to do just free running, because obviously the mice prefer to run at night, and the postdocs prefer to work during the day. So so we had to adapt to that. But that is why it was very important for us to see that indeed there was the expected changes, which, by the way, I did not have time to mention this, but one thing that we noticed in the knockout mice is that they do not develop compensatory remodeling with exercise in the way the normal mice do, which may be perhaps one of the reasons why the effect of exercise may differ in patients with HCM versus patients with ARVC, just as a hypothesis.
We have another question. Okay.
Hello there. I'm interested in dosage effect of exercise. I mean, that's what our patients constantly ask about. And how much have you been able to look at dosage of exercise? I mean, you gave us the paradigm that you did there. Do you have ideas about how that reservoir might change based on intensity, duration, frequency?
No, we did not. And the reason is because we needed to set one time point so that we could get enough number of animals to do that, and other things that we have done with the same model in other papers. So we have not explored the dose effect of exercise. We just did it to the point in which we could reliably see remodeling in the control mice, and then we fixed that point.
Christina?
Marath, always thank you for your always informative and excellent presentation. My question has to do with, can you explain to us that, like that question from Bob, in terms of the good enough theory and the differences that we see in terms of concealed versus, so we got a young patient who, doesn't do a lot of exercise or exercises, and a family member who has severe disease, why there's such differences? How do I put that together with this good enough theory that we have differences amongst ourselves, but this family's carrying the same variant? And does that affect, is exercise, do you think, playing a part in that?
I mean, from the studies of the Hopkins group, you would conclude that exercise is a major variable. Same with studies from the Utrecht group. Christina Haga in Norway has also gone through their data pool. As in Scandinavia, they have a very nice accumulated data, and it looks as though exercise is a determinant. So you have two family members with the same variant, one exercises and one doesn't, and it looks as though the one that exercises is the one that has a higher propensity to disease. Now, sorry, go ahead.
How about the twins, the identical twins?
Yeah, I cannot quote you that one. I cannot quote you the paper. I can tell you that I asked that to Cindy, and she says they have identical twins. One exercises, one does not, and the one that exercises develops the phenotype before the one that does not exercise.
All right. Well, thank you very much. That was a great session. We'll have a 15-minute break. If you guys can come back at 10:25 for our next session, that'll be great. Bathrooms are over this way.
All right, welcome back, everyone. We're moving on to our second session. This is What's Next in Channelopathies. The first speaker is Dr. Andrew Landstrom from Duke, and his talk is on Approach to Variant Analysis. What do I do with a VUS? Welcome, Andrew.
Thank you, Christina. Thank you to SADS and the TCH Planning Committee for a chance to be here. It is wonderful to be back in Houston. I may also add I'm at the tail end of a non-COVID viral pharyngitis, and so please be patient with my speech. So our objectives for this talk are to illustrate the increasing impact of variants of uncertain significance VUSs in both diagnostic and predictive genetic testing, to detail some methods by which that diagnostic uncertainty may be mitigated, to highlight advances that are on the horizon for additional VUS reinterpretation. So in my view, variants of uncertain significance, and perhaps you might share this view as well, are a big barrier for both diagnostic gene test interpretation, as well as the promise of true risk predictive testing, as they stand in the way both of making an accurate genetic diagnosis, as well as if we're ever to use broad spectrum genetic testing in the population to predict disease, it's going to be a key component of interpreting incidentally identified variants for those who might go on to develop genetic cardiovascular disease. And as many of you know, the gene test oftentimes is uncertain, and that gene tests are probabilistic, and simply that uncertainty reflects probability that's unclear and may not rise to the level of a genetic diagnosis. And so when you get an uncertain significance test, what you're really saying is that this VUS, this variant of uncertain significance, falls in between two thresholds: a greater than 90% certain chance of being pathogenic, a likely pathogenic designation, or a greater than 90% chance of being benign, a likely benign designation. And that's a pretty big probabilistic space. As many of you know, back in 2015, the American College of Medical Genetics put out guidance for how to interpret variants found on gene testing. This is not cardiac specific, and because of that, there are some limitations to the ACMG guidelines, but I think it forms a very important foundation from which VUSs can be interpreted. And the way they did this was they started to ask specific questions, both of the patient, of the family, of the variant itself. And all of those aspects were weighted in a probabilistic way. And that weight went into a determination of whether a variant was a VUS or something on the more diagnostic extremes. And so in my view, the best approach to still delineating VUSs even after ACMG guidance is to sort of take a few things into consideration. The first is the patient. We'll talk a little bit about that. The second is the family, the gene, and the variant. And I think by kind of ticking through all of these things, sometimes VUSs are not quite so uncertain. Let's tackle the patient. So this is work by Mike Ackerman and his group, who's really done the gamut of evidence in this space that the phenotype of the patient actually matters. And I think this is really intuitive because the gene testing company, when they call balls and strikes or VUSs, they don't have all the deep phenotyping that you do at your fingertips. Moreover, if one systematically includes key phenotypic features of the patient in front of you, VUS can often be upgraded. And so this is work published in 2022 and 2020, showing that if a phenotype-specific score, in this case, things like a short score, things are prototypical for long QT syndrome, are used to interpret a KCNQ1 VUS by ACMG guidance, that you can decrease the amount of VUSs that you call simply by incorporating this enhanced phenotypic model. This is not just the case for long QT genes, it's also the case for MYH7, a major cause of hypertrophic cardiomyopathy. Again, incorporating key features of hypertrophic cardiomyopathy in the evaluation of the patient can help you determine whether that VUS is actually likely pathogenic or pathogenic. The family also matters. And so we've talked a little bit in the prior session about family history and the importance of obtaining a careful family history and family phenotyping to better delineate whether a variant may or may not be diagnostic. The easiest way to do that in my mind is a 3-generation family pedigree. And ideally, you'd end up with something like this. The dark squares are individuals who are phenotype positive. The genes are the plus minus for a heterozygous variant. And here, you have an individual who's clearly affected by the phenotype in question, whether it be long QT syndrome or hypertrophic cardiomyopathy syndrome, yet is genotype negative for the gene in question. If this were a VUS, this would be co-segregation evidence that this VUS cannot be the cause of disease in the family because you have an affected individual who's genotype negative. Conversely, and 2 panels ago, we talked a bit about a de novo variant. If you're like me, you tend to see pediatric patients, and early onset disease, particularly when there's no family history of disease, can help you sometimes. If that child's the only one who's affected, there's no family history, phenotype negative for both parents, you can conduct VUS resolution testing to ask, are those parents genotype negative? If the answer is yes, then it heightens the chance that a de novo variant, one found only in this patient, might actually be pathogenic. The gene is also important. The number of genes that have been associated with disease is quite significant. And many of you may have been, like me, exacerbated at times by the size and the scope of gene panels. Enter ClinGen, which since the mid-2010s has been systematically reevaluating the evidence of particular genes with disease. Shown here are genes that are associated at one point in time with Brugada syndrome. However, ClinGen, which is comprised of an international group of experts that use objective measures in the literature to reevaluate a gene, has found that only one has definitive evidence of being disease associated, which is SCN5A with Brugada syndrome. All the other genes really lack that evidence. Not to say that down the road that evidence can change. In fact, ClinGen routinely reevaluates genes. But if you find a VUS in a gene that has a very weak disease relationship based on ClinGen, that might lead you to believe that perhaps that's not a diagnostic variant, or at least your bar should be a bit higher to calling it likely pathogenic. Moreover, the variants themselves can change. And so many of you are familiar with this. This is ClinVar. It's a curated database of the best evidence that a particular gene variant may or may not be associated with disease. And if so, what's the strength of that evidence for each disease process? This is a wonderful tool that's updated routinely. And in fact, if you're so inclined, you can actually follow specific variants. So if we end up with a VUS in my clinic, you can actually click follow. And if you have an NCBI account, you can get automatic emails if ClinVar ever redesignates that variant for you. And again, this is based on objective measurements and literature. One cautionary tale with ClinVar is that we have shown that ClinVar variants are changing, which is not surprising, but they're changing towards uncertainty overall. And so this is work done by Michael Rosamilia from our group, looking at ClinVar variants associated with cardiac channelopathies. This is an alluvial plot showing how those variant assertions move over time. The pink is likely pathogenic. The purple, conflicting or variants of uncertain significance, and the blue are benign, likely benign. What Michael showed is that about 1% per variant is the rate of change in ClinVar from either VUS to LPP, VUS to LBB, or some clinically meaningful change. Moreover, they are moving not towards diagnostic certainty, but they are converging towards VUSs more often than going out to LPP or LBB. And in fact, if you measure this, the confidence of these variants is falling over time. We think there'll be an inflection point. And of course, with additional research, we would expect the uncertainty to begin to decrease, but at least in ClinVar from 2011 through 2020 or so, uncertainty is increasing among those variants. So I think new approaches are needed. I think the idea of doing single cell patch clamp, for example, on every KCNQ1 variant is really something that's challenging. So what's the role of new methods like artificial intelligence? This is one particular stab at this that we've taken with two of our phenomenal collaborators, Ricardo Heneo and Rachel Drelos, over in computational sciences at Duke, and Jordan Ezekian, now a advanced EP and genetics fellow over at SickKids, led the study from our end. I can barely turn my computer on, and when it goes, when you get that spinning wheel of death, I can only turn it off. Ricardo and Rachel are experts in this. We partnered with them. This is a lot of their work. They developed Genesis, which stands for Gene-Specific Machine Learning Models of Variants of Uncertain Significance. When you take VUSs in KCNQ1, KCNH2, SCN5A, and RYR2, and entered three things into an unsupervised machine learning model, one of them being the evolutionary conservation of the locus of the variant, one being the minor allele frequency of disease in a given disease population over a ostensibly healthy population, which we'll talk a bit more about, or whether it lies in the functional domain, we can arrive at areas under the curve of 0.87, which is actually really good for variant pathogenicity calling. We can functionally validate it by patch clamp, which we did via blinded HEC293 patch clamp. This is HEC293 cells expressing both KCNQ1 as well as KCNE1, which allows us to patch the channel. And our predictions of whether a variant might have been benign or pathogenic matched up by our blinded patch clamp studies. As you can see on the panel all the way to your left, more traditional models such as PhD-SNP, SIFT, polyphen, their areas under the curve were about 0.6 to 0.7. So 0.8 to 0.9-ish is not diagnostic in our minds, but a significant improvement, and perhaps the sign that artificial intelligence may play a role in VUS resolution testing. Moreover, work done by Teddy and John, who are in the audience today, has shown that amino acid level signal to noise may be helpful. And this is based on the premise that in a large population, a variant that falls in a given location in the primary sequence of a protein may be more pathogenic if it's found more in diseased individuals than that same rare variant in healthy individuals. And this is a plot of what that signal to noise looks like. On the y-axis is this relative frequency of disease over health. On the x-axis is the amino acid position, and in green are long QT variants. In blue are variants attributed to long QT genes found by whole exome sequencing that were considered rare in VUSs. The green line up beautifully with known functional domains of the channel, while the exome identified incidental variants in blue really have a flat line. Work done by Patrick Connell, also in this room, and Amy Berkman in our group, has identified that you can use this method to actually predict the onset of pediatric penetrant disease. And so this is a signal to noise plot for TTN encoded Titin, which anyone has done any gene testing, you've been befuddled by Titin variants before, I promise. Our highest area of signal to noise shown here in green are in the A band. Most people would appreciate that the A band is where most pathogenic variants lie, but the A band is sort of thought of as a homogeneous block, and we found it's quite heterogeneous. And if you use this signal to noise prediction model, then incorporated into ACMG, we find this does enrich for individuals who develop pediatric onset cardiomyopathic disease. Moreover, we've shown, and this is work by Teddy Jones and Leonie Kurtzlichner from our lab, showing that this can also be applied to hypertrophic cardiomyopathy genes. Thus, signal to noise does have a diagnostic role if other individuals are able to validate this prospectively in the identification of variants predictively for hypertrophic cardiomyopathy. And we're putting this into a website, so I don't have to open up all these papers in clinic. This website is called Discovery, and when it's done, you'll be able to enter variants into it, enter your gene of choice, be careful with the transcript, enter your gene of choice, and you'll be able to get a signal to noise measure for your gene and whether it lies in one of these pathogenicity peaks. Hopefully we'll see this up in the next year or so. Another great resource in my closing slide is one called Franklin. If you haven't heard of this, this is a wonderful resource. Many GCs use it. You can enter a variant, a gene, and it'll actually give you, based on ACMG guidance, specific data points to help you reevaluate VUSs. And so my take-home points, I believe that VUSs pose a diagnostic challenge that will grow as genomic medicine matures. Management of VUSs relies on clarifying the probability of disease association, clinical phenotype being up to date on gene variant associations, and leveraging family history can help resolve this diagnostic uncertainty, and machine learning and high throughput variant functional analyses may hold promise in resolving VUSs. I've tried to do a good job of showing you the individuals who do the actual work. It's important for me to convey that I am just the representation of many talented folks I get to work with every day. I'll acknowledge our funders and take any questions during the Q&A. Thank you very much.
All right, our next speaker is Dr. Mike Ackerman again, and his talk is Precision Medicine for Channelopathies.
That was great, Andrew. So for precision medicine for channelopathies, we could take this in a lot of directions. And so when I saw the agenda and the different topics, I thought there was going to be too much overlap. So I found a space where there's zero overlap, and to share with you something that we've been working on at Mayo Clinic for the last 5 to 10 years. And I think it clearly fits under precision medicine, and it's artificial intelligence. You heard Andrew present some work with AI for genetic variant resolution, but I'm going to share with you the state of the AI ECG that we've been working on. And some people have started to say, let's not use artificial intelligence. I know Jamil Tajik has invoked we should be using augmented intelligence for the A part. I don't care. So whatever you use, float your boat. These are the conflicts. None of these are relevant. I guess the one that could pertain is the relationship of Mayo Clinic with its spin-off company called Anamana. But I don't think it affects this ability. And we're going to detail precision medicine as in AI. And then I'll show you that it's just not papers that we're publishing and clinical translation. It's actually clinical implementation. So we have the AI ECG in daily clinical practice at Mayo Clinic. This is a space, it's new for me. It's largely providing our patients and not our knowledge, or at least not my knowledge. So I'm AI deplete. but we have a lot of patients with a lot of careful, exquisite phenotyping. And it just kind of blows you away when you think of the number of papers in the machine learning space, and then just in cardiology for nearly approaching 1,000. What we're trying to do is saying Eindhoven is dead. In other words, the ECG has been around for 100 years unchanged. And maybe it's time to say, can we do and look at and measure the ECG differently in the AI way, where it stares at, from a practical standpoint, 6,000 points of information on each 12-lead ECG. We grinded our teeth, and the we really is Zakia Adia in our program is our lead AI scientist. He is unbelievable as an AI engineer. But we did this at Mayo Clinic with the ability to do the AI ECG HOCM detector, recognizing that there will never be a universal echo screen with the echo at the point of detection if we're going to ever start screening universally for HCM. So here's the scale of how we do this. And again, it's different, isn't it? I showed you in the first talk, one family, one pedigree, genome sequencing exploration, and we do it one by one. In the AI world, we're talking thousands and thousands of data points, 3,000 hypertroph, 63,000 controls. Standard in the AI world is the 70-10-20 model for training the brain, the AI brain, validating it, and then testing it. And here, what we can show you is that the AI ECG HOCM detector is really, really good. Vastly better than our international athlete screening criteria for what will flag as being a flaggable ECG to pursue HCM. And that ability is true whether or not your HCM is sarcomeric driven or gene test negative. So the ability to see electrically on a 12-lead ECG that we're having maladaptive hypertrophy, and that maladaptive hypertrophy is from HCM rather than aortic stenosis, is working really well. Our next step after this was achieved was to say, can we take the AI ECG HOCM detector that was trained and built on adults, not fine tune it, just apply it, turn it on in pediatric HOCM? And how would it work if it's the heart electrically of an 18-year-old, 15-year-old, 5-year-old with no additional fine tuning? And this is pretty satisfying that without adjusting it, without tuning it further, whether it's the heart of a 15-year-old with maladaptive hypertrophy or a 55-year-old, trained on the older adults, the AI ECG HOCM detector is working really well. Now, this doesn't mean it's ready for the AI ECG HCM screen universally of healthies, because maybe the performance characteristics won't hold up. We're working on that now. That study is in motion, and we'll see how it performs in a screening model. So that's our work in AI ECG. And I know this section was channelopathy, but the whole world of channelopathies and cardiomyopathies, they have so well intersected that I thought you might like it even in a channelopathy session. The rest of the time is the QT interval. And the problem with the QT interval is obvious. We've talked about it for a long time. Here is one where is extraordinary QT prolongation, extraordinarily missed at the Mayo Clinic ECG reading room. That was actually prior to Dr. Cannon's arrival, so it would not happen now. But this happened then, and but it's not a surprise. We all know this. Sammy Viskin taught us that most of us are not that good. And while this might be a true statement, it turns out that the computer-generated QTC on most of the machines isn't bad. 93% of the time it gets it right. It's probably better overall than the entire community of cardiologists who would be asked to overread the QTC. So remember these cut points when we look at disease and health for long QT syndrome. 480 women, 470 men, 460 before armpit hair. And that is the 99th percentile values in health. We're going to come back to that. 480, 470, and 460. We also know, of course, right, of this conundrum of concealed long QT syndrome. But in a way, if you're thinking about ever screening, we're not trying to find people with concealed long QT. We can back into them and find them by genetic surveillance after we find the past 98th percentile, 99th percentile individuals, because those are the ones a priori at more risk of a long QT triggered event in the first place. 5 areas that we've been trying to do. We won't be able to do all 5 or all 4. I think we'll do 1, 2, and 4 in our time. But this is what we've been trying to do is, can we get an AI deep neural network derived QTC to be better than what exists right now? Can we get that to happen from a mobile ECG? And then can we create a long QT syndrome mutation detector? That's part 4. I think we'll skip number 3. Published this last year with our new genetic cardiologist, John Giudice, who was my former trainee and joined Mayo's faculty a year ago. And what we asked is, can we train and tune the deep neural network to get the QTC better than expert calculated QTC? So here we go to the Mayo Clinic data vault, and we look at all those ECGs, do the neural network, and then see, can we move it from, can we train a mobile-based ECG, 2 leads, 6 leads, as if it's seeing all 12 leads and derive the QTC? And the answer is yes, we can. And so here's the thing that just blows my mind when I think of the whole machine learning world. 675,000 patients, 2.3 million ECGs that we're doing for our computational analysis. Standard 70, 10, 20 for the development set. And what I just trying to show is that in this big number, big data world, that with the power of computation, we can tune, and we have tuned, a deep neural network QTC calculation to be as good as the 12-lead ECG derived ECG. And we get it tuned to that level of comparability between whether you are a QTC reading aficionado, whether you are a lab who gets paid by drug companies to measure the QTCs, that we can have the neural network do the QTC very well. And in fact, we can get it done from the mobile ECG device in this case. And here we looked at a simultaneous study, near simultaneous, 12-lead ECG on a long QT patient, followed by the mobile derived within the next 2-3 minutes from this set of patients. And then again, can we derive a neural network-based QTC? And the answer is, with on the left, we have the neural network from the 12-lead. We have the mobile derived QTC from the mobile-based ECG, and whether you're asking the QTC readout to be from the lab or from my measurement or from the commercial lab's measurement, we get a very good correspondence, to the point that this was submitted earlier this year to the FDA, and the FDA provided clearance for the deep neural network QTC as an FDA cleared device. They did it by prescription, so that's one of the things that's slowing it down compared to the FDA clearance for a mobile ECG, for example, to be an AFib detector. That is non-prescription. That's why it's turned on. And so we're working to show the FDA that it can be done as a non-prescription turn on. They're worried about drugs and the whole, what will people use with the data? Now, long QT syndrome is a little different. So we have a really neat paper on, we're not gonna have time to show it, showing that when you get to my clinic and you've been called long QT, but your QT is normal and I dismiss you, or you get to my clinic and your QT is normal and you own a mutation, that the neural network in that setting can tell us who's who. But that's not gonna work practically for, you think about the filter and where we come to tune the network to that point of discussion. But what we have done is step back and like Peter Schwartz once said, I don't measure the QTC, I look at it. And so looking at the different looks, and so when the AI brain is staring at the 12-lead ECG, it's staring at 6,000 unique data points on every 12-lead ECG. That's what it's doing. That's not what we're doing. So we then asked the question most recently is, if we have somebody who comes to Mayo Clinic, gets an ECG, And that ECG is past the 99th percentile values, 480, 470, 460. Can it tell us who owns a mutation and who does not own a mutation? That's what we set out to do. So this is so far unpublished. It's shown just last week for the first time at American Heart Association, and Martijn Boss, who's been with me for over 15 years, led this study. So the same platform you've seen, and the tuning that we've done is, can we tell who owns a long QT causative mutation and whose QTC is beyond those thresholds for a non-genetic reason? Might be drugs, might be electrolytes, it might be whatever, but it's not because of the presence of a long QT causative mutation. So there's more fine tuning to go. You can see where we start with our cohort of 1,600 patients. That's closer to 2,000 now. You see the data vault of the 2.5 million patients with ECGs. You see the cutoffs. And then the first thing you note again is think about screening. Half of all of my patients that I see with long QT syndrome have a QTC underneath those 99th percentile values. Who are those? The relatives. Okay, so again, if our goal is screen those who might have first symptom, we don't need to find the relatives first. We need to find the future probands and intercept before they become a defined proband. And so we did that training, and you can see the punchline. And the punchline is not as good as our HCM detector yet, but pretty good AUC of 0.9. So you walk into Mayo Clinic and your QTC is at or above, say it's a 500. You turn on the AI ECG brain and it can tell you you're at 500 because you own a mutation versus you're at 500 for some other reason. Imagine what we do then if we link it and we just sort of link that signal to, oh, by the way, what drugs are you on when you arrive? What did your morning electrolytes show? That 0.9 is going to jump a lot higher than that. And I suspect that this, like the how good the AI ECG hokum detector worked in children without training it, this one ought to work even better if we move it to a healthy screening population. Because remember, if you come to an institution and somebody orders an ECG, that's probably not a wellness ECG. So your ECG, if you're naturally above 480, you're a natural 1%er, is going to be even cleaner. At least that's the working hypothesis. So we have now a long QT mutation detector. Last few slides, not just publications, we've translated and implemented. So at Mayo Clinic, this is the AI ECG. So on any patient seen, we can click on this button and then we can have pop up what have been the validated machine learning AI ECG derived signals to say, what's your probability that your electrical signals are telling us that you have a low EF? Your electrical signals are confirming manhood. That's an aside, it's a whole nother topic. Just by the way, mine is 1.0 on probability of male. But anyway, and what's your AI ECG predicted age? Might have something to do with electrical health and longevity and so forth. But that is in the real world happening every day now at Mayo Clinic, where not just the Eindhoven-based ECG, but now the augmented intelligence ECG that stares at those electrical signals and gives us readouts like this. The long QT mutation detector I added on there, that's not been moved to clinical practice yet. It's the next one that's just waiting additional validation. So the future of precision medicine and the present of precision medicine certainly includes artificial intelligence, augmented intelligence in it. The Mayo Clinic AI ECG HCM detector is now in clinical practice, and it's been validated throughout many centers, including South Korea and Switzerland and so forth. The AI QTC detector that's derived from a mobile ECG is now available commercially, clinically. It's FDA cleared. In fact, it's the first FDA cleared deep neural network algorithm in cardiology. And then the Mayo Clinic AI ECG long QT mutation detector can stare at an ECG from a patient who walks in, gets an ECG for whatever reason, somebody decided to get one. And if the QTC is above those thresholds, here I said 500, it can point us to who owns a long QT causative mutation and who does not. And so I'd love to see what other questions and comments this might generate during our panel discussion. So thanks a lot.
Okay, our next speaker is Dr. Bob Hamilton from Sick Kids, and he's talking about novel understanding of pathogenesis and autoantibodies in ARVC.
Thank you, everyone. It's a really great pleasure to be here. I hate traveling and I hate speaking, but I like speaking to a nice group like this. And the polar vortex is hitting Toronto tomorrow morning. Oops, somehow I ended up at the end of my slides. There we go. So this is a bit of a change in condensation from some similar work that I presented to the ACC on the role of autoantibodies, and I'm just bringing it even more up to date for the SADS Foundation today. So I'm going to talk about our autoantibody that we identified and discovered for arrhythmogenic right ventricular cardiomyopathy and how it may participate in its pathogenesis. I'm really going to focus on a few things about translating the test to a clinical test, which we're working on with some companies, although we're not at a regulatory status yet, like Mike is. One of the things I'm going to talk about is we have some nice real-world data from a collaborator, Katarzyna Bernacka, in Poland, who's provided us with 110 Polish cases. Now, these are a little different than the cases of ARVC that you might see here in terms of how they're diagnosed. So MRI information is missing in a third of these cases, and genetic information is missing in almost all of the cases. But nevertheless, it's quite a severe group of ARVC adults, and so I'll speak to how our test does in that group. And we just got the control samples from them, and so I'll be presenting most of the data without controls. I'll talk about some of the evidence for pathogenicity, and then I'll talk about some aspects of therapeutics. And this is my one disclosure in that I have a 7% interest in a company called Arvada Therapeutics. And then I'll talk a little bit about how it may be a predictive and companion biomarker, some of its limitations and alternatives. So this was our original study in 2018. And we we wondered, because we saw patients who had no family history and no identifiable gene, not very often, but we saw a few of them. We wondered if there might be some other cause and some other way to make a diagnosis in ARVC. And because it's a desmosomal disease and there's this paradigm of skin disease called pemphigus, which is caused by antibodies to desmoglein 1 and 3, we thought that we would go looking at cadherins. And so we looked at the 3 cadherins that are in the heart. So desmocollin 2, desmoglein 2, and N-cadherin. In the end, what we found is that there were antibodies to anti-desmoglein 2 in everyone. And that was whether you had a gene-identified arrhythmogenic cardiomyopathy, didn't matter which gene it was, didn't have to be desmoglein. Could be any gene, and we would find these antibodies. And we found them in 12 out of 12 of our definite ARVC in the discovery cohort. In those with probable ARVC, so 3 points out of 4 in their ARV task force score, we found them in 7 out of 8. But we did find a slight weak reaction in one of our 12 controls. And so we did a validation cohort with our Zurich colleagues, Dr. Saguner and Suna. And in 25 patients with definite ARVC, all had anti-desmoglein 2 antibodies. There was really, and you could also in both sets note that there was quite a difference in variation in intensity. And I know in our own group, those 2 that I showed here that were darkest were a mother and daughter who had a very severe disease. And then in this group, this validation controls, we did another 20 controls and they were negative. And so that's where we were at in 2018. We also looked at with the late Bruce Kattenack from the UK, we looked at boxer dogs, and Bruce was a mouse geneticist who, in his retirement, became a boxer dog breeder and was fascinated by the genetics of this disease. Really didn't believe in the striant mutation, nor do I, and was able to provide us with samples of a dozen affected dogs. And what was really key is that Bruce provided us with unaffected dogs that were pedigree negative going back 3 generations. And so these were really clearly free of disease. What's not shown here is the group in between that were well dogs but had ARVC in their pedigree. And in those dogs, half of them had the antibody, so suggesting it might be predictive. And so if we take the human data, you can see that we have the control group with all very low, under 0.2 optical density, one sort of borderline in that one 53-year-old female. And then in the possible ARVC, they would be a little bit higher in 7 out of 8. And then in our cohort, which is somewhat younger, mostly adults of our parents of our kids that were referred, they would have higher levels. And then in the Zurich cohort, which was an adult center, even higher levels. The original study showed some correlation with PVC burden. And what we think is going on here is that any mutation of the desmosome is releasing desmoglein, and that the molecule has what we call a cryptic epitope, so a portion of the protein that is very close to the membrane, just not exposed to the immune system, and that portion, once it's released from the desmosome, then circulates, triggers an autoimmune response because it's not recognized. And that does a couple of things. One is it acts as an amplifier for the biomarker. So you could just look for desmoglein, but instead of just looking for desmoglein, you look to antibodies for the desmoglein, because then you have an automatic amplifier in the system. But then what it may also do is participate in the disease, so that these antibodies come back and start attacking or latching on to desmoglein molecules. And it's sort of kind of like, I don't know if you ever used a Velcro zipper and it gets kind of old and full of lint, that maybe things aren't kind of holding together very well. It may also have some cell signaling effects, and we've seen that in pemphigus with antibodies to desmoglein 1 and 3. So that was 2018. So why is it taking us so long to get there? So the original test was looking at the whole molecule, but to make the whole molecule soluble, you had to add a tag to it. And so the tag that we added was an FC domain that's often used to make proteins soluble, particularly large membrane proteins or membrane-associated proteins. But then when you do that test, you have to do a lot of blocking steps. So you have to add things like dilute milk and that kind of thing to make the test work, so that the test will recognize antibodies to the actual extracellular portion of the protein and not to the tag. And that makes it very difficult to translate to a clinical test. You then have to create a very unusual platform or a very complex platform, which the commercial companies don't like. So what we did is we identified what the particular epitopes of the extracellular region would be that are triggering the response, and that the antibodies in the clinical patients are too. And they're really to these last 2 domains of the protein. This is called the extracellular 4 domain, and this is called the extracellular 5 or extracellular articulating domain. And so now our test includes EC5, EC4, and also EC3. But it doesn't include this one out here, which was the one responsible for the false positive in that first set. So using that new test, we've now taken a look at the Polish cohort, keeping in mind that we don't have our controls. So we're sort of demonstrating those from the Polish cohort, those very few that were followed in an ARVC clinic, but didn't quite meet criteria. They were, 2 or 3 points out of 4 instead of 4 out of 4. And you can see there's a big difference, but you're still now going to miss about 8% down here, probably even once we get our control data done. So, you go from 12 patients to 20 patients to 110 patients, and you start out at 100%, there's only one direction you can go. So we're now down to about 92% sensitivity, but that's still pretty good. So what else can it predict? In the younger cohort that we had at sick kids, we showed that it could somewhat predict PVC burden. In this cohort, we can show that it can predict disease with about 92% accuracy, and that's the ROC curve. But we can also show that it can predict runs of sustained ventricular tachycardia. And so this is the regression for antibody presence versus runs of sustained ventricular tachycardia, or antibody level. Now, are these things pathogenic? And this is some work that was done under funding by Arvada and under contract to one of the to Charles River. And this is again looking at MEA platform, looking at normal cardiomyocytes, but exposed to patient ARVC sera. And so you can see, actually, this first study was done with commercial anti-desmoglein 2, not patient sera. But you can see that after a couple of days of exposure to anti-desmoglein 2, that the microelectrode amplitude changes. And this didn't occur when you added a decoy peptide to complex the antibody. And it didn't occur in vehicle rabbit IgG or another adhesion molecule called VCAM. And it occurred pretty much at any concentration of the commercial anti-DSG2. This is work from our own institution, again under contract from Arvada. And this was done in Jason Main's lab. And you can see that after 2 days of exposure, and this is now to patient serum, that you can get an introduction of arrhythmias in the cell culture, and you can get a drop in sodium spike. This is a little bit more dilution dependent. So this happened in 1 in 10 and probably 1 in 15 dilution, but by the time you got to 1 in 25 dilution, you lost the effect. So not quite as strong as with the commercial anti-DSG2. And we also did this in constructs of normal iPSC cardiomyocytes. So these are mixed 2 to 1 with fibroblasts, and we can make these constructs, and then we can measure the power of contraction. You can see that the force generated falls with the day of exposure to the antibodies. Now, the other therapeutic we worked on through University Medicine, a design program, was to try to take T cells and target the B cells creating these antibodies. And the way we do that is we work with Dev Sidhu, who does synthetic antibodies. And so here's a synthetic antibody. One end of it grabs the T cell through a motif that is recognized, and the other end of it has the DSG2 antigen, so the target of the antibody, which then recognizes the antibodies on the surface of the DSG2 B cell, and then brings them in opposition or in apposition and activates the T cell and destroys the B cell. So that's the theory. And so the first thing we wanted to do is see if the antibody and the synthetic antibody on a plate could be used to activate the T cells, and they can. And then the second thing that we wanted to do, and this is not in a B cell, but in a cell that's been genetically modified to look like a B cell presenting antigen, but also to have a Lucifer assay within it that we can identify if it's being destroyed. And so we did get cell killing but it wasn't quite as much as we would like. So I think we need to find more ways to activate the T cell to try to get the T cell to recognize that B cell and more actively kill it. This work, unfortunately, is finished, and the postdoc has moved on, and so that's work that's laying fallow right now, but it would be an interesting direction. I can tell you these antibodies show up as early as age 2 faintly, and they're clearly present by age 7 in gene-positive patients. And I can tell you that they may function as a companion biomarker for therapy. We've studied them in the JUP mouse, which is a very weak phenotype, unfortunately, but they always correlated with status once the phenotype arose. And then other mouse models can be assessed. And so this may be a potential for companion to gene therapies. And we're in contact and in talks with some of those companies that have already been mentioned. So one of the things that it didn't do very well is when we looked and entered patients into the task force calculators for risk for ARVC, and you've heard today some of the deficiencies of those calculators, but our antibody levels didn't correlate very well. They were significant. They could give you a significant correlation with the risk score, but they weren't predictive enough. And so one of the things that we're looking at, because we have the serum, is we're looking at microRNAs. And so now we've got a microRNA that we can look at that identifies whether you're low risk, control, or moderate or high risk. And you can see the microRNA levels here. And for one of them, and one of them in combination with others, that you get a significant prediction of risk. And then finally, of course, all of our work has been interrupted by COVID, but COVID's also added some other problems to this work, and also some other opportunities, because when we look at long COVID, a portion of those patients have anti-desmoglein 2 antibodies as well. These patients, unfortunately, we don't have a cardiac phenotype for, and so we'd love to find some long COVID clinic where there's also good cardiac phenotyping and identify if these long COVID patients have a cardiac phenotype as well. But it'll be very important for us to select our controls carefully. And that's it. That's where we're at. Thank you.
All right, moving on to our next speaker, Dr. Dominic Abrams from Boston Children's Hospital, and his talk is Gene Therapy for Channelopathies. How close are we?
No. I should have put my name on it, shouldn't I? Put it at the end. It's not annoying. Oh, uploaded them yesterday. They said they were uploaded. You want to have Charlie speak and all that?
Yeah, let me go. Okay, we're gonna go ahead and we'll switch the order as we get the slides up. So if I can invite Dr. Charlie Berul. He did, all right. That's not my forte, but I can check your genes. All right, well, why don't we then take a second if there is a question. Does anyone have a question? We'll utilize this time until Charlie gets back for either Dr. Landstrom, Ackerman, or Hamilton. You got it? Okay, go ahead, keep going. Oh, we can keep moving here though, if anyone has any questions as we switch over.
Apologies.
Okay, go on. We're on.
Apologies for that slight hiccup. Well,
firstly, I'd like to thank Alice and the team at SADS and Jeff and all the team here in Houston for the very kind invitation. And it's, as everyone has already said, great to be back here in person, actually speaking to a live audience. So I've been asked to speak about gene therapies, which is an area of great interest to us. And it'll come as no surprise to many of you that I thought I'd focus my talk on CPVT, largely because it's an area where there's been a lot of interest in this approach, something that we've been working on as well, specifically. I thought I'd use this to give us sort of an overview of where we're at the moment, and then also to think about things going forward into sort of the bigger picture of gene therapy and sort of how we get there, because one of the questions we're always asked is, when do you think this will be available? So I'm not going to talk much about CPVT itself. You heard about it from Prince already this morning, but obviously it's a malignant disease of childhood with a high risk of sudden death, and therefore you could argue a significant unmet need. It's got a well-defined phenotype, which is reproducible, which is very important from a therapeutic perspective. And the management strategies at the moment are largely considered suboptimal, but I think that's an important point that I will come back to later in the talk. It's a monogenic disease, and I'm going to focus largely on RYR2, which is the autosomal dominant and most common form of the disease, and a little bit on CASQ2, which has historically been recessive, but now we know there is a dominant form of it as well. And CPVT is, of course, a relatively rare disorder, but it's sufficiently common to make gene therapy a credible strategy. So 4 sort of approaches have been looked at to date, and I'm going to touch on each of them briefly and the biology behind them. The first is replacement therapy. So if you've got loss of a functional allele and the protein associated with that, can you just give it back? The second is to suppress a dominant allele that's having a negative effect on the wild type. The third is gene editing. And then the fourth is inhibition of downstream pathways, and that's particularly what we've been focused on in Boston. So the first is calsequestrin 2, and this was 2 studies that came out in the early 2000s, which defined calsequestrin 2 as a cause of CPVT. The image on the left is from the well-known autosomal recessive families in northern Syria and Israel. And that was a missense homozygous mutation, and shown to correlate very strongly with a profound phenotype with early onset and pretty severe outcomes. And then a year later, Arthur Wilder and a group from Paris showed these 3 families with, again, a recessive inheritance of a truncating variant, again, causing the classic CPVT phenotype, as you can see there on those ECGs. And subsequently, what was shown in the biology was very interesting, because the first work was in 2007, came out of the Seidman lab, and they took 2 mouse models, one which was deletion of exon 9, and one of which was that Israeli mutation, the 307 homozygous variant. What they interestingly showed was they could recapitulate the phenotype of CPVT in the mice very accurately, but in both situations, there was a very significant loss of calsequestrin 2. So even though there was a missense variant, there was a significant decrease in the protein levels of CASQ2. And that was again shown by Silvia Priori's lab a year later. They used a different model, the R33Q, which is now a well-known CASQ2 model. Again, they could recapitulate the phenotype in mice. And again, they showed a very significant loss of CASQ2 of the protein, but interestingly not of the transcript, which suggests some post-transcriptional breakdown. And also there was an associated loss of triadin and junctin, which are part of the sarcoplasmic reticulum with CASQ2. And you can see they show these very nice ultrastructural changes at the junctional SR, which was associated with loss of calsequestrin. So not only was there just an unrhythmic phenotype, but there was also a structural phenotype when you looked deeply with EM. So of course, loss of calsequestrin makes it very attractive to give that back as a therapeutic strategy. And this is what the Priori lab went on to do. They used the same mice, the R33Q mice. They recapitulated the phenotype, and when they gave calsequestrin 2 back, and that was done with an AAV9 vector and a CMV promoter, they were able to either prevent the phenotype in very young mice or restore the phenotype back to normal, and so eliminate it in older mice aged 3 months. So they could not only could prevent the disease, they could treat it in older mice who had already shown evidence of the phenotype. And I think one of the most important things that came out of this initial work, and you've already heard about from Prince this morning, was this concept of the source sink effect. And what that meant from this study's perspective was that they didn't have to transduce every cell. In fact, the transduction rate was only about 40 to 45%, but that still had a very profound effect in eliminating the phenotype, which of course is very important from a dosage perspective when you're thinking of how much agent to give. The RYR2 is the main cause of CPVT. It's a dominant effect. So the protein that is produced has a deleterious effect on the wild type. And of course, this has been very well known. This is one of the original descriptions back in 2002, showing that RYR2 was the gene involved. And again, the Berul lab went on to demonstrate that they could silence the mutant allele. And the way they did this was an siRNA approach. So they created a small interfering RNA. They found the position on that where the effect was maximal, which was the U10. And again, they gave this to very young mice who hadn't yet displayed the phenotype, to older mice who again had shown evidence of CPVT. And again, they were able to both prevent and reverse those two situations. And what they then went on to show that there was a significant shift in the transcription of the wild type to mutant allele ratio from 1 to 1, which we'd expect, from 2 to 2 to 1, favoring the wild type. And when they looked at the tetrameric structure of the channels, you can see that there's a significant shift away from so 6.25% in this example, where all 4 were mutants, to 1.23% in the treated mice with the same phenomenon. So they could shift the genetic expression by silencing the mutant allele. But that's great if you happen to have this specific one variant. So of course, this is very individualized to this one variant, the 4496 or the 4497 as it is in humans. The next approach is gene editing. This has, of course, received a lot of press, particularly with Jennifer Doudna's Nobel Prize. And I obviously don't have time to go into this, but this is a wonderful paper for those of you who are interested, written by Eric Olson, which really goes through the mechanisms of gene editing in some detail and different applications that have been used to date. And the one that's been tried in CPVT is this one, CRISPR-Cas9. Basically, there's a guide RNA which identifies the mutant allele. It causes a double-stranded break in the DNA. And then there's that usually leads to a frame shift and therefore breakdown of the mutant allele transcript. There's many other forms, as you can, and base editing has also been particularly looked at, not in CPVT, but the Seidmans have done some really nice work on base editing in hypertrophic cardiomyopathy. And this actually was work from here in Houston, from Sander Behrens' lab. And they showed again that they could perform this in mice with the 176Q RYR2 phenotype. Again, the mice recapitulate the phenotype very nicely. They could identify the mutation and cause a double-stranded break, and that then heals with indels, and that leads to frame shifts. So overall, there was a 30% reduction in the mutant transcript, and that again led to a significant shift in the ratio of RYR2 favoring the wild type and away from the mutant, with a total reduction in 25% of the RYR2, but that didn't seem to have any significant effect. So you could knock down, if you like, the mutant allele and cause a reduction in the total amount of protein, but that otherwise the heart was functioning normal, but they lost the CPVT phenotype. There's a lot of sort of interest, of course, in gene editing and the potential for deleterious effects of editing elsewhere. What happens if you edit on the wild type allele? But that hasn't happened to date, certainly in animal studies, but obviously there's a lot of work ongoing in this field. And the work that's we've been focused very much on, which has been led by Vasilios Bezeridis, is silencing of a downstream protein. And this is calmodulin kinase 2. And the reason for this, of course, is RYR2 is a huge gene. There's 5,000 amino acids. There's many different mutations. And so you can't really design a gene therapy approach just for a family and then use it specifically for them. It's just not an economically sound way to approach this. So this was some early work that Vasilios and Bill Pugh did, and they were able to demonstrate that it's calmodulin kinase that is the key to that excessive function of the RYR2 molecule. And that if you inhibit calmodulin kinase with this protein called AIP, you could significantly suppress that effect. That has been known for some time. And that didn't work by inhibiting phosphorylase kinase A, which is also thought to be involved in dysfunction of RYR2. And that could be done either by direct inhibition or by genome editing of these 2 phosphorylation sites, one of which relates to pKa and one of which relates to CAM kinase. One of the big problems with inhibiting CAM kinase is that it expresses ubiquitously elsewhere, particularly in the brain. So if you knock down CAM kinase in the brain, you're going to have a very deleterious function overall. And so the sort of the question they set out to answer was, can you selectively inhibit cardiac CAM kinase 2? And of course, the way to do that is by introducing a cardiac promoter to specifically target those cells and potentially spare the other sites. So this is how the study was designed. This is the molecule. As you can see, this is with the AIP, the active protein, and this is the control without that. That goes into an AAV9 vector. There's a troponin T promoter to make it cardiac specific. And obviously the idea is that this will inhibit CAM kinase 2. Again, the study was very similar to those done before. This was done in very young mice, again, the 176Q. It was done in older mice who were sort of akin to adolescents in humans, and was done in iPS cells, which were derived from patients who've been well phenotyped in the clinic, known to have CPVT associated with ryanodine mutations. Thankfully, the effect seemed to be very much limited to the heart. There was very little inhibition of CAM kinase 2 in other organs, particularly in the brain. And interestingly, again, the sort of transduction level that was able to be achieved was around 45 to 50%. So again, we didn't have to transduce every cell. Basically, the way this was tested was with EP studies, inducing the VT or VF in these mice, spontaneous ectopy driven by catecholamine provocation, both in the mice and also in iPS cells. And you can see here the demonstration of the after depolarizations, although these are all drawn images. These are not the real images. And again, with AIP, you could significantly reduce all of those effects, showing that suppression of CAM kinase in these individuals was sufficient to restore or prevent the phenotype of CPVT. And of course, this has a lot of attractions in that potentially you could address the whole gene by interfering with a protein downstream through which the entire protein of RYR2 functions. So moving on to sort of the future of CPVT gene therapy and what could it potentially look like? Well, there's a lot of things that go into considering how any new therapy could work. And of course, one of the most important things is, what is your market size? If we think that the prevalence of CPVT is 1 in 10,000, we don't have specifically robust data to support that, but that's the assumption that's always made. And then we have to think, well, how many of those patients are truly accessible? If 1 in 10,000 in the population, how many of them can we actually get to, and can we find and identify? That's obviously going to be much less than the prevalence of the overall disease. As I said at the beginning, we think there's a significant unmet need because current therapies don't really work. But I think in many patients, and I'm sure this is your experience the same as ours, if they're well treated with flecainide and beta blockers and they're compliant, keyword there, and potentially some of them have a sympathectomy, many of them actually do very well. So what is the true unmet need in a very well treated population? Probably less than we originally thought. How many of them actually want gene therapy? Important thing to ask. There have been many molecules and therapies that have been developed for specific populations, and when they went to the community of patients, the patients said, thanks very much, but not for us. And then how many of them would be ineligible for any study? So the big thing we're looking at now is neutralizing antibodies, and what these are is antibodies to the adenoviral vectors, so they will break down the vector and the effect will be lost. So it's very important when you're thinking about developing a new therapy is how many patients have we actually got out there who we can really treat with some significant degree of confidence in terms of we can get to them, they want it, and they're suitable. And one of the big things, of course, is what is the cost of gene therapy? Well, it costs a huge amount to develop these agents, particularly in producing the vectors, which at the moment is very expensive. It'll probably come down over time. But these are 3 agents that are out there at the moment. So Zolgensma, you've probably heard of. It's quite well known now. It's been out for a few years. That's used to treat SMA. For about 500 patients a year who are born with SMA, current cost just over 2 million for 1 dose. These are 2 new agents which were approved last week by the FDA, both for hemophilia. There's about 24,000 hemophiliacs with hemophilia A in the US, 6,000 with hemophilia B. And these are going somewhere between 2 and 3 million, again, for a single dose. All of these drugs were shown to be cost effective by ICER. So ICER is the Institute for Clinical and Economic Reform. They're based in Boston, and they effectively look at the current treatment strategy, look at the efficacy of the new agent and say, is this a cost-effective approach? But of course, with all these agents, you don't need me, or all these disorders, you don't need me to tell you, these are very, very expensive to treat. In SMA, you've got long-term ventilation, long-term ICU. In hemophilia, you've got regular dosing of very expensive agents used to treat bleeding. disorders. So these are very, very expensive to treat. And if you flip back to, well, many patients with CPVT do very well with very simple agents, you're coming into a very, very different equation. I think one of the big challenges in gene therapy at the moment is the host innate immune response, which has been a big issue and remains so. That's because the viral dose is very, very significant. And again, so it's very important we understand to what degree, how much of a dose that each individual needs to have and what is the transduction rate you need to achieve. This was a sort of a paper by a guy called Jim Wilson, who's been involved with gene therapy for a long time. And he was involved. This patient actually is Jesse Gelsinger, who was a young man who died from gene therapy in Philadelphia in the late 1990s. And they showed he had an untoward immune response. And this is a problem that's ongoing. And if you read the sort of biotech news, you'll see that regularly patients are still coming into some significant harm due to the immune response, both myositis and myocarditis related to the significant viral dose. But there is good news on that front. This is Pardis Sabetti's lab at the Broad Institute. And this was they came out with a new vector they called MyoAAV. And the potency of this for muscle is significantly higher than for standard AAV. Effectively, what that means is the dose you need to give is significantly less. So there are new agents. There are non-viral vectors being used as well and being tried, which is going to be very interesting. So there's a lot of work, obviously, trying to get around this problem. And I'm sure that will ultimately be achieved. So in summary, where are we at for gene therapy with CPVT? Well, the CASQ2 story was fantastic in many ways because CASQ2 is very small. It fits nicely into a vector. It's an autosomal recessive disease. At the time, it was thought heterozygotes don't exhibit much of a phenotype. But unfortunately, that was ultimately shelved because it was considered too rare. The other two are variant specific, but that may change over time. And obviously, the work that we're doing is still ongoing with significant evaluation with the potential for effects elsewhere that we hope won't be. So there's still a lot of work to do, but there's sort of a lot of interest in this, obviously. So in conclusion, I think the potential for gene therapy remains enormous to cure a huge number of genetic disorders. We're now down to N of 1 therapies, and I'm sure many of you saw it in the medical and lay press, the story of Myla, the little girl who had true N of 1 therapy devised for her with Batten's disease. It's an incredible opportunity for collaboration across the whole spectrum. Clinicians, biotech, scientists, and obviously the patient community are inherent to making this work. There still remains significant hurdles in the short to medium term: the immune response, disease effect, treatment modality, case selection, equity, and inclusion. Is everyone going to be able to get this? But I think the intangible benefits of being able to cure a rare genetic disorder are enormous, and you cannot put a financial sum on a mother who can sort of stand at the soccer pitch and watch her son play soccer, knowing that he's not going to have a cardiac arrest at any moment. So thank you very much for your attention. I apologize again for the slight issue with downloads. Thank you.
All right. So we get the computer loaded. It's really a pleasure to introduce actually my former mentor and current mentor, Dr. Charlie Berul from Children's National, and his talk is on ICDs and sympathectomies, optimal use in channelopathies.
That's not the beginning.
Yeah, hold on.
Great. Well, thank you, Christina, and thanks to the Texas Children's Team and the SADS Foundation for having the opportunity to come here and finally attend this great session. I've really enjoyed the first few talks. They've been terrific, and it's made me a little bit nostalgic because I was thinking it's from about 28 years ago till about 13 years ago. I did a lot of mouse electrophysiology studies and a lot of genetics. And so seeing the progress in those fields is really exciting, and enjoyed seeing a lot of that. So we're going to shift gears a little bit and talk about ICDs and sympathectomies in patients with inherited arrhythmia conditions.
change that from channelopathies, actually. But because it's really the whole family, and a prior speaker mentioned, it's not just channelopathies, and they're all overlapping. There's the inherited arrhythmias that are channelopathies, as well as some of the cardiomyopathies that have inherited arrhythmia conditions, and they have overlapping treatments. So my talk's going to end right around noon. So I thought I'd put up a few slides to, make you salivate a little bit. So it makes the news, these rare conditions. This boy whose heart stopped after biting a hot dog. Dr. Dubin found that he actually had Brugada syndrome. Not to be outdone, Shu Sanatani and Libby Sherwin published a case report of choking after someone was eating macaroni and cheese and was diagnosed with CPVT. So the title that was given to me was ICDs and sympathectomies, but I wanted to put one slide up that sometimes we still use pacemakers, and particularly in this unique situation that the adult electrophysiologists rarely, if ever, see, which is 2-to-1 AV conduction in 2-to-1 AV block due to profound QT prolongation in neonates. And sometimes if that doesn't progress, you can see, I'm just looking, pointer there, yeah. You can see the little green arrows there. No, okay. Little green arrows there are the P waves, and the black arrows are the very long QT. That's showing the T waves there. And so sometimes you need more than just a pacemaker. And so these days, when kids that have long QT syndrome or other inherited arrhythmias have an indication for a device, it's uncommon, other than in neonates and infants, that we use a pacemaker, and we often default to an ICD. But as Dr. Ackerman said earlier, the vast majority of patients with these conditions don't need an ICD. And the most frustrating thing you see is someone coming into your clinic with a fresh scar coming in for a second opinion. Now, ICDs have come a long way. I got nostalgic already and talked about 1994. This was in my first year as an attending, and had a girl come in after drowning and was pulled out of the bottom of the pool. And nowadays it's obviously common. That was long QT1, and drowning is a known issue with that. Now, in 1994, at age 10, she was the youngest recipient of an ICD. Imagine now, we put ICDs in a lot smaller than age 10, but so she got this little plaque from a company that she's now outlived the company. So she's now a grandmother, and has gone through several revisions and is doing great. The company didn't survive as long as she has. And we've gotten to the point where there's now expert consensus on management of ICDs specifically in pediatric patients, which is really unique because most of the prior consensus documents, the pediatric group was sort of an afterthought, or maybe there might be one pediatric electrophysiology representative at best. And so the task was talking about ICD therapy. We know defibrillation is effective therapy for sudden cardiac death, including in long QT syndrome. But there are risks, including ICD storm and a catecholamine surge, particularly if they get shocked before they're unconscious. And so here's an example from one of my patients who you can see the defibrillation shock that did convert her to sinus rhythm. And then seconds later, with crying and screaming, she went back into VF. Unfortunately, if I continued the screen, she got shocked again and stayed out of it. There's some data out there on the use of ICDs in long QT patients. This is from Wojciech Zaryba and the International Long QT Registry, looking at the probability of death, whether you have an ICD or don't have an ICD. And that looks like a pretty big difference, but it's really just a trend with a p-value of 0.07. Susan Etheridge and colleagues a few years later in pediatrics showed a similar trend, 0.06. And it really depends on how much you spread out the y-axis of your scale, because they're really the same difference. And they may look different, but both of them are just a trend. And there's no statistically significant difference whether you have an ICD or not. And it really depends on who you're putting an ICD in, and you have to be very selective. There are indications and guidelines. As I mentioned, here's some of the older guidelines from the adult recommendations for long QT syndrome. There was one pediatric electrophysiologist on this committee, and the usual guidelines of after cardiac arrest as a class 1 indication, although Mike and others and I have had exceptions to that rule because those patients typically haven't even been tried on any medication. A class 2A recommendation for patients with syncope despite receiving beta blockers, and 2B for primary prevention. Those are sort of the older guidelines that are out there. And Mike showed this slide before. There are side effects, even if you use guideline-directed therapy for congenital long QT syndrome. And from their paper, I'm just going to put a few highlights. You've heard Mike talk. I'll put them up again. And I think what's really impressive about this is the N, the sample size. In the Mayo cohort of 1,300 patients with long QT syndromes that are getting guideline-directed therapy. That, I think, is the most impressive part. Congratulations of this paper, is just the sample size and the power to be able to make these conclusions based on the treatment plan. So most of the patients, 1,100, were receiving beta blockers. Some were getting sodium channel blockers. About 15% got a left cardiac sympathetic denervation, and about 19% got implantable defibrillators. And with those therapies, they concluded that although the long QT syndrome is the treatment using guideline-directed therapy is effective, they're not innocuous, and that you have to take into account the potential side effects, whether it's medications or procedures, and they're not trivial, and you should compel an ongoing quest for new ICD therapies. I should have, new long QT therapies. I guess I should have gone right before you. It would have been a great segue to your presentation. In terms of ICDs in Brugada syndrome, there are several papers that are out there, including ICDs in children with Brugada syndrome, and they've shown to be effective. The big challenge is knowing when do you put the ICD in, because right now there's not great medical therapy. So it's either monitored observation or defibrillator, sometimes medication, but there's problems with the ICDs that are unique to Brugada syndrome in children, which mainly is based on T-wave oversensing. Brugada syndrome, as you know, they often have peaked T waves. The ICDs aren't that smart and see those peak T waves, as you see there, as QRSs and double count. And it's one thing to get shocked out of a ventricular arrhythmia, even if it hurts and can cause some issues. It's another thing to get shocked when you're just standing around. I think people really kind of hate that, to get shocked while they're in sinus rhythm. And it can be dangerous because it can trigger a shock-induced proarrhythmic event. And similarly for CPVT, we and others have shown that ICDs are not innocuous in CPVT. There's two things that we see here. One is the ICD storm. Not surprisingly, in patients with the C is for catecholaminergic. And so if you shock them, they're going to get a catecholamine surge. And so while that shock may terminate the arrhythmia, it also leads to a catecholamine surge that can be a vicious cycle and cause another VT-VF event and get multiple shocks. The other thing that's a little disconcerting is this thing called secondary termination. So here in the bottom panel, you see ventricular tachycardia that's appropriately detected by the ICD. The patient gets shocked, and 3-4 seconds later, they convert to sinus rhythm. The shock doesn't immediately convert them, and that's called a secondary termination. And that's a well-known phenomenon that's seen more commonly in CPVT than in other patients. And so cautionary tale in terms of using ICDs in CPVT. This is a study from Arthur Wildes' group and a multi-center study looking at ICDs in previously undiagnosed patients with CPVT who were resuscitated from cardiac arrest. So these patients had a cardiac arrest, class 1 indication for an ICD, and then subsequently were diagnosed as having CPVT. And 136 patients were in the study, and an ICD was implanted in 79 of them. It's a pretty high percent. I'm surprised it wasn't even more than that. And what they compared is the patients who received an ICD with the patients who didn't receive an ICD, and showed that there was no survival benefit of having an ICD in patients who had a cardiac arrest due to CPVT. And in fact, if you look at the red graph there compared to the patients without an ICD, there's a trend towards a higher complication rate or even a higher event rate in patients who have an ICD compared to those who are treated with other medical or procedural therapies. And so in previously undiagnosed patients with sudden cardiac death, an ICD is not a survival benefit and may be associated with a higher event rate with more appropriate shocks, but not higher survival. And obviously with device-related complications. And so let's switch gears to left cardiac stellate ganglionectomy or left cardiac sympathetic denervation. They're synonymous, I think. And this is an old slide from a surgical general surgery textbook. And the reason it's in a general surgery textbook is this is a common treatment, surgical treatment for sweating too much, for hyperhidrosis. And that's how the general surgeons really got good at doing sympathectomies before this became a cardiac procedure. This is still how they're trained in general surgery residency to treat hyperhidrosis, is to do a bilateral sympathectomy. If you do one side, only one side's going to sweat less. And they don't go as high. We'll get into that in a second. And here's the 20th century data from Dr. Schwartz, the landmark paper on the impact of left cardiac sympathetic denervation on patients with long QT syndrome. And you can see from this paper, it came out in 2004, but many patients were treated in the 90s with this. And the left panel is the cardiac event rate. And don't worry about the different panels, or you had a lot, you had some, and you had a few cardiac events. And no matter which group you were in, after left cardiac sympathetic denervation, you had significantly less events and 60% less events in the follow-up after sympathectomy. So that was really the landmark paper on using this as a therapy for congenital long QT syndrome. The complications that we worry about and why we don't send everybody for this, one is that a lot of surgeons aren't as good at it, and you have to train your surgeons and either go to a center that does this frequently and make sure the surgeon's doing it correctly. One of the big concerns is Horner syndrome, the ptosis, meiosis, and anhidrosis on one side. You see the eye droop in kids and adults, and depending on how high up they go in the chain. And this has been around for a while. I found this from 1852, a nice picture of Horner syndrome, and even further back, King Edward I looked like he had Horner syndrome in the pictures that have been drawn about him in the 14th century. So this is not a new thing. The other thing that's an interesting complication, this is actually one of my patients, a little sticky note over her face to make it anonymous, but I know her, and she had this for about 6 weeks after her sympathectomy, and we worried about it. She worried about it. Eventually went away, and I think it's a sign of efficacy that the surgeons are actually going up and ablating or cutting the lower half of the stellate ganglion, because that's been the issue that our surgeons have learned the hard way, that if you don't go high enough, you don't have an effect on decreasing the arrhythmic risk. If you just do what you do for hyperhidrosis and just go to T1, that doesn't give you a cardiac effect. And you have to get the bottom half of the stellate ganglion. You get the top half of the stellate ganglion, you get the eye droop. So the surgeons have gotten very good at this, and it's an effective therapy. As Mike also alluded to this, that in rare cases, that can actually be monotherapy, treating patients with just a sympathectomy. And I've done that in select patients. You really have to know your patients before making that decision. In most cases, I've done it for patients who had significant adverse events from beta blockers or severe contraindication to beta blockers, asthma exacerbation requiring a PICU stay, depression that caused a suicide attempt. Those are the ones that I can think of where I thought long-term beta blocker therapy is probably not a great idea. And so monotherapy with a left cardiac sympathetic denervation is sort of the concept of a surgical beta blockade. It's not really that, but it's close to that, is one way to potentially avoid having an ICD. The most common use of left cardiac sympathetic denervation is for those who have continued arrhythmia on beta blocker therapy or appropriate shocks from their ICD. And in this study, Mike and colleagues showed that the vast majority of patients don't have any complications. About 86% that says had no complications. And the complications included short-term ptosis, which again is tolerable. Long-term ptosis, only 1%. And is someone else, I think Jeff Kim said, well, at least you're alive. But it's not a horrible complication. But persistent pain, neuropathic pain, can be an issue and is seen in a small percentage of patients. We haven't seen much of it, but in the one patient I can think of who had it, it's a true problem and needs to be treated with neuropathic pain medications like gabapentin and others. And so in their study, I can't read this here, that long QT, in patients with long QT syndrome, left cardiac sympathetic denervation can be used as a safe and effective monotherapy as standalone patients who may be treated without beta blockers and without defibrillators, but you really have to be careful and know your patients. Now that was all for long QT syndrome. And then along came 2008 and a bunch of case reports, small case series of 1 to 4 patients came out that left cardiac sympathetic denervation may be effective for CPVT as well. It's been around since the 90s for long QT syndrome. It took us a long time to even try it for CPVT. And all 5 of these papers came out within a year of each other. I'm not sure that any of them talked to each other. I know our paper came out within months of Arthur Wilda's paper. We didn't know they were doing it. They didn't know we were doing it. This is their case in a young adult in the before and after showing that the ectopy goes away 2 days after denervation. Our paper had 9 children using videoscopic denervation in 9 consecutive children. 4 of the 9 had CPVT. The others had some sort of undefined ventricular arrhythmia that had failed medical therapy and had defibrillators and were getting shocks, appropriate shocks from the defibrillator. And 8 of the 9 improved after the sympathectomy, including 3 of the 4 with CPVT. Again, early in our experience, and again showing the sympathetic chain and knowing where you have to go to be effective. And the videoscopic approach makes it a lot less invasive. This is a relatively minor procedure. The cosmetic result is better than an ICD in terms of cosmesis. There's no lead failures. And as we talked about, there can be some complications, but using a videoscope, you get a really good view of the sympathetic chain, and the surgeons can be taught with a pretty easy learning curve. Some of the more recent studies that have come out is this is actually an interesting one from Germany, looking at sympathetic denervation for life-threatening arrhythmias in CPVT. If you look at their study, it was only 10 patients, but basically 9 out of 10 were improved after sympathectomy. And I took a snapshot of this ICD interrogation history. And if you look on the left side prior to the sympathectomy, I cut this out from a bigger figure in their paper. This is the non-sustained VT episodes per day. It's a lot of VT in this patient that was recorded on the ICD. Another part of the panel showed shocks, which were fortunately much less frequent. But in all the panels that you can see the left sympathectomy on that dotted line. And after that, everything really goes away. There's just a little bit of non-sustained VT and no further sustained VT or shock. So again, impressive therapy. There's been some multi-center studies that this one is probably the biggest study showing event-free survival before and after left cardiac sympathetic denervation for CPVT. Again, this is an issue a little bit, I'm a co-author, so I'll criticize myself too, an issue with the scale axes. The event-free survival on the left scale prior to sympathectomy is in years, and the event-free survival after sympathectomy is in months. And so that curve on the right may not look as optimistic if you did that in years, and that's, if you took that 48 months and shortened that x-axis to 4 years. It's not going to be as bad as pre, but I think we the global we in this group of 20 authors might have exaggerated the visual look of the improvement on this, but just self-critical. A couple of new state-of-the-art reviews, and this one from Dr. Cron and others. When to use an ICD, when to use a sympathectomy. There's not much difference from 20 years prior. Secondary prevention for resuscitated cardiac arrest, and consider for primary prevention in high-risk patients who either have breakthrough syncope or despite beta blocker therapy, or potentially in high-risk subgroups, and using atrial overdrive pacing during ventricular arrhythmias. And when to use a left cardiac sympathetic denervation is, again, beta blocker intolerance or arrhythmic events despite beta blocker plus or minus an ICD. I would say minus the ICD. My approach is sympathectomy first for CPVT, ICD only if they're still having events. And again, sympathetic denervation and the prevention of arrhythmias. Some of the pathophysiology in this review from Dr. Schwartz and Ackerman, there's a decrease in the release of norepinephrine at the nerve endings, a decrease in the arrhythmias associated with ischemia, an increase in the ventricular refractory period, which is probably the actual true physiologic event probably, and an increase in the ventricular fibrillation threshold. They all work together, and an increase in myocardial hyperemia, and no effect on cardiac performance during exercise, which has been a concern. So unlike chronic beta blocker therapy, you don't see a decrease in performance. So they came up with this, sort of red light, green light category, and recommend left cardiac sympathectomy in very high risk patients, either if they have it in the first year of life, where again, an ICD is not ideal to put in, or certain, some of the COM gene mutations, and recurrences on beta blockers, the yellow group for aborted cardiac arrest, lighter yellow for syncope on a beta blocker. And then they even propose a green group that may be left cardiac sympathetic denervation in the right hands with the right surgeons, maybe a safer approach, even in patients for primary prevention, whether they're high-risk patients or even light green for the not high-risk patients that are asymptomatic and intolerant to beta blockers. So potentially for anyone with the disease as a light green recommendation. So it's really a matter of risk versus risk. I actually took this slide out of a talk I give on lead extraction, but it's the same thing. It's risk versus risk. Risk of arrhythmias and risk of the therapies. And you really have to balance those risks. After all of this, these are life-saving therapies. And so we need to approach these and optimize the treatment for our patients. Thank you.
So we're running a little short on time, but we're going to, for about 5 minutes, if I can have the second group come on up. And does anyone have any questions? Anyone? Oh,
Thanks. Great talk, Charlie. When, if ever, then would you consider putting an ICD on a CPVT patient?
Yeah, for CPVT, I use that as third line therapy. So medications, high dose, long acting, non-selective beta blockers, and flecainide. If they're still having arrhythmias, sympathectomy, and if they're still having arrhythmias, then an ICD. I think in that case, and when I put the ICDs in those patients, I program them to allow them to have non-sustained VT, so that either they'll self-terminate on their own, or they'll pass out before they get shocked, so they don't get as likely to get the catecholamine surge. Probably better before they are driving, but.
But having said that, right, Charlie, and I totally agree, but you have a CPVT sudden cardiac arrest survivor. You and I might be very, very comfortable with a non-ICD treatment solution. They may not be. And so you still have to honor that if they just can't get there because their child just did death and got resuscitated, they may get a secondary prevention ICD for which the guidelines completely support that. Sylvia Priori still has new data that's about to come out from her data set suggesting that the ICD is actually protective. We would respectively say, I'm not sure about that. But if you have somebody who says, I need the defibrillator, need as an emotional need, in our program, we would provide triple therapy in the background, beta blocker flecainide denervated, so that we completely neutralize the risk of the ICD participating in the storm.
Sure. You only, as I tell my family's parents, you only get to die once, right? So if someone comes in with a resuscitated cardiac arrest, I offer an ICD, and many parents will choose that. But I also offer for CPVT patients who haven't had a cardiac arrest to go without an ICD first.
Right. I was just saying that in the cardiac arrest survivor,
Sure.
we offered not doing the ICD
Yeah.
and saying we're now comfortable and confident that even though you started with cardiac arrest, the same for LQT1, we're totally confident with a non-ICD solution, even though they started with cardiac arrest. But you and I might be comfortable with that, but they may not just be able to get their heart around that and may just say, I need a defibrillator. And if they do, then we counter it with the full Monty.
Yeah. I had a kid just 2 or 3 weeks ago who came in after cardiac arrest, exertional cardiac arrest, documented VF, shocked in the field with an AED, little short-term memory loss, but overall survived. And I said, all right, we're going to do a quick V-stim through, before putting an ICD in, but I'm going to do a quick V-stim first because I had no etiology for his arrest. All his initial evaluation was normal QT, normal prokinamide challenge, normal cardiac MRI. So he didn't have any clear substrate. And as I'm doing the V-stim, I induced typical SVT. And so I'm like, oh, now what do I do? So I ended up ablating his SVT and not putting a device in. And hopefully that was the cause of his arrest. That's a pretty rare cause. I've not seen it before in all my years, but I'm hoping he doesn't have two separate things.
It is known that the right stellate also innervate the heart. Did you consider, denervate the right side also?
Hey, Mohammed, how are you? Yes, we've done a few bilateral sympathectomies. I think only after the left side fails to offer right side. I'd say in the ones that we've done, it's typically those who continue to have appropriate shocks on optimized medical therapy. And after a left-sided sympathectomy, that would be the next step, is to do a right-sided sympathectomy. And once we've even done an auto transplant, the surgeon takes the heart out, puts it back in to essentially denervate the heart once.
You have to be really careful with that. There's a group out there that's put forward the idea of upfront bilateral sympathectomy. That's dangerous, and I think it's wrong, and you don't need it. So the point is, you don't need it in long QT and CPVT almost always. And where that's coming from is in the adult ischemic VT-VF, where they're very fragile. They may only have one chance to do something. So they're often thinking, and this is Shiv Kumar at UCLA, and he does great work, but the application and the transference of that idea to long QT and CPVT, I think is not good. And the idea behind why you might do the right is 90% of the time, the left chain is the predominant noradrenaline secreting chain, and the right chain is not. But every once in a while, you have a lot of noradrenaline coming out of the right chain.
Can I ask a question? So, Mike, on the AI differentiating gene positive versus gene negative long QT ECG, I was always under the assumption that some of the acquired long QT was sort of a concealed genetic abnormality, that they may have a normal QT or borderline QT, and then you give them a drug and their QT gets long. Is that still true? And if so, can the AI differentiate those?
Well, we haven't tested exactly that. I love that. But we were actually surprised and are surprised with how good the mutation detector is working, because you think about what's the most common cause of drug-induced QT prolongation. It's hERG block. So hERG blockade pharmacologically and LQT2 are sort of kissing cousins of each other. And yet the computer is able to distinguish a QT prolongation because of an LQT2 mutation versus one that's because of the presence of diphthalate. And so there's more going on than just what the ECG looks like when you get genetically disrupted versus pharmacologically reduced.
Yeah, it's amazing. I can't tell them apart looking at it.
All right. Well, thank you to all of our speakers. I'm going to go ahead and you can have a seat. Thank you. And it's really a pleasure to introduce Dr. Nademanee, who came all the way from Bangkok and Bumrungrad Hospital to talk to us about his true expertise. And his talk is an ablationist approach to channelopathies. Welcome.
Thank you, Christina. How could I get my... I'd like to thank SADS Foundation and Dr. Lee for inviting me here and give me an opportunity to enjoy the wonderful talk. I found myself the first time that I pay attention for 4 hours without falling asleep. Thank you very much. I learned a lot. My task today is to talk to you about the ablation of the channelopathies.
I can do it.
Okay, thank you. I'm sorry. Okay. This is my disclosure and funding, and I have to acknowledge the most of the work that I just about to present to you. A big collaboration from 3 continents, as you can see here. Most of the collaborators, you probably recognize them. Talking about the channelopathy, there are different kinds, as you have heard throughout this morning, and the mechanism that causing arrhythmia is somewhat different. But as far as the treatment of using the ablation, it started from the Bordeaux group that Michel and his group tried to identify the trigger of the patient with the long QT syndrome and the Brugada syndrome, and later on expanded to CPVT and short QT. And however, the success rate overall, especially in CPVT and long QT, are not that great. And a lot of these group of the CPVT and long QT usually had multiple focal that coming from Purkinje and some of them myocardium. And as you have heard from the speaker throughout this morning, that the CPVT and LQT2 is respond so much better with medication and blood standard gangrenotomy and other treatment, and you don't really need to do the ablation. My experience, we had patient that was referred to for the ablation, but their father they treated with the itoflecainide, beta blocker. They're all doing well, so we didn't really have to do much. On the other hand, the Brugada syndrome and early repolarization syndrome, they have, although the success rate when you identify the VF trigger, it's very high. Unfortunately, most of these patients, when they came to the lab, they didn't have any PVC for you to map. You'll be lucky if you have the frequent PVC that trigger VF, by all means, try to map that. But on the other hand, even though the PVC trigger was not rarely present, but they have the subject. I just want to remind the audience also that this is part of this is the work that my Ackerman group published, and also had been confirmed by the St. George group in UK, that sudden unexplained death syndrome, or SAD, that you all try to fight now, is the major cause of death in the population that's younger than 40, 50 years old. And even in sudden death, it now had been recognized as a major cause of death. And when you're talking about sudden unexplained death, for me, especially in Thailand, 92% is JVEP syndrome, Bucata syndrome, and early repolarization syndrome. It's about 8% is QT, LQTT syndrome, and CPVT, and some of the idiopathic VF. And so because of that, the effective treatment in the JVEP syndrome is really needed. As you can see, Bucata syndrome, the early repolarization syndrome, and it's been like this patient who had the inferolateral SC elevation. This patient, we give Ashmalin, did not have any Bucata pattern. Many of our patients, especially in Thailand, in the northern part of Thailand, we have this, the Charlie ancillary, we like to call it a JVEP syndrome, meaning that they all have a curve type SC elevation across the limb lead and precordial lead. And this group are really the high risk group because they usually have frequent ventricular fibrillation. And just like this example of this patient that have the trigger PVC in causing ventricular fibrillation, and this trigger also coming from the RVOT epicardium. The first 2 decades of the JVEP syndrome, we don't really have any treatment. We just had an ICD and quinidine. And now, but quinidine is just only a few countries has them. ICD doesn't prevent VF. And here comes the catheter ablation for the treatment. And this is, I'm going to focus on for the rest of my talk. Maybe 10 years from now, the gene therapy would supplant all this treatment. I hope that is the case. To talk about the ablation, I would also like to highlight and go over carefully about the pathophysiologic mechanism. As you know, in the first 2 decades, we all just talk about repolarization abnormality, but I show the slide of the repolarization abnormality all the time. But when we, this is one of the very few patients we did the ablation. The force of the circumstance, because the patient have a lot of recurrent of VF, I could send the patient for heart transplant or do something. We all know that even though there's a controversy about repolarization or depolarization, we all agree that the substrate most likely would be at the RVOT. And we had a protocol that approved by the IRB to go in and then to plan to do the mapping and ablation if we see the substrate. And this is one of the second patient who had multiple ICD discharges. And I just happened to be in Bangkok at the time and went in and do the epicardium mapping, and lo and behold, to see this fractionated electrogram. And I said, wow, this is during sinus rhythm. And it turned out to be that it's only exclusively in the RVOT epicardium. The adjacent opposite in the endocardium did not have any fractionation abnormal signal. And you can see here, nice amplitude, single monophasic potential, and compared to the low voltage fractionated electrogram in the epicardium. And look at the unipolar, very nice, look like a curve type pattern in the unipolar. And when we ablate this area, I got so excited at the time, you can imagine, because of the Bucata pattern disappear. And this patient now is over 10 years because still didn't have any shock, whereas he had multiple shock before. At the time, we concluded that the RVOT epicardium exclusively substrate is in the RVOT epicardium. And when we ablate those, we normalize the pattern and suppress the VF recurrences. But the conclusion in that paper is not correct entirely, because exclusive over anterior IVOT is not correct. Subsequently, we learn more about that. So one of the struggle at the initial early on that at the time, what caused of this fractionated electrogram? The MRI of the IVOT, the echo and all that, and the autopsy in this patient never show any abnormality. And we learned from Jacques de Barker and in Colombia, Andrew Wiss also, that in the ischemic myocardium, especially that have fibrosis, like the cartoon here show the dark area. And when you put the bipolar electrode here and then stimulate at this site, and then you will see the conduction zigzagging. I hope it, okay, zigzagging, and the record the bipolar signal, that's why you see multiple potential throughout this. But why is all the imaging is normal? So I cannot, okay. Sorry. Fortunately, the answer came when we had to go to treat this patient over the thoracotomy, because some of these patients need to have the lead extraction and could not be done successfully through the percutaneously. So we have to do an open thoracotomy. And some of these patients, I could not go into the pericardial percutaneously. So what we did is we do the mini thoracotomy and decide the grid over the RVOT. And you can see here the grid and the area by all these numbers are the area that we record this electrogram. And the area 8 and area 9 here is where we did the biopsy as well. You can see the fractionated electrogram as I showed you earlier. And the biopsy, we show epicardial fibrosis. It's very, very thick. We have done now over 10 patients, I think up to 12 patients now. This is a combination from our group and Dr. Nogami in Japan. All patients have the thick epicardial fibrosis. And this is the epicocerious stain and have the interstitial epicardial and focal replacement fibrosis. So here we go. So now we can explain it why you see the fractionated electrogram, because of the patient has subtle fibrosis. The St. George group also looking in the patient who died suddenly. Those victim has a family member of the Bucata family history of Bucata syndrome and have EKG documented. When they're looking at their heart, they have a special cut. Those patients in St. George that they did the study, also the routine autopsy initially was negative. But there is expert in cardiac pathology, Professor Mary Shepard, carefully cut the RVOT and RV. So they found that the collagen present very significantly in this victim, especially in the RVOT and in some part of the RV body and the inferior wall as well, and compared to the control. Also, they did the immunohistochemistry, looking at the connexin 43 expression. I forgot to bring the slide to show you, and they show that that's a suppression of the connexin 43 suppression, and at the gap junction, it just totally disarray and disappear. So no question, all this causing the conduction abnormality. And then the patient that I just showed you, after we did the ablation through the thoracotomy, we normalized the electrogram, and the patient did very well. Now, this also very, very interesting. The another patient, in this area 3, you can see here that before ashmaline, the electrogram is normal. And after ashmaline, you see fractionated signal. Same thing with the area like 13, normal electrogram, normal good looking, and then after ashmaline is fractionated, and you can see the change in the unipolar. When we did the biopsy on this side, it show this is mesothelioma stain and show the collagen. So what does it mean here? It means that even though you have a fibrosis, but it's not severe enough to express the abnormal signal. But once you have the sodium current reduction with suppression by ashmaline, then it became the prototype become manifested. And that's one of the reasons that how the ashmaline changes. And also confirm that the same thing if you have the pathogenic SCN5A mutation, or now we know that it's polygenic, and if anything that affects the sodium current reduction, it will cause this phenotype to become more manifest. And in some cases, you can see the conduction block, and then the area of the fractionation. When you see the two potential, and this is single potential, and the reason is some of the terminal portion of the way the fibrosis is zigzagging at the terminal part of that conduction. There's a block or no excitation in that area because of ashmaline. And that and you can see the unipolar here that look like a monophasic action potential. And this area is also have fibrosis. When we pacing the heart through the atrium, we found that the shorter the frequency, the electrogram, the fractionation electrogram increased. But when you keep ashmaline, even the same frequency of 600 millisecond, do you see this is the top, it's before ashmaline, but it's after ashmaline, you can see the decrease in the amplitude of the voltage, and then no excitation. So with this study, we show that ashmaline can cause the conduction block, failure to excite, no excitation, and also the severe abnormal conduction abnormality that all could cause arrhythmia, obviously. And I'm going to show you, I'm going to skip this one. I will show you that not only when we see those abnormality, we can also show from the program stimulation that there's a conduction block typical of the entry. This is the patient who have frequent ventricular fibrillation and ICD discharge. I have a tough time to advance this. Okay, here we go. This is the ECGI from the West cardio insight. This is during sinus rhythm. You can see the delay activation in the RVOT and some in the inferior wall. And this side, you record the fractionated electrogram. We're using lasso up in this area. And you can see the unipolar look like the Bucata sign here. And after ashmaline, the area even become much larger. Not only just in the RVOT, but it goes all the way out to the RV body, and also in the inferior wall. And coincide with the SC elevation in the unipolar lead. And when we do program stimulation, there's a single premature beat. I'm gonna highlight this. In this particular area, you can just gonna see the conduction block, and that you see that here is you see the electrogram of the S1. After S2, you can see here there's a block, no excitation here. And then the pattern of the activation chain and causing VF. Again, the typical reentry by the unidirectional block, and then you cause the reentry. As you can see, when you compare to the S1, the S2 doesn't have any excitation, much delay later on. And this is the ECGI just to show you. This is the area that when it started, and you can see the isochrone very lump into together. Not only one side in the RVOT, but also in the inferior wall as well. And you can see here from the basic movie, that's the butterfly, nice butterfly up there, and then down here. And the shade area and the hexagon represent the focal activity and the rotational activity in this area. So these are the two subset area that we have to ablate. And you can see here that where we ablated. And that's the electrogram of this side. And this is the electrogram of the inferior wall. So this patient had two big area that causing ventricular fibrillation. And after that, with the triple, we couldn't induce any VF. This patient we just easily induce with a single, and the patient did very well. And this is the summary, the distribution of the VF substrate. All our patients that had the abnormal substrate in the RVOT and RV body 100%. This came from the registry data that I just about to present it to you, and 29% has the substrate in the inferior wall. So that's what I mentioned early on, that the conclusion of my first paper was incorrect. It's not exclusive in the anterior RVOT. It's also in the body and in the inferior wall. So you have to really carefully map. And also we had 2% in this area, posterolateral area of the LV. And this area also important in the early lipolarization and also as well. Now, I just about to submit this paper, so this is the first time I share with you here. This is the registry data, we call it Berul, to report the experience of the Bucata substrate ablation. In the past, it has been a case report here and there, or some of the small number of patients. Pony has probably have the most, but most of the Pony patients not really overly symptomatic. And we had this from the 3 continents. I'm not going to go the interest of time to read them, but it's from the tertiary center throughout the world. And we have 159 patients, median age of 42. The majority of our patients had a cardiac arrest, survival of the cardiac arrest, and only 19% had SCN5A positive. Majority of the patient has spontaneous pattern, and there's almost 30% had a combined syndrome. The Bucata and early lipolarization syndrome. And the majority are Asian, Southeast Asian, Chinese, and Japanese. And we have 17% Caucasian. And this is the all the patients except 5 had the ICD implanted. And you can see here, this is most of the patient had ICD discharge after the implant. But this slide show that if you have an ICD discharge in the first year, the clean the red, orange, green, orange, and black are the frequency of the ICD discharge from greater than 10, 5 to 9, and then 10 to 20. Those patients who usually who had the first ICD discharge within the first year, whereas in the patient who had an ICD discharge rarely, but between 1 to 4, usually did not have any ICD discharge at the first time. So what this slide shows is it shows that if you have ICD discharge within the first year, it's very likely that you're going to get recurrent ICD discharge, and this is the number of the patient that I mentioned. And after the ablation, this is after the last ablation, and the mean of the ablation is 1.2. Some of these patients have more than one ablation. On the left is before the ablation, and on the right is after the ablation. Not only we have almost 95-96% success after the last ablation, and even those who did not have the completely suppress the recurrent of VF, the frequency of the VF is much less. Like these 3 patients, they used to have more than 20 or 4, and now it's only between 1 to 4. But majority of the patients had no more recurrent of VF with a follow-up about 3 years. And this is the Kaplan-Meier. About 95% of the patients did not have any have a VF-free survival. The only predictor of the success is the normalization of the Bugada sign, especially if you have the sodium channel blockade, show no suppression. And so we, based on this registry data, we feel very strongly that the ablation of the subject is very effective. And this is the only treatment I'm not trying to just up there. The only treatment that truly prevent recurrence of the VF. And the question is, can we replace the ICD treatment? I'm not answering that yet, but we have a study ongoing, and hopefully in the near future we can answer that. Now, because of interest of time, I know that it's late, and I'm not going to present this the early repolarization ablation. It's similar to what we did in the Bugada. But if you give me 5 minutes, I want to show you a case, because initially I want to present it, but then I heard many discussion, so I want to go on to show you this case, because it might be of interest for you. And so this is a 16-year-old girl who suddenly lost consciousness while playing basketball. And the law student and witness that she had some contracting and jerking about 30 seconds and remained unconscious for about 2 to 3 minutes, no incontinence. She had her sister who died 11 years old at nighttime. And this is the proband. She's 16. And this is her EKG, completely normal. The genetic study, she had these 3 genes, and they're unknown significance. I was for sure at the time, I thought that she's going to have a CPVT. So I did the treadmill. She did not have any single PVC. Maybe, so what do we do next? The family obviously lost one child already, and she's the only one left. have listened to this the talk this morning, I should also do a booster exercise treadmill to see if I can produce it. But I gave Ashmaline, and here this is the EKG. So I told the family that because of this, she has an indication for an ICD. I don't know you guys agree or not. And her mother had the ovarian cancer and also had the breast cancer. She said, well, let me think about all this stuff. But I know that you're doing ablation. Can you just do ablation? I said, yeah, I could do an ablation. But I still think after the ablation, you still need an ICD because, just for various reasons, and the same that what Mike was just saying, they don't have any kit anymore. And and here's her ECGI baseline. You can see the delay activation here. And then after Ashmaline, the same thing, like I showed you before, you have an area that increased. I could not induce VF on her, so I don't have a VF map to show you, but I have this map. She had fractionated signal, allow this area and all that. And I ablating all this area. And her EKG normalized is after Ashmaline. And this is before, and then this is after Ashmaline. So I said, well, we put an ICD. She said no. And the whole family refused. And this had been 2.5 years now. I'm just leaving this. It's just provocative. I don't. I don't know. I should have put an ICD before. I didn't plan this way. Okay, this is because I thought it would be easier to do an ablation before the ICD. But thank you for your attention.
Again, excellent talk. I know we're running out of time and everyone wants to get to food, but does anyone have a question?
Thank you. That was a great talk. I really enjoyed it and learned something from it. When you're ablating, do you do any endocardial ablation or is it all epicardial? And are you isolating the area? Because it looked like there were like circles around some of the areas rather than ablating around.
No, I didn't isolate. The Bordeaux tried to do the isolation. Somebody together did together. It turned out that the area, especially after Ashmaline, it became very wide. The average now is about 16 centimeters, square centimeter. It's pretty big. One might ask it, what happened? How the ARV functions so far so good. We no problem even after 10 years. And no recurrent of monomorphic VT from the scar from that either. So those are at least we have the long follow-up now. Now, I did always and do an endocardium map, but I didn't see any substrate. Some of the group in Europe and some in Bordeaux, they wanted to do that because they know where the area is, and so they try to ablate it from the endocardium. But usually it's much easier to do the epicardium. By the way, I didn't mention from the registry 159 patients, the only complication is 4 patients had a hemopericardium. But it's no big deal because we have the pericardial space, and that didn't make any major consequences.
Do you use any flecainide or Ashmaline during your
I use
ablation?
Ashmaline, yes, always.
During ablation?
Yeah. I'm thank you for mentioning that. It's very important to use Ashmaline because then you can see that after Ashmaline, the area of the substrate become more manifested. I mentioned, and you can expand. It's much more. And so you have to really, the endpoint of the ablation is just to eliminate all the substrate. The induction is a secondary endpoint. Normalization is also secondary endpoint because sometimes it's very difficult for you to, because when you did ablation, you see ST injury from the ablation. So sometimes well, this is curb time, not curb time. Especially if the patient have some right type of a conduction defect, or like Lieberman branch block. But asthmaline, definitely. We don't use flecainide, and I kind of scare of flecainide because they long half-life. Asthmaline is much better. But the Japanese using pisecanide, which is also the type 1 blockade. The Paponi, Carlo did use the flecainide at the beginning, but that now he's changed to use the asthmaline.
Well, I know there's some more questions, but I know that we have lunch, so I know Dr. Nademanee is around, and you can ask him personally. So thank you guys so much, and go ahead, and there's lunch ready.
All right, I think we're going to get started today. So welcome to the afternoon portion of the SADS Foundation Conference. We're going to be doing challenging cases, what I've learned and what I would have done differently. I think it's a cool honor that I get today to moderate this session. There are 3 wonderful physicians presenting, but all of them are close personal friends of mine. And I think that's kind of a rarity oftentimes in academic medicine, but it's pretty fun today. First up is Stephanie Chandler from Lurie Children's Hospital. And she's been teaching me since I was an intern at Boston Children's Hospital when she was my chief resident. So welcome, Stephanie. Yeah.
He still makes me laugh every day. Thanks so much for the invitation to speak here today. This is part of the Challenging Clinical Cases series, what I learned and what I would have done differently. I myself have no disclosures. So for the purposes of HIPAA, we'll refer to this patient by the student name John. I first met John during an outpatient visit when he presented clinically asymptomatic from a cardiac perspective, but was referred to cardiology clinic because of a secondary finding of a pathogenic variant in SCN5A. He had a history of autism spectrum disorder. He had a history of autism spectrum disorder, global developmental delay, and hypotonia. And his medical history is pretty important in this case, as it speaks both to why he ended up in our clinic, but also how we would approach his care in the future. For many of you, the idea of a secondary variant is not a new one, but for anyone less familiar in the audience, effectively what this means is John was evaluated in neurology clinic because of his history of developmental delay and autism spectrum disorder. As part of his workup, he had extensive genetic testing. And unfortunately, that genetic testing didn't yield a clear genetic etiology for his neurologic phenotype. But as part of that screening, he did have this what we call incidental or secondary finding of a pathogenic variant in SCN5A. And that, of course, brought him to our clinic. So let me take a quick step back in time. Even before we met John in clinic, when we knew he was coming to our clinic, we spent time in our cardiovascular genetics group adjudicating variants ourselves and ensuring that we're concordant with the laboratory evaluation before we discuss the results with patients and families. We do this because there's a lot of evidence out in the literature that the frequency of disagreements in classification is particularly high in cardiovascular genetics. I won't go into the details of our adjudication here, but they're summarized for those of you who want to read them. And suffice it to say that we agreed that there was compelling evidence that John's variant in SCN5A was pathogenic or disease-causing. So when I first met John in clinic, as I mentioned, he was 8-year-old who, despite some communication limitations secondary to his autism, had never, as far as his parents could tell, had any cardiac symptoms whatsoever. His baseline ECG demonstrated here was fairly unremarkable for an 8-year-old male. His high lead ECG with V1 and V2 in that high position demonstrates an incomplete right bundle branch block, but no clear evidence of pathognomonic sort of STT wave changes in the setting of that incomplete right bundle, sort of highlighting no clear Brugada pattern, but definitely some evidence of ventricular repolarization abnormalities. His echo demonstrated a structurally normal heart with normal biventricular function. So when I first met John's mom, these are the things she described to me that she was feeling when we started discussing why she and John were in our clinic. Not everyone that I've ever met in my clinic is as eloquent as John's mom at describing the emotional roller coaster that she felt she had been on with her young son. But one can imagine that for many patients and families, they share some of these feelings. John's mother, like so many of our patients and families these days, had, upon receiving the genetic results from the neurology team, immediately gone to Google and started looking up SCN5A. We know that SCN5A, like so many genes, demonstrates varied expressivity, and variable expressivity refers to the range of signs and symptoms that can occur in different people with the same genetic condition. SCN5A is a really fabulous example of this point because the relationship between genotype and phenotype is not necessarily linear, nor is it singular for these patients. Genotype doesn't always equate to phenotype, and phenotypes differ, and this highlights the idea of varied expressivity, which you can imagine for patients and patients' parents when they walk in and read that SCN5A can cause all of these things, can lead to confusion and uncertainty for families. But getting back to John's clinical evaluation, we started our clinical visit with a genotype positive patient who on phenotypic evaluation had a normal echo, normal ambulatory monitor, and whose ECGs were not pathogenic, but did raise some suspicion for that interventricular conduction delay that we saw. John's family history for cardiac disease was negative, and at the time of our first meeting, there had been no additional genetic testing or cascade screening performed on his family members. So what I told the family at the conclusion of that visit was the following. As best as I understood the data at that time, John didn't have evidence of any clear cardiac phenotype, but his ECGs in conjunction with the genetic variant did make me suspicious that we needed to monitor him for Brugada syndrome. But what would this monitoring look like going forward? We discussed the options of a procraniamide challenge, and the family had some concerns about that given John's history of autism and developmental delay, and the fact that this would be a lot for him to undergo. The other option was just ongoing outpatient monitoring, and they elected for that, which makes sense. As all good Saturday calls go, I was sitting in my office a few short months later, and I get a call from the cardiology fellow. Can you call me about a strains ECG that's being sent to us from another hospital? And so at this point, I sat up pretty straight in my chair. And sure enough, John's mother had done exactly as we instructed, which was that John had come down with a vomiting and diarrheal illness, and that morning had spiked a temperature to 102 degrees. With that fever, she brought him immediately to the ER and asked for an ECG be performed, and then she asked that it be sent to us. What you can see here most strikingly is the abnormal repolarization pattern in the early precordial leads. This is extremely abnormal ventricular repolarization, and we've seen this pattern over and over throughout today, so it's not something that's new to you. But seeing this classic type 1 coved shape appearance of the STT wave changes in an 8-year-old boy sitting in an outside hospital with a fever because of what turned out to be influenza, you can imagine caused some consternation amongst the ER staff. So John got admitted to our hospital to the cardiac floor where he was on telemetry for 5 days, and mercifully he had no ventricular and no atrial arrhythmias. Over the course of his hospitalization, his ECG normalized, and this sort of shows you how things normalized over time. And he was ultimately discharged home without any additional medical or surgical interventions. And this comes to the first point of why I find Brugada one of the hardest things to manage, because I just don't have a lot to offer families. And that creates really hard challenges, I think, for parents as we talk about how we manage these kids going forward. But mercifully, John did really well over the next 6 months. But then in the fall of 2020, he started to have other symptoms that were brought to our attention. So in the fall of 2020, John's mother contacted our office to say that John had once again been admitted to the neurology service because he was having staring spells during the day and abnormal movements concerning procedure activity a few times at night just before he fell asleep. He was admitted to the neurology service, and video EEG was performed, and there was evidence that he may be having some absence-like seizures, which explained the staring spells. But unfortunately, any episode where he was having the abnormal movements that the family described before sleep were never captured by video EEG. And this really had my attention because I was concerned that I might be missing arrhythmias. So I recommended to John's mother at this point that he have an implantable loop recorder placed to look for arrhythmias that we were maybe underappreciating on other forms of ambulatory monitoring. What worried me most was ventricular arrhythmias, but we also know that patients with SCN5A variants, and as well as those with Brugada, can manifest atrial arrhythmias and conduction problems. And despite this family's sort of hesitation about intervention in general, they finally agreed to implant an ILR in December of 2020. And John did well for the next year and a half. And then in June of this year, he was participating in a school music event. He was playing the drums and his parents were in attendance to witness the event. And his mother reported that he suddenly seemed to stare off into space, go stiff, lost consciousness, fell to the ground, and demonstrated convulsive movements. This lasted a few seconds, according to John's mother, and she reported this event to be different than any of the other events that she had witnessed to date. He was taken by ambulance to a local hospital near his home, where upon arrival, he was mentating normally. He underwent a full neurologic evaluation, including a head CT, which was negative, and the diagnosis of seizure was made. He was referred to follow up with his neurologist and his cardiology team. John's mother contacted us first thing the next morning, once they'd arrived home, to see if any transmissions had been sent from the ILR at the time of the event. And sure enough, he had this massive 10-second pause, which correlated exactly to the event that he had. So when I opened the ILR tracing and I saw this sinus pause, I remember thinking to myself, where are the expert recommendations for this scenario? I feel like, unfortunately, and somewhat not surprisingly, this is a pretty common theme in my life. As most of us are acutely aware, there are so many clinical situations that we face on a daily basis that don't fit nicely into a flow chart that we can conjure up at our fingers and help us know exactly what to do. Fortunately, there are some recommendations for device, meaning pacing in this situation, based therapy with symptomatic bradycardia. And for me, this is an example of what John had. He had symptomatic bradycardia secondary to sinus node dysfunction that resulted in a serious syncopal event. And this put him into a category of meeting class 1 recommendations for a pacemaker. But the question that John's mom sort of astutely asked was, how do we know that this wasn't an isolated event? Should I really commit my son to an intervention based on a single event? These are very challenging and I think super important questions that many providers, including myself, ask all the time. How much is too much? Am I overreacting? Am I underreacting? Ultimately, John's family felt that they didn't want to incur the risk of any additional episodes of symptomatic bradycardia, particularly because of some of the challenges that John faces with communication. They were acutely aware that he might not be able to ask for help in a situation or that people might not be able to understand him when he was asking for help. And so ultimately, they agreed to have a pacemaker placed, which he had done this past month. So in conclusion, and in keeping with the theme of this section, I've learned many things from this one case, and I suspect John's case will continue to educate me over the coming years about SCN5A and its phenotypic manifestations in children. Some of the questions that I have considered and reconsidered over the past 3 years have been the following. Should I have made a stronger recommendation for procainamide challenge at the initial meeting with this family? Would that have changed my clinical course or the clinical recommendations? I don't think so, but I'm open to other people's thoughts. Should I have recommended that an ILR be placed as soon as the diagnosis of Brugada was made, given this patient's clinical history and comorbidities? Should we have recommended an ICD at the time of pacemaker implantation? And would experts have held off on the recommendation for a permanent pacemaker based on this single isolated event? These are the questions that sort of plague me with this individual case and keep me up at night. Thanks.
So we will have time for questions and answers at the end. Our next speaker is Dr. Audrey Dionne from Boston Children's Hospital. Let's see if I can get this. There we go. Okay, yours should be down
Perfect. Thank you, everyone, to be there. Thank you for the invitation to present. I have a slightly different case than Stephanie presented, but still with more questions than answer at this point. I have no disclosure. So this first started when we were asked to screen the children after the father had a sudden death while driving at the age of 34. He was previously diagnosed with mitral valve prolapse at 16 years of age and had been followed regularly by cardiology. And at his last follow-up, he had moderate to severe MR with a normal ejection fraction. He was asymptomatic from a cardiac standpoint with a normal EKG. He also was pretty active with no other cardiovascular risk factor, normal blood pressure, and normal cholesterol. So initially, there are two daughters that we were asked to see, especially after the first one at an abnormal evaluation by the pediatrician. And when we look kind of more broadly at the family history, the more extended family, we saw that the dad who had the cardiac event had a sister with mitral valve prolapse, and his father had a possible history of arrhythmia, but we don't have any further detail. And then on the maternal side, there was a remote history of neonatal death without a known cause and some cardiac aneurysm, but in great-great-grandparents. So we saw the first daughter. She was evaluated at age 2 after initial testing by the pediatrician was abnormal. She was otherwise healthy with no significant medical history, and she was asymptomatic from a cardiac standpoint. Her EKG done showed WPW, probably suggestive of a septal pathway. An echocardiogram at the time showed a structurally normal heart. She had normal biventricular systolic function. And then she had an Holter monitor, which showed persistent pre-excitation throughout without episode of SVT and without any other arrhythmia. Based on her family history, they elected to do an esophageal study to try to risk stratify her. She had an AP-ERP of 300 milliseconds. Her shortest pre-excited RR interval was 310 with no inducible SVT. So a bit somewhat in the intermediate, but not clearly high-risk category. And despite the lack of SVT, she was started on propranolol at 2 milligrams per kilo per day. And then she was followed yearly. She remained asymptomatic. And then when she was 9, ventricular pre-excitation went away before she reached kind of her 25 to 30 kilo threshold for ablation. But then 2 years later, at age 11, she had an early systolic click. So we got another echo that showed bileaflet mitral valve prolapse with mild mitral regurgitation. And she again had normal ventricular function. And then our Holter monitor showed no ventricular pre-excitation, no ectopy, and no arrhythmia. And at that visit, we saw our sister, who was 8 years old at the time. She again had no significant past medical history, and she had complained over the past few months of an episode of fast heart rate at school, but that was in the setting of fever and intercurrent illness. She had no other cardiac symptom. She had an EKG that was normal sinus rhythm with normal intervals, no ventricular pre-excitation, and normal repolarization. On echo, she did have mitral valve prolapse with mitral regurgitation. She had a borderline dilated aortic root and a mildly dilated left ventricle with normal systolic function. And her Holter was also normal with no ectopy and no arrhythmia. So we just kept following them, both of the siblings yearly with echo, EKG, and Holter monitor. And then I saw her last when she was 10 years old. She was still asymptomatic. Her EKG was normal. Her echo was stable. So we're reassuring. We said we're going to send them an Holter. The family's from Florida, so we send them back to do after their vacation. And when our Holter came back, she had rare atrial ectopy with a 3-beat slow run of atrial tachycardia, but more significantly, she had frequent ventricular ectopy, about 170 beats per day. They were mostly isolated, but she had 4 episodes of non-sustained VT, the longest of which was 8 beats, and the fastest was 168 beats per minute. This was our 12-lead EKG, which really was unremarkable with specifically normal repolarization. And then this was our Holter tracing with our longest episode of non-sustained VT, which occurred mid-afternoon and was relatively slow. Her fastest episode was only 3 to 4 beats, but she had nothing above 180 beats per minute on her Holter. So then I called the mom, who's obviously not in Boston anymore. We have the conversation. Well, she had non-sustained VT. What does that mean in the setting of her mitral valve prolapse and in the setting of her family history? So we started her on Nadolol, 20 milligram, which was approximately 0.6 milligram per kilo, and sent her another Holter to do. And on the repeat Holter, we showed that she was well beta blocked. She had rare atrial ectopy and she had rare ventricular ectopy without non-sustained VT. So that was slightly reassuring. And then we brought them back and had a cardiac MRI. And obviously she had a contrast reaction, so we were limited in images we could actually get, but we did see evidence of mitral annular disjunction with a mild dilation of the mitral valve annulus and mitral regurgitation, although we were unable to quantify it. She had normal LV size and function and no large areas of LGE, knowing that our imaging was suboptimal. And these were MRI images, and the mitral annular disjunction, we measured a gap of 8 millimeter, and there was no obvious LGE. So then kind of discussed with the family, debated what to do, and we ended up proceeding with an ILR implantation to monitor her more closely and continue her on her beta blocker. And then as far as her last follow-up, she had no significant arrhythmia, and she's been doing well. So we thought that her phenotype and most likely her family was arrhythmic mitral valve prolapse. And then if you look at the recent guideline, it says patients should undergo risk stratification to assess their risk for sudden death. But that remains one of the biggest challenge on how to do it and what that means in this population. And they propose this algorithm for risk stratification and management, which is actually very nice and useful because we're rarely provided with that. But there is still very limited data behind those recommendations, and there are still many questions. And I think some of the specific questions in those cases are the finding of mitral annular disjunction. How does that affect their outcome and their prognosis? Also, what does that mean in a pediatric population? Is there a risk of progressive disease? And kind of interesting that the sister first echo was completely normal with no mitral valve prolapse. And I'm not sure we would have kept following her that often if it wasn't from her WPW. And how do we apply the risk factor to this patient population from it being mostly adult-driven data? And then the family history. How does the family history of the dad having sudden death at 34 affect her decision-making? And that was one of the first questions that mom asked me when she heard about the non-sustained VT. She said, is she going to die on me like he did? Which you can't really say no to it. And obviously, you don't want that to happen. So to conclude, arrhythmogenic mitral valve prolapse is recognized as a cause of ventricular arrhythmia and sudden death. And I think we talk more and more about it, I think, over the past few months. The genetic remains incompletely understood, and the risk prediction and best management for prevention of sudden death unclear in this population.
All right, thank you, Dr. Dionne. Next up, we have Dr. Tina Pham from Texas Children's Hospital.
All right, thank you. And thank you for the opportunity to present my case today. So this is a 3-month-old baby girl, former X32 weaker, who has a history of premature closure of the PDA and biventricular systolic dysfunction. After delivery, her right ventricular systolic dysfunction improved, but she still had residual LV dysfunction, which is atypical for premature PDA closure. Thus, with concern for underlying cardiomyopathy, she underwent genetic testing that revealed a heterozygous pathogenic frameshift variant in SCN5A. She ultimately did well and was discharged home from her neonatal period and was referred to follow up with EP as an outpatient. And she never made it to her EP appointment quite yet, but she did follow up in cardiomyopathy clinic where at 3 months of age where EP was called for wide complex tachycardia that was noted on her ECG. And so this is the ECG here. That looks like inferior axis with left bundle branch block morphology. Maybe if you look really closely, there might be a P wave in lead 2, but not quite convincing. But with subsequent ECGs, when the heart rate slowed down, there seems to be much more convincingly atrially driven rhythm, with the rhythm being consistent with sinus rhythm with rate-related aberrancy and a prolonged PR interval for her age. Here's another example of just improved intraventricular conduction delay as the rate slowed down. So we discussed with the family our concerns for Brugada phenotype and did the typical Brugada counseling of aggressive treatment of fevers, avoidance of certain medications that's implicated in arrhythmia potentiation of, in Brugada, and then also to follow up with EP. So before we were able to discharge her from clinic and before the leads came off, she became angry, and this is the rhythm that we saw. So we pivoted our recommendations and admitted her for inpatient for workup and management. So in the cardiac ICU, she continued to have frequent salvos of wide complex tachycardia, and not as convincing here, but she also had salvos of bursts of narrow QRS tachycardia, more consistent with atrial tachycardia. So I'm staring at this for hours and hours. Is it atrial tachycardia with aberrancy? Is it sinus rhythm with rate-related aberrancy? Or is it ventricular tachycardia? So we did place an esophageal probe to obtain an electrogram, and was able to catch a 3-beat run of wide complex tachycardia. And here you see where my arrows are. There are the variable V-A relationship, and the V to V cycle length is slightly faster than the atrial rate, confirming ventricular tachycardia. And so where do we go from here? Is this infantile Brugada, which is very rare? What do we treat her with? So in looking at the literature, this is an editorial that shows the clinical characteristics of 19 patients who have loss of function sodium channel mutations in infancy. These patients are less than 2 years old, and over 90% of these patients have VTVF as a presenting symptom. And 13 of these patients have variants in SCN5A, and 12 out of 13 patients, interestingly, had intraventricular conduction delay. And only less than 30% of these patients had a typical Brugada pattern on the ECG. We also looked at Dr. Cantor's experience with very young children with ventricular arrhythmias and intraventricular conduction delay. Dr. Cantor reported 5 patients with this, and a patient circled here, patient number 4, had a similar frame shift mutation in SCN5A and was maintained on propranolol. He also provided a clinical schema of treatment for these patients that included esmolol, and if there's a response, then transition to pranolol. One patient who had a calcium channel defect responded to the lidocaine, so was transitioned to mexiletine, and then some patients were managed on quinidine, and one required discontinuation due to QRS prolongation. So with this, we started on our anti-arrhythmic journey. That started with esmolol. And with esmolol, there was great response. There was significant improvement in conduction delay, with also improvement in wide complex tachycardia. So esmolol was then transitioned to atenolol, and we chose atenolol due to wanting to potentially avoid sodium channel blocking properties of propranolol. And atenolol, patient did pretty well on that, but still control wasn't perfect. Every time she was angry, there would be more conduction delay and short bursts of wide complex tachycardia. So we decided to add quinidine at really only half of the usual starting dose at 15 mg per kg per day. And with this, there was significant worsening of conduction delay and unclear improvement in ventricular tachycardia, but also Brady episodes, AV Wenckebach, non-conductive P waves, and so this was discontinued after 4 days. Of course, we also trialed sotalol that had more conduction delay compared to atenolol, and also some conduction deficit and maybe an increased VT burden. So we went back to our drawing board of atenolol, but also as a last-ditch effort to see if the patient would have a better response from propranolol based on Dr. Cantor's case report. We started propranolol 4 mg per kg per day, and this compared to atenolol had a little bit more conduction delay and probably comparable VT control. So we opted to stick with atenolol monotherapy 2 mg per kg per day. And so the next step is where to go from here. We have this 4.5 kilo infant who has uncontrolled arrhythmias that includes atrial tachycardia, ventricular tachycardia, conduction deficit, with a phenotype that we know is very high risk. And also, in addition, it's very a socially complex situation where she was the youngest infant of 4 young siblings. The mom worked the night shift and so was rarely at the bedside. There's an unclear understanding from the family of what disease process her daughter has, and also question of potential compliance moving forward. So we decided that she would be better protected by implantation of an epicardial dual chamber ICD. And so this is her film after ICD placement. And notably, she did have elevated RV thresholds on discharge, and she was ultimately able to be discharged after 48 days in the hospital on atenolol. She's not required any ICD therapies quite yet. She's now 9 months old, and no inappropriate therapies as far as I know. I found out yesterday that her older brother also has tested positive for the variant, and the family still has had a few clinic no-shows that sort of speaks to the social complexity of her situation and concern for compliance. And so what I learned from this case, I learned a lot, but more so for our trainees, intraventricular conduction delay manifesting as wide QRS, complex monomorphic ventricular monomorphic tachycardia appears to be the most dominant sign of disease, as opposed to what is observed with adults with loss of function, so SCN5A mutations. And in patients with this Brugada-like phenotype, VT and VF is a very common finding. And frameshift mutations are considered double hits with severe phenotype. And then I also learned the role of the beta blocker, that not only can it control arrhythmia, but also its role in reducing rate-related conduction deficits. What I could have done differently, I think about this picture a lot, where this patient has an ICD generator on one side of her abdomen, and then a separate pocket that includes her ICD lead and pace sense leads that comprises her entire abdomen. So, in the future, could she have feeding intolerance or, trouble with growth? Could she have adverse events from her ICD? I think only time will tell. But I'd love to hear your thoughts and comments on if you would have done anything differently for this patient. Thank you.
Well, I'll invite the speakers back up here, and we'll invite comments or questions, but an emphasis on comments, hopefully from some of the experts in the room here.
Thanks. So they were all great. I really enjoyed all of them. So I guess the question or comments for Audrey, and might as well challenge the Boston person. So in the 2-year-old, what was the thought process or the rationale for doing an esophageal EP study at age 2? And if you were going to find a high-risk pathway at that age, were you going to ablate the baby at age 2, or were you going to do the same thing no matter what the esophageal study showed?
I think that's a great question. And I think kind of when the WPW came up, I think that kind of raised a lot of flags, but was probably unrelated to the rest of the family history and what happened to the dad. I think some of it is discussing with the family the risk of sudden death with WPW and the recent history with what happened to the dad. I think they wanted to gather more data. Not sure how it would have been any difference if we had found a high risk pathway. Maybe we would have pushed her closer to like 10, 15 kilo, as opposed to say, oh, you're not specifically high risk, you have no SVT, let's really wait until you're 25, 30 kilo. That's probably what I would have done differently. I don't know if it was a peace of mind, but I think with all the WPW cases, I think the risk stratification can be hard to interpret. And I think not high risk doesn't mean reassuring either. So.
Dr. Cantor, did you have?
Yes, I enjoyed all of them, and I think they were well-selected cases that all have a lot of educational value. My question is for Stephanie. The story obviously hasn't been fully told on your patient because he or she just got the ILR very recently. So my question is, was there a contemporaneous or a recent Holter or ECG which showed a normal PR and everything in normal heart rate and so forth?
Yeah, so sorry, the timeline wasn't clear. He actually got the ILR in 2020, and the ILR was just recently removed this past month. But prior to the ILR being placed, when he had that event, when he started having these concerns for seizure activity, I'd actually been seeing him about every 3 to 6 months, and he'd had multiple Holters that showed normal PR interval. Even though he was 8, he's only about 22 kilos at the time, very, very small, and he wasn't able to run on a treadmill or do any kind of exercise. So the best thing that we could do was just sort of put Holters on him not continuously, but as many times as he would tolerate, knowing that his autism gives him some sensory issues. But we had had a Holter from a month and a half previously, and there was no evidence of conduction problems at that time.
Yeah, I think high grade AV block with a lot of P's and no QRS is a very interesting rhythm.
Yeah.
And I think that it's not very well understood by all of us. I think we like to blame channelopathies. I think we like to blame sudden autonomic disturbances where there's a lot of vagal tone limited to the AV node. And I think there are rare cases of this being accessory pathway related of some kind, whether it's a nodofascicular fiber, a blind ending nodofascicular fiber, or something like that, which is by electrotonus is suddenly influencing AV conduction down the His bundle. I don't know, but I think that those kinds of patients, unless you can make a really compelling argument for being channelopathic, like there being just a general decrease in conduction. I mean, there's a clear progression of conduction, the disease. I think they need a very careful evaluation.
That's super helpful.
Dr. Cannon.
Yes, so just a comment for Audrey. We reported at Mayo the malignant bileaflet mitral valve prolapse, which when I first came there, I'm like, that's not a real thing, but it actually is a real thing. What we found is it's an intrafascicular reentry between the Purkinje fibers that are there that run up on the papillary muscle. So sometimes they look like a long QT because the papillary muscles are the last depolarized. So we actually found that if you ablate that intrafascicular circuit, but we've seen it occur over time. And so the more it occurs over time and everything else, the more risky it is. But it sounds like a challenging case. And then a comment to your case is when we just wrote the new pacing guidelines, we commented about no pause is really too long to warrant a pacemaker. It got chopped out of the final version despite my objections, but it's always a challenging thing. And, but I also encourage people to think carefully about that because the knee-jerk response of just putting that in and thinking that the syncope is going to go away, certainly if you saw ventricular arrhythmias and everything else. But thank you guys all for your presentations. They were very nice.
So I have one question for the mitral annular dysplasia. It seems like a diagnosis that reaches us rarely, maybe the adults have a little bit more experience with that, but what are if you fail Nadolol, what are the next options and what's your threshold for ICD implantation in that group?
Yeah, and we discussed ICD specifically with this patient, and she was kind of 10 years old where she was small, where it would be a bit tricky, but she wasn't too small to really take it out of the picture. And especially with the family history, it's hard to risk stratify. And I really said, I don't know. And despite kind of all this anxiety, the family was mostly against it and kind of wanted to gather more data first. But I think if the family would have said, can we get an ICD? I would have agreed to it. Beta blocker was kind of an obvious choice. I'm not sure if we've really tested the role of other antiarrhythmic. And I think anecdotally, we brought one patient to the lab for PVC ablation and non-sustained VT. And we didn't have the diagnosis of mitral annular disjunction when she came to the lab, but when they found it kind of around the papillary muscle of the mitral valve, and when they went on the RF, the kid just kept going in VF. And they ended up aborting the procedure and putting an ICD a few months later. So I'm not sure what's the next step after that, or what should be the threshold for the ICD either.
Yeah, Dr. Kane, you had a
I
comment.
think that brings up an excellent point. In our study, we had in fact, we expected people to go into VF when we ablated that. Second of all, it's hard to keep an RF catheter on the papillary muscle, so cryoablation sometimes is helpful. But understanding that it's an intrafascicular reentry, actually flecainide we found to be very effective for that. So that's why I think it's kind of important to kind of think outside the box, because this is kind of a new thing that came up. But yeah, they're very difficult decisions because they have really nasty arrhythmias. And if you try to ablate them, sometimes you can't get them out of VT.
Thank you. Dr. Ackerman?
Yeah, just great cases. I mean, those were fantastic, beautifully presented. Just on the Stephanie, you had your list of questions. So yes, no, or my answer. No, those weren't my answers, but you had I would take the first one, the procainamide. I completely agree. There was no role for the procainamide because the action step was going to be the same.
This patient had reduced depolarization reserve, had a susceptibility variant. You would give them the Brugada precautionary measures. If the Percana test would have shown it, you would have given them the Brugada precautionary measures. So I completely agree with that one. And I think for the mitral valve prolapse one, for those who are interested, it is wide open for exploration. So you have to remember when the syndrome was described by us at Mayo, this was, the portal of entry was you had to be a cardiac arrest survivor. So out of that, all of those patients were first called elsewhere long QT syndrome. And then what emerged was this common phenotype of women with bileaflet mitral valve prolapse syndrome, the characteristic PVC multiform that Dr. Cannon said, and then subsequently came forward this observation of the mitral annular disjunction, or the MAD. So we know exactly what to do if your portal of entry is cardiac arrest and you get this syndrome and you get a defibrillator, and then you get, and flecainide is almost magic potion for this entity. So remember that one, that's really key. And then we showed that ablation bends the curve, but is not wow. What we don't know at all is what happens when we find this phenotype the way you found it. So this is going to be a huge denominator. There's no data that family history is a risk factor in this entity yet. So is it going to be a risk factor like it definitely is in HCM, or is it going to be a risk factor like it definitely is not, like in long QT? So we don't know. And so how aggressively do you treat an asymptomatic, incidental bileaflet mitral valve prolapse woman who has the multiform PVCs and so forth? So Brian and I and others were thinking about, could their EP study be helpful for risk stratification? The answer is don't know. So the point being is for the asymptomatic person who really fits the tetrad, and we do see men with this entity, but it's like 9-to-1 women versus men, kind of the opposite of Brugada in terms of expressivity, is if people are curious about this entity, it is wide open for investigation.
Thanks so much. So I think we've reached our time. We're going to take a short break and then look forward to joining us back here for the afternoon session. Thanks so much.
Okay, everyone, welcome back. We're in the home stretch here. And so we've moved on to the last segment of the agenda, and it's a holistic approach to treating sudden death diseases. And so we're going to see some interesting aspects here. And we're going to start by a talk from Jeanette Strasburger in Wisconsin. She was unable to make it because of an NIH meeting, but she recorded her talk. And so we're going to play that. I don't think she anticipated being so big on the screen.
Hello, everyone. I'm Jeanette Strasburger, pediatric cardiologist at the Children's Hospital, Wisconsin in Milwaukee. And I'm unfortunately teaching a grant writing course this weekend, or I would be there with you. Hopefully I can be there for the question and answer session. And I'd like to thank Marcia and the team at SADS for all that they do for long QT and other inherited channelopathies. I'll be presenting today on pregnancy. And let me see if I can share my screen. Hopefully it will work this time. So I have a few disclosures. You can read them, but I do want to mention that the 2022 Heart Rhythm Society's consensus statement on arrhythmias in pregnancy should be published really soon. We just signed off on the final version of it this past week. It's been 3 years in the making and should be very helpful. It covers both adult and fetal arrhythmias. And also we will be a part of it. Our team, myself and my colleague in Madison, Ron Wakai, will be part of a near-term quantum sensor technology in biomedical applications virtual conference put on by the NIH on January 5th and 6th of this coming year. So pregnancy education and care is really a cycle, and there are two patients, the mother and the fetus. It really rotates between prepartum and postpartum. And when you see the patients in your clinics as teenagers of childbearing age, and this would be both male and female, it's important to begin the process of teaching them some of the tips that I'll give you in this presentation. In the postpartum state, it's also important to recognize that there may be a future pregnancy as well. So it's really a cycle. The pre-pregnancy genetic counseling is really important to determine what the family history is, whether there's been a genetic diagnosis, since prognosis does relate to the diagnosis, and whether there's been any reclassification, because that may actually impact whether medications are needed or not. Inheritance patterns are usually autosomal dominant, but maybe others. And it's important to know what to expect for the inheritance and to recognize that many of these babies are going to be affected with an inherited arrhythmia syndrome, and their presentation in utero will depend to some extent on many factors. So reproductive options before pregnancy are important for patients to realize that they have some potential options, such as pre-implantation genetics, and to be able to go for a fetal MCG test if they wish to. Testing of the baby and the timing of testing is often gone over with the genetic counseling and educational resources. This is just a nice handout here by the group at British Columbia and covers those topics on the right. And I just really like this. So you can Google British Columbia pregnancy and long QT and it should come up, but it's written for the patient. I think it's a very good resource. Prepartum also is important for the obstetricians to go over things with the patient, and that this would include reviewing the potential symptoms that the patient might experience in both the fetus and in the mother if she is affected, discussing medications and breastfeeding. In general, medications shouldn't be altered or discontinued because of the pregnancy, and this is still a common problem. Substitution is also a common problem, and I've seen labetalol substituted for very effective arrhythmia medications, and labetalol really is not a good anti-arrhythmic. High risk OB and fetal care centers are usually the preferred place for the patient to start in terms of the management of the pregnancy, and then of course if the baby is not affected, and that can be shown by FMCG, or if there's low risk otherwise. More alternative care may be possible. Nutrition is really, really important. We actually use these agents to treat torsade in the fetus. So recognizing early on if the mother is low in vitamin D or any of the minerals is important. And then specific situations should be discussed, like what she should do with hyperemesis, since she may not be able to keep down her medications, what to do with ICD events, QT prolonging drugs, and the defibrillator care in general is not usually altered as a result of the pregnancy. So assessment during pregnancy, and it's important to anticipate medical conditions of pregnancy such as preeclampsia and growth restriction. Sometimes growth restriction can occur because of beta blocker therapy. Multidisciplinary care planning is important, and this should involve nurses because they are excellent at communication. And these are often complex pregnancy management strategies, and they should be put in the medical record as well. And close to term, it may be important to have an anesthesia consult and to review the delivery care planning on the chart. Since not everybody is available 24/7, it's important to be on the planning beyond the medical record. A fetal echo is indicated in all of these pregnancies to rule out associated abnormalities such as syndactyly or other conditions to assess fetal growth and ventricular function. Cardiac arrest can occur in the midst of delivery or in the midst of pregnancy. If arrest does occur, these are medications that can be used safely, magnesium, isoproterenol. The patients can be put on ECMO. And in fact, the C-section to deliver a viable fetus is actually a way of improving the chances for resuscitation of the adult patient. So until recently, it was not known that women who have, not just women, but families who have familial long QT are at increased risk of stillbirth and miscarriage compared to the general population. This is a study of 162 patients that Dr. Cuneo put together, and the incidence of stillbirth was 8 times normal, and of miscarriages was twice the normal rate of the general population. Not all of these babies died in association with the familial genotype. And so, in fact, there may be some potential that the gene itself may affect placental function. And this is going to be studied in a research protocol done by Dr. Cuneo in the near future. Mothers and female infants seem to have a higher transmission rate, and we've seen this as well. I'm not sure why. Genetic testing of fetal losses is important to determine if they were affected by the gene. And then high-risk surveillance of pregnancies for risk of stillbirth in the third trimester using biophysical profile rather than non-stress testing is important. And then just when Dr. Cuneo looked at birth weights, the babies whose fathers were affected had a normal birth weight, but whether the mother was on treatment or not, the baby had some degree of growth restriction, though very minor, and really this is not enough to recommend stopping medications. So the other potential is that there are many cases of long QT that are causing stillbirth that are not recognized as being familial conditions. In other words, the fetus is actually the proband. And so in a study by Crotty, 3.3% of 92 genetic autopsies showed fetuses with known ion channelopathies, and 8.8% had the potential for ion channel dysfunction that could have contributed to the fetal demise. And we reported recently in our manuscript that de novo long QT syndrome was much more lethal and potentially unrecognized. I'll mention this later as well. So during the pregnancy, the one question that comes up is Nadolol safe? And this is just published this past month by the group in at the Cleveland Clinic. In 64 pregnancies, Nadolol was found to be safe. It was used in the majority of the patients treated. Growth restriction was seen, but it was no more with Nadolol than with other beta blockers. The infants did not show hypoglycemia or bradycardia, and only one had bradycardia. Nadolol is passed more in the breast milk than other drugs, so this should be taken into consideration. And there were 5 events in their study, all of which occurred in undiagnosed patients, and 4 of the 5 were in KCNH2 patients in the postpartum period. And this occurred up to 9 months postpartum. So it's important to recognize that the postpartum period really extends for quite some time. And these were just their growth studies, but 8 of the 12 that were on beta blockers had growth restriction. In terms of delivery room care and management, it's important to recognize that nursing certification may be lower in patients who are otherwise in the ICU than other ICU settings. So work with your hospitals to see that your nurses are ACLS trained, and then check the equipment because it can be need to be used for both either the mother or the baby. ICD precautions may be needed for cautery. And this is just the AHA algorithm for cardiac arrest in pregnancy, and it would be good to have this posted in your nursing area. So postpartum care, it's the highest risk time that we see. It's especially risky for patients with long QT2. It extends, as I mentioned, and the breastfeeding is okay for patients, and there is a lower chance of transfer of beta blocker in breast milk for both propranolol or metoprolol. So I'm going to switch gears and just quickly go through how do you recognize if a fetus has long QT syndrome. And I would argue that the best way is actually to have the patient undergo a fetal MCG after 27 weeks is the most accurate, but we can do the procedure anytime after about 18 weeks if the patient's having arrhythmias. The patient may have abnormal isovolemic relaxation time, and this has been a fairly consistent finding. The patient may be bradycardic, and that's true whether it's a familial history of long QT or if it's fetal bradycardia that's later found to be due to long QT syndrome, as in this case. And in this particular case, the patients who were recognized as bradycardia would generally be those below 110, which is what the obstetricians recognize as bradycardia. But in fact, we would miss most of the cases of long QT if we didn't use the 3rd percentile as a cutoff for what's normal and abnormal. Second degree and 2-to-1 and 3-to-1 block is seen here with both the FMCG tracing and also the ultrasound Doppler tracings. This is just an example of 3-to-1 block. And I point this out because when you see rates in the 50s, it's very tempting to just assume that this is 3rd degree AV block. But in fact, you can see that there's a stable PR interval with some of these beats. And that's important because if they're SSA negative, these patients, when put on terbutaline, have a very, very prorhythmic response, often with torsade. So do not start terbutaline. And then finally, late PVCs can be associated with long QT. In this case, there's T-wave alternans and late PVCs. And with the T-wave alternans, you can sometimes see mechanical alternans by echo, and that's helpful if you do see it. It's not always present, but if you do see it, it's helpful. And then here you can just see the presence of a late PVC that induces torsade on the lower tracing. So in our series of patients, you can see here that the majority with severe symptoms were LQT3, and they were mostly those that were de novo. The patients with LQT2 often had symptoms, but we did not see any mortality in patients that had a family history, and most all the patients were LQT1 and LQT2. So we did have one patient who was an LQT1 that had a familial gene and also had a de novo gene as well, and that patient did have torsade. So torsade is common. It's often unrecognized because it doesn't look like torsade. The semilunar valves don't open, and so this is, an ascending aorta Doppler, and you can see that it looks more like a bradycardia or a normal rate with ectopy, and so it can easily be missed. It was missed in 7 out of 9 cases, actually 8 out of 10 cases now in our experience. Hydrops is common in these patients, so think of that in patients with undiagnosed hydrops. And the fetal torsade should be treated in utero. These patients shouldn't be delivered even if they're near maturity because the torsade is so poorly tolerated in the newborn period. So the mom can be loaded with magnesium and started on propranolol, and these babies are often more stable in that setting. Other treatments like lidocaine and mixilotine can be added if needed. And withdrawal of any QT prolonging drugs and avoidance of those with an anesthesia for C-section is important. And finally, 100% control of torsade is not needed in order to see the hydrops resolve and to see survival, and it may not even be achievable. So we feel that we do the best we can, but we don't have to have 100% survival. I'm sorry, we don't have to have 100% arrhythmia-free in utero environment. So the prenatal to postnatal ECGs show, MCG to ECG show that the QTC often shortens postnatally. We're not sure exactly why that is, and it's less so with LQT1, probably because they have a shorter QT. Here we can see a 10-minute heart rate trend with the fetal movement shown in red dots, and this baby's in 2nd-degree block, but you can see the tracings where it looks like the rate is really under 200 beats per minute. And so is this tachycardia? Is this ectopy? This is what it turned out to be, and you can see fairly classic runs of torsade in this circumstance. We also see at times more monomorphic appearance when the rates are slower. So you can see both normal rate torsade and rapid torsade, but by echo, they're very difficult to pick up. So in a summary then, mothers with a long QT syndrome require specialized care. They have a higher risk of stillbirth and miscarriage, as do fathers with inherited arrhythmia syndromes. The fetuses have FMCG is very useful for detecting long QT related arrhythmias in these patients, and sinus bradycardia is a common presentation. And when it's there in the familial conditions, it's usually not due to the beta blocker. It's usually due to the baby being affected with long QT. Torsade should be treated in utero to stabilize the infant. Thank you very much. And this is Wisconsin, and come see us. I'm going to stop sharing here.
Well, thank you to Dr. Strasburger. She's going to join us for the Q&A remotely. So if you have questions, save them up. You may need help getting her off the screen here. This one here?
Yeah.
There you go. And that's fine. Okay, got this ready to go. Okay.
Yeah, but I don't know if it's going to show up.
I think so. Close it out. Okay.
All right.
Now we're ready.
Perfect. Next up, we're going to have Dr. Brian Cannon from Mayo Clinic. He's going to come and speak to us about sports restrictions in the era of shared decision-making.
Well, thank you very much, Jeff. Just one comment. I'm glad my face is not that big, or pretty much everybody would be leaving the room. Second comment is thanks to Dr. Kim for a fantastic job. I've enjoyed all the speakers today. They've done a fantastic job. And as many of you know, Jeff was one of the very first fellow I trained, but he's all grown up now, even though he looks like he's 12 years old. Next, I'd like to thank Alice and the SADS Foundation for their dedication to teaching not only physicians, but helping families out. It's a wonderful organization. So thanks to you and all that you do. So thank you very much. And lastly, I'd like to thank some of the true pioneers in this field, Mike Ackerman, Sam Sears, who are in the room, many of whom their articles I'm going to be quoting today. So even though I'm up here, and everybody else in the room who's participated in this process, thank you for all your work. So we will be discussing off-label use of an IC lead in the pericardial sac. So we're going to talk a little bit today about shared decision-making and try to understand a little bit more. I think it's a fantastic word. We always like to talk about shared decision-making, but it's more than just words. There's actually a process. There's actually an idea that goes along with it. And then we'll also recognize the legal pitfalls that may interfere with an athlete to play, because not only are we medical entities, but we also have to think about the legal aspects as well. So what is shared decision-making? Well, in 1982, the Presidential Commission published a seminal report calling Making Healthcare Decisions, advocating for informed medical decision-making between the patient and the healthcare providers that's sensitive to the patient's values and goals. And it generally emphasizes informing patients of their options and supporting patient autonomy. It is not a blanket statement or anything else. And we'll kind of go through some of the subtle nuances, but it's not like, okay, we don't know what to do, so you pick. That's not really how shared decision-making works. And there's a whole process that goes along with that. So in 2016, because most of this time these were around adult end-of-life decisions, but the American Academy of Pediatrics issued a revised policy statement on informed consent, stating that shared decision-making is a central tenet of the family-centered medical home. So as we move forward into practice, especially when there's not clear-cut decisions, we're going to move into the area of shared decision-making. And common features of pediatric decision-making are not completely addressed in the current guidelines for the main reason that the principal person making the decisions is not the patient. They're not making it for themselves, they're making it for kids. So it adds a whole nother layer of complexity in. Well, part of the problem that we don't have a great example is there's a whole bunch of different models. There's over 30 different models, but all of them have these four basic tenets. One is at least two parties are involved. Number two, the information is exchanged in both directions. It's not just one party talking to the other one listening, it's back and forth. All parties are aware of treatment options and what they are, and all bring their knowledge and value-related priorities equally into the decision-making process. So this is not only a knowledge-based thing, it's also a value-based thing. And this was published by the American Academy of Pediatrics. And what we can see is that step one, does the decision include more than one medically reasonable option? Okay, and if the answer to that question is no, there's no shared decision making. If there's only one potential option, but that's rarely the case in medicine, then you can move on to step two that says, does one option have a favorable medical benefit burden ratio compared with other options? So is there something in the medical field that's preferred? And if so, then you go to more of a physician-led thing. So if there is one that seems like it's better than the other, then you are into the physician-led shared decision-making policy, of which if you take a look at preferences, actually, if there's not really a preference one way or the other, that's more of a strong recommendation versus if you lean towards one way, it's more of a weak shared decision-making property. On the other hand, if there's really not a good option that one's clearly better than the other, then you kind of go into a parent-guided shared decision-making, at which point actually what the parent wants and prefers is very important and central into help making that decision. But like I said, this is not a carte blanche that you can do whatever you want to as a patient. There's a careful process that needs to happen. Well, certainly Dr. Sears has done a lot of impact about how do these events, how do these conditions, how do ICDs affect people's psychological well-being? And the answer is quite a bit. And poor quality of life is associated with anxiety and depression in patients with ICDs. In addition, discharges of the device have adverse consequences in patients' psychological quality of life. The younger patients, or the patients that we see, are likely to have more problems than older patients. And what kind of things are people scared about? Well, shock experience, device malfunction, and death. But it's very interesting, if you actually delve into the studies, it's actually not what they were doing when they get shocked. It's actually what I think is going to happen to make me get shocked. So it's really interesting. It's not the fact that going upstairs necessarily causes me to have stress afterwards. It's the fact that if I think I run up the stairs and my device is going to go off, that's actually more impactful than the actual event itself. So what about quality of life in children? We do know that in comparison with a sample of chronically ill children, pediatric ICD patients reported a lower physical quality of life. And they also have a lower psychosocial and physical quality of life than parent-obtained healthy norms. So this is an effect not only with ICDs, but also with heart conditions, particularly those that limit that. In the adult studies, it's been shown actually the biggest concern is, what am I losing that I had before? I could play sports before, now I can't play sports. You know, I could work before doing this, now I can't do that. It's those things that are taken away that are very important. So as we move forward with these decisions, we need to realize that they have a big psychosocial impact on the patient and their entire family. Well, the first question that we ask is it safe? Okay. So my mom sent me this. I don't know what she's saying with this, but the fact is that can we do this safely? And so that's the first important thing, because as pediatricians and people who care for children, the question is it okay to do that? And this is area where Dr. Ackerman has certainly been a pioneer. And this is looking at a study of 494 athletes with long QT syndrome. 16% were symptomatic and 12% had an ICD. Over 2,000 years of follow-up. So significant follow-up, no cardiac related deaths, 6% with one or more non-lethal cardiac events, and 3 with an event where athletes at the time of the event. 0.6% of the whole cohort were related to sports. So if you look at these patients who have long QT syndrome, even though we're concerned about sports and all kinds of different things, actually the incidence is very low, and the event rate is 1.16 per 100 athlete years, and these are non-lethal events. So if you look at this study, it suggests that, okay, we may be protective of things, but we may be doing so in a way that's not best. In addition, you know, Rachel Lampert's group looked at well, actually, Dr. Ackerman's group also looked at a 20-year study of 125 genetic heart rhythm athletes with an ICD. Mean age of return to sports was 19, and there were no sports-associated deaths or reports of sports-related ICD damage. So if you look at this data, it's like, even though we tend to be protective of things, there's really not good data that sports really are that hard on the ICDs. And this is actually a Rachel Lampert study where they took a look at 440 participating athletes and 393 participating in organized competitive sports. 47 were involved in what we consider to be high-risk sports, which are sports possibly resulting in injury or syncope, like skiing or surfing, okay? We don't think of surfing as a high-risk activity. I think people who get bitten by a shark would probably disagree with that, but the fact in general, it's not there. But if you fall off your surfboard and pass out, that can be a life-threatening injury. Same thing with skiing. So all of these things are important. They looked at those athletes and still there was a low incidence. Arm movement sports were played by 76% of subjects, including major arm use like swimming in 39 or 9%, and medium arm use in baseball in 59%. Contact sports, football or hockey, were played by 33% of subjects, and limited contact sports like soccer were played in 42.5%. So if you look at this, there are a lot of athletes that are participating. And our idea before that, gosh, you have this device up here, you need to get in a little hamster bubble and just walk around in that all the time and be careful. It's not true. Actually, they can participate safely, and that's been shown by multiple studies. But there's a couple of things that we have to be cautious about. And so just before we say, okay, gosh, it's safe for everybody to play, there are small groups that we have to pull out of here, and we have to pull out individually and say, gosh, this may be a higher risk. So in the study, if you look at sports with use of the arms and contact sports, were not associated with lead malfunction. So we always get concerned about the arm movements and everything else, but in this study, it didn't pan out. Subclavian axillary access versus cephalic access and structural heart disease were also not associated with lead malfunction. So all these things that we get concerned about tell us it's probably not quite as big a deal as we have. So in this registry, the 5-year lead survival of ICD leads was 95% and not different than most non-athletic lead registries, including the one by Charlie Berul, and not different than any other registry. So if you look at these athletes, even though it's a theoretical concern, that's not borne out in the literature, and it's not what we're actually seeing. So they did find things that were associated with lead malfunction. So once again, we can't just throw caution to the wind. So age at implant less than 21 years, younger age at enrollment, and yearly weightlifting hours. So we always tell people, be concerned about weightlifting. Well, actually, the data bears that out. And so whenever we're counseling patients, we can't just say, oh gosh, you have an ICD, go back and play sports. You have to say, well, you have an ICD, you can consider playing sports, but maybe consider not doing bench pressing and not trying to max out these things. So there are limitations, and there are things that we can set based on the data to make these devices safer and make it less risky to participate. In addition, we've done this technique where we actually put a lead in the pericardial sac and then put the abdomen, the generator in the abdomen. We've had people in full contact sports participate this. This was initially described by Charlie Berul back a long time ago. So thanks to Charlie for all his pioneering work on that. But we've seen these patients be very well protected, and we can actually do it through a minimally invasive approach, which actually has a very nice cosmetic outcome. So the fact is that part of pediatrics is we have to think about different ways of doing things. And we put these devices in one person whose passion in life was to be a calf roper. So, he gets on a horse, he ropes a calf, and then he takes it and he turns it to the ground. Okay. I'm from Texas, I don't understand it, but that was his passion. And so we put this device in, and it allowed him to continue to do that. And he actually did it without a problem with the lead. And this is actually a picture of him. You can't see his cowboy hat, but if you could, you would definitely know that it's him. Well, so if we decide, okay, maybe we're going to do shared decision-making, are there laws that affect things? Are we just free, or are other things that we have to think about? Well, the courts generally recognize national guidelines as good medical practice. However, they are not conclusive evidence of the medical or legal standard of care. So when we say, okay, I'm basing it on the guidelines because if I don't, somebody can sue me, that's not necessarily true. The courts consider it in the decision, but it's not like that is the be-all, end-all law. So a lot of times we'll say, well, you can't play because the guidelines say that, and I don't want to get sued if I let you play and something happens. Well, that's not necessarily the case. And as ideas evolve and as things change, we may actually change our opinion about those types of things. So licensed physicians are held to the standard of care, possessing and applying the knowledge ordinarily used by reasonably well-qualified physicians. So really the standard of care is what would another person in your position do? And a lot of these are not set in stone decisions. They're not black and white. They're very gray. So the fact is that if you can say what you're doing is what a lot of other people would do, that may actually qualify from the standard of care. But this varies from state to state. And one thing to realize is that individuals with a profession who specialize may be held at an even higher standard of care. So if they're coming to see you as a cardiologist about a cardiology condition, it may be that you're held to the standard of care of cardiologists rather than the general community. So it's just kind of important to think about that. And when you're helping make these decisions, make sure that they're based on literature or other things where you can back up your point. Ultimately, the legal responsibility for the return to play decision belongs to a licensed physician, whether that's a team physician or you as a physician signing off. Ultimately, you're the ones who make the decision. And with the increasing presence of medical professionals in the cardiovascular care of athletes, there's a rising concern about the ethical and legal implications of screening, restricting, and disqualifying. There's a whole bunch of things that come into play, including financial concerns, including specific concerns of the athletes. So important things to realize if you're going to go down the shared decision-making pathway is obtaining a patient athlete's informed consent when necessary under the circumstances should be well documented. So if you're going to take one thing out of this talk is if you do decide to go down the shared decision-making route, document what you've discussed. All pertinent risks and benefits of procedures need to be clearly discussed in detail and documented. However, there's a potential difference between the elite athlete and the normal patient. The benefit to the elite athlete is being able to compete in the respective sport at the highest level, but they're going to hear what they want to hear. So you have to be very careful because they're going to cherry pick out what you say, but it's important that you describe what you've told them and the different risks that you have. So you need to have realistic goals. It should be documented that the patient athlete understands the importance of the recommended restrictions and the medical risks prior to attending. So this is not to say that if we say, okay, if you want to go play football, great, you go play football, you do whatever you want to do. You can actually say you can play football, but I don't want you to do this. I don't want you to be having contact sports where you can, contact where you can hit your shoulder. You can put restrictions on them. That's not a good example, but you kind of get the idea. This is not a carte blanche. You go play football. All right, you made your decision. Not my problem anymore. You can say, I want you to do this. I want you to do this. I want you to drink plenty of fluids. I want you to drink electrolyte drinks. I want you to do all these other things, and that will make it safer for you to participate. And that is fine to do. It's not a carte blanche, release you from everything. It's you can put specific restrictions and limitations on those athletes and say, okay, I'd like for you to do this. I'd like for you to not do this. So let's go through a couple of the case examples. So during a pre-participation examination of a community basketball player, abnormal findings of a heart murmur and 2 prior episodes of syncope led to performing an echocardiogram. The patient was subsequently diagnosed with hypertrophic cardiomyopathy. However, the sports authorization clearance form was signed before the echocardiogram and diagnosis of hypertrophic cardiomyopathy had been completed. The athlete died 6 weeks later after playing basketball. So basically went to a screening. They said, you have something, but I'm going to sign your form off and you come back later and we'll fix that. Well, this athlete actually passed away, and the allegation of inadequate screening was settled out of court in favor of the family. And the adherence to the screening guidelines and prudence would suggest that the final medical clearance be withheld pending the results of the diagnostic evaluation. So these things that we do, signing forms and everything else, you have to be careful because if there is a legal ramification that can happen even down the road. And this is the case of Hank Gathers versus Loyola Marymount, where the sudden cardiac death of an elite college basketball player, likely owing to an inflammatory cardiomyopathy, was alleged to have been influenced by a reduction in beta blocker dosage to a non-therapeutic level to allow him to compete without medication side effects. So basically, what the family alleged is that his beta blocker dose was lowered so he could play basketball at a higher level. And the court said that's not a good idea. So actually, the court sided in the side of the Gathers family, and it illustrates that in addition to appropriate disqualification, one needs to be aware of competing interest and outside pressures that may influence things. So if the families, so if you're like, well, I'm not taking the beta blocker because it's making me feel bad. You can't just say, well, okay, fine, then don't take your beta blocker, because actually you'll be on the legal hook for that. Okay. Ultimately, you can't control what people do, but you can control what you recommend. And if you recommend that they decrease their beta blocker dose and then something happens, you can be held legally liable. So once again, it's not a carte blanche decision and shared decision making that you can do whatever you want to. You can put specific goals and restrictions on that. And also, if you're changing it because of the athlete's ability to play or other reasons that are not medically indicated, you may be held medically liable. And this is a case of Knapp versus Northwestern University, who I'm sure many of you are familiar with. But basically, Knapp had a cardiac arrest while playing basketball, had a defibrillator implanted, and then Northwestern said, we're going to honor your scholarship, but you can't play. So this went through the legal system and everything else. And basically what the legal system says is that he didn't qualify under the Rehabilitation Act. So basically, the university can ultimately make a decision. So even though we make these decisions and put things into place, ultimately universities and other people have the power to say, yes, you can play, no, you can't play, applies to governing bodies, applies to everyone else. What about waivers? It's okay, hey, here's how you play. As you sign saying that you won't sue anybody if something bad happens to you. Well, that's really kind of a thing that is not well described within the legal literature. And it's important to disclose all the risks of potential participation. And there's no good legal precedent that forces a school to accept signed waivers. And in addition, even if they sign it, you may still be on the hook. So if you think that the patient can say, oh, well, it's fine, I'll take full responsibility for this case, the law says that may not be the case. So we have to keep things in perspective. And this is a thing says, sometimes I feel I have the worst job in the world. Yeah, right. So if you take a look at things, first of all, if we look at car accidents, suicide, and homicide, the death in kids is high versus athletic sudden cardiac death. And it is up there. It's this little tiny microscopic red line. It is there. It's a real thing. It's a tragic thing, but it's a small percentage of what we do. And in addition to that, if you look at that, every child should be screened for potentially dangerous cardiac conditions. We shouldn't just limit this to athletes. Sudden death is 8-fold more common in non-athletes than athletes. So Dr. Valdes helped write this AAP policy statement, basically saying, if you're going to screen, fine, but screen everybody. Don't just limit this to athletes. So how do we made these decisions in the past? Well, we go to the guidelines and say, what did the guidelines say? And then you're just like, okay, that's what I'm going to do, and that's what I have to do. Well, not in the current era, that's not the best way to do things. So hopefully a new paradigm, and this is based on a People Public website about Jared Butler, who was diagnosed with hypertrophic cardiomyopathy at age 17 when he was getting ready to play college basketball. He went on to win a national championship at Baylor and be named the Final Four most outstanding player and drafted 40th overall in the 2021 NBA draft. And his mom basically said he's been playing ball ever since he was 5 years old. I wanted to see him live out his dream, and he's done so successfully and actually started this website for hypertrophic cardiomyopathy awareness. This is all public knowledge available on the web. But the fact is that we have to think about things in a different way. And the way that we did things before is nice, and the guidelines are nice, but all of those have to come together, and we have to think what's the best thing for these people. So thank you very much for your time and attention.
Thank you, Brian. I can't wait for question and answer, mainly because I want to see if Brian's feet hit the ground when he sits on this stool. But next up, we have a great talk by Greg Webster, who's here from Lurie Children's. He's going to talk to us about using big data to advance care beyond the local center.
Well, thank you all for having me here, and thank you for SADS for inviting me and the organizers for making this happen. It is nice to be here at last. I'm in a session called the holistic approach, and it's sometimes a little bit hard to give a holistic approach when we think about big data. So I am going to try to do that. I'm going to try to fit into the rest of the session. And I have been told that the one thing Hollywood loves to do is make movies about itself. And so to capture our attention, I am going to talk about us for a while. There are lots of folks here, some of whom are physicians, some of whom are researchers, some of whom are family members, but a disproportionate number of the people who are here are from PACES. And PACES is the Pediatric and Congenital Electrophysiology Society. Dr. Cannon put it up on his title slide that he's the past president. He's led us before, as have other people in the room. And I'm looking at Prince and Charlie and many of the other folks that have been involved. And this is data that I pulled from public data sets. So PACES publishes their public data set of folks who are enrolled. And you can look all those people up on PubMed. And if you do so, this is what you get. You get a linearly increasing publication record from PACES over the last 40 years since 1980. And if you look at the y-axis, the number of publications hovers now about 80 or 100 a year. So it's not an overwhelming number of people. Or sorry, it's not an overwhelming number of publications. And we often in our community cite this as a bad thing. We often talk about how small the pediatric community is and how small the numbers of studies are. But in another way, it's a good thing because it allows every individual practitioner to assimilate the amount of data that's out there and develop their own data assimilation of how to treat these diseases in a very different way than if you're an adult who's taking care of coronary artery disease. And there are literally 100 publications a week that come out on coronary artery disease. We have the ability to wrap ourselves around that a little bit more succinctly. And I'm going to show that. So we don't look at bibliographic methods very much in our usual talks, but they are a big data way to represent data. And I'm going to talk about it. So I just took the data that I showed you. And not only did I download how many publications there were, but I downloaded who are they, who did they publish with, who are the other co-authors, and where are they from? Where is their center? And this is a distance-based visualization. So every node is an author and the edges are connections. The distance on the page between two nodes approximately indicates the relatedness of the nodes. And edge connections are normalized for popularity, which means that if you're Dr. Ackerman and you are an order of magnitude of publications above the fellow that just graduated, nonetheless, you don't have to go to Milwaukee to see the fellow's dot. They're normalized so it all fits on the same screen. And this is our PACES network. So this is literally the people who have been involved in PACES. And the interesting thing is that the data analysis chooses clusters. I don't choose clusters for the data. The data analysis process tells me where people are clustered together. And these colors are those clusters. And I'm not going to go through every one of them, but I think there's some illustrations here that are important. So Washington, D.C. has one big publisher. That person is probably a fellow. It's probably not Charlie Berul, but it could be Charlie Berul, who is right in the middle of a lot of other networks. Washington, D.C. has a dominant publication engine that is extraordinarily closely related. Canada likes to publish with itself, right? Canada likes to publish with other people from Canada. The green area is all together. Doesn't mean they don't publish with everybody else, but it is a network that is a little more centralized. Similarly, the Bay Area, which includes Stanford and UCSF, there are a relatively large number of researchers, and they are the background of this. They publish with a lot of people. So this is a cute picture, and it's interesting, and it tells us something about ourselves. But there is something important about big data here. This is a network. Oh, Charlie, I was just talking about you, man. Charlie uses the bathroom too. So this is showing the difference between two networks. The left side is the PACES bibliographic network, and the right side is a relatively famous bibliographic network by Van Eck and Waltman that shows the relatedness between scientific publication fields. And what's really important about this diagram is you see huge gaps in the bibliographic network when you scroll out a little bit, and you see very few gaps within the PACES bibliographic network. What that tells us is that we are tightly interrelated with each other. If you learn the data within our field, you very rapidly become interconnected to other data. And that's not based on me saying, I really like SVT and I really like learning about long QT syndrome. The data suggests that we are very tightly linked. And that puts us in a major advantage. We have the ability to synthesize the data that our field produces and to have each individual practitioner have a more careful view of the data, to assimilate their data in a bigger way that is extremely challenging in fields that have to pull from very disparate areas. Does that make sense? So these are quantitative data about how our field has advantages as well as disadvantages. Because now I'm going to pivot to some of the ways that people have talked about big data. And it is really common to put on a hair shirt and talk about how pediatrics can't do big data. But I'm trying to put this talk in perspective and say, we have advantages that other people don't have. So let's take advantage of those advantages. So I'm going to do that by talking about layers. I'm going to talk about how we get data, how can we get more data, can we analyze data bigger and better, and then because I feel lucky to be invited to SADS, I'm not going to miss the fact that genomics is a critical piece, so I'm going to layer the genomics on top of it. So how do we get data and can we get more? Well, most of us start with single center studies. This is not a SADS related disease, but this is a paper from 1988 where Dr. Weinlein looked at 32 patients who had post-surgical heart block and plotted the rate of recovery of post-surgical heart block. There have been 13, 18 more papers on this, but we learned 90% of what we know on post-surgical heart block from this figure. If this is the only figure you knew about post-surgical heart block, you know enough to take care of most patients with this disease. And so this idea that single center studies are necessarily bad, that's not necessarily true. It is the foundation upon which we build a lot else. So how do we go up from one level? Registries and multi-center data, whether you look retrospectively, whether you look concurrently and prospectively, whether you set up a prospective trial, conceptually, this is that up one level. The International Long QT Registry was established in 1979. Our fundamental understandings about risk stratification in this disease came out of that registry. Our fundamental understandings about genotype and phenotype came out of that registry. And there's now over 1,000 long QT probands and 7,000 members. There are others, but this is an example of a registry doing meaningful things to make our field forward. When Dr. Ackerman and Dr. Crotty and Dr. Schwartz decided to think more systematically about calmodulin, the first thing they did, or one of the first things, was to develop a calmodulin registry. And the first paper that came out of it had 41 authors and 22 centers because people said, yes, this is a good idea. This is how we should learn more. So these ideas of how to enlarge our data are not necessarily, just because they are older, they're not necessarily bad. And this is the Cardiac Networks United, which is a registry of registries. Sarah Pasquale and others have led this out of University of Michigan and CHOP and some other locations. But basically what they're trying to do is take networks that already exist, identify the data fields out of the data dictionaries that overlap one another, and create data repositories that take advantage of that. So this is kind of that next level of data size, taking this idea of single center studies, taking this idea of registries, and then compiling them together. And finally, the biggest data sets we tend to have are administrative data sets, whether you call those administrative data sets in the United States, which I've shown here, or administrative data sets which are de facto countrywide, Denmark, England to some degree, Australia. There are countries that have made this their de facto method. And I'm going to talk about one particular paper. I'm going to use this in 2 slides to talk about both strengths and weaknesses of administrative data sets. So this is a paper that just came out. I chose it because it's brand new and out. And it looked at 1.3 million cases, the majority of which were adult, but in pediatrics as well, from the KID, the National Inpatient Sample, the National Emergency Department Sample, and they were interested in pediatric heart failure. And in particular, they looked at 2012 versus 2016, and you see on the graph that the number of emergency visits for heart failure is going up and the number of hospitalizations for heart failure is going up. And the other reason I picked this is because the hospitalizations, despite having 2 lines that are close together, are statistically different because these are big numbers. If you get big enough numbers, you can start to say those somewhat similar lines are actually statistically different from one another. But what did we learn from this study? We learned an interesting factor that heart failure is going up. But then when they used those same data sets to decide what are the associations with pediatric heart failure, these are their top 3 findings: congenital heart disease, arrhythmias and conduction disorders, and cardiomyopathies. But one of these things is not like the other ones. Congenital heart disease and cardiomyopathy are probably causing pediatric heart failure. Pediatric heart failure is probably causing most of the arrhythmias. It is far less common to have PJRT that gives you heart failure than it is to have dilated cardiomyopathy and have PVCs. But registry-based methods can piece that out because you are learning that from a research standpoint. Administrative data sets can only show association, and it's extremely difficult to piece out causation in administrative data sets. So even though they're very big, it's a challenge to create causality. And here's an example of a very big data set that nonetheless can't piece out those differences. And these authors got that. This is in the manuscript as well. I'm taking this, but I'm not suggesting that they missed that point. So if you go to an MPH program or you go to medical school, they will teach you about this is a randomized control trial, this is a case control trial, these are the ways to gather data. But in the big picture, no matter what you call the trial, these are our 3 big scales. Either we do single center data where we have extreme control of our own data. We do multi-center studies, whether we call them a registry or a prospective study, or we look at administrative data, no matter how big that administrative data is. Those are the primary ways we gather big data. So can we analyze data bigger and better? I want to thank Mike Ackerman for standing up here and telling us how he was not going to overlap any other talk so that he could definitely overlap this talk. So I appreciate you stealing the thunder out of the next 3 slides with your own data. This is Dr. Ackerman's data. So maybe big data is what you do with it rather than where it's from. This is a great study. He walked us through this morning in detail, and I am actually going to go a little faster through this because he did such a great job. But this is an AI-based neural network to detect hypertrophic cardiomyopathy from an ECG. This is single center data derived from the Mayo Clinic, training set, validation set, testing set. And the model discriminates hypertrophic cardiomyopathy from normal. It does a pretty good job of that. This is one figure. This is not probably the figure that people who are most interested in AI and AUC criteria would choose to look at, but for our purposes, I think it does something interesting. It says that on the left, the model outputs a very high probability of hypertrophic cardiomyopathy, and in fact, those people tend to have hypertrophic cardiomyopathy. And when the model outputs a very low percentage of hypertrophic cardiomyopathy, there tends to be a very low percentage of hypertrophic cardiomyopathy. And in this particular study, when they tweaked their output variables, they could get the positive predictive value down to about 1%, which is terrific in an AI-based model. Is it ready to go to the whole population? Dr. Ackerman already answered that question for us. It's not quite ready yet, but it is getting there. The thing about this model that is so important that he mentioned, and I want to just underscore, is that they have then gone and tested it in Korea. They have gone and tested in other populations. The problem with AI models is they are opaque to the outside user. And so it is extremely difficult to know whether it's predicting what you think it's predicting. If you look at the Seattle criteria, these are criteria that we have gotten very familiar with. Our group collectively takes advantage of an enormous amount of learned history, that bibliographic network that I told you, to understand about how to interpret what interventricular conduction delay really means. But an AI model tells you nothing about that. And so if you train the model on a certain population of data, and then you try to apply it to a population of data that doesn't match that, you can get very different results. And although there are ways to blind the model as you do the AI to certain cohorts of data to get a sense of what it's sensitive to and what it's not sensitive to, it turns out that you could end up trying to apply a population model to a population that wasn't used to train the data and end up with wrong conclusions. And what we've learned in genetics is that that can happen, especially in ethnicities and in small areas of the population who aren't necessarily usually included in big data analyses. And so AI models are susceptible to that as well. Doesn't mean they're not worthwhile, but I think this idea of once we develop AI models, looking for ways to test them in very wide variety of data sets is really important. Finally, we're at the SADS conference. It would be silly not to talk about genomics. So this is some work that we did, the Northwestern Sudden Death Network, and this is a population of deaths that occurred all over the United States, and medical examiners and coroners referred these cases to us. And among these deaths between age 0 and 41 years of age, 45 years of age, about 15% of decedents had likely pathogenic and pathogenic variants. This is not very interesting. This is data that has been shown over and over again. If you take groups of people who have died suddenly and you go searching for pathogenic variants, you're going to find it in 15 to 20% of the population. That is relatively a small data approach. But there's a ton of information that variants of uncertain significance encode data. The amount of disease that we explain by pathogenic and likely pathogenic variants is relatively low. And so people have been looking for ways to understand, do VUSs encode data in a mechanistic way, in a big data way. So here we did a genomic approach, and we did automated filtering for rare protein altering variants. And you can define what rare protein altering variants are. And then we normalize those to transcript length. You would expect more rare variants in the big ryanodine receptor than you would find in the very small gene transcript that's encoded by KCNH2. So we normalized it to the size of the gene. And then it turns out that some genes seem to be more tolerant of missense variants than other genes. And so we then normalized it to the missense z-score in NOMAD. And then without us telling them what we expect to see, we asked the algorithm to come back to us and say, where do you find the highest burden of variants? Where do you find the highest burden of missense or potentially deleterious variants? And if you look at the top of this heat map, Dr. Delmar showed us a heat map that was based on transcripts. This is a heat map that's based on genomic data. The genes that pop up at the top of that heat map are genes that we would expect to be implicated if we're going to see sudden deaths. The SCN5A, filament C, the ryanodine receptor. It suggests that there is signal that is embedded in these VUSs, and this heat map excludes any data out of likely pathogenic and pathogenic variants. So this is a bigger way to approach, or a bigger data way to approach this same idea of how do we determine sudden arrhythmia death. The NIH CDC Sudden Death Network that was started by Kristen Burns, or was led by Kristen Burns and Heather McLeod, that Prince has been involved in and others in this room have been involved in, ended up looking at sudden deaths drawn from a number of registry awardees among the United States. And so together with Utah, we said, well, if we see signal in the heat map for sudden deaths in the Northwestern cohort, when we look at this predefined cohort and look in young people, the median age here was less than a year, so these are infants, can we in a more quantitative way explain how much that variation differs? So here we used the GEM methodology that Dr. Tristani, Dr. Yandel, and Dr. Etheridge developed at Utah. And they use a human phenotype ontology to do genotype-phenotype correlation, and it gets iterated by individuals. And in particular, we looked at 2 cardiac panels and 2 epilepsy panels. And we compared those against a group of housekeeping genes that we think are totally unrelated to sudden death, genes that we pre-specified that we said, boy, something would have to be really wrong for this to somehow be implicated in sudden death. And then we said the same thing. Now we want to walk through these individuals and we want to do it statistically. So I'm sorry, the screen didn't show me what I thought it was going to. So the big picture is we asked this model, count how many rare, potentially disruptive variants each genome has, and tell us where we would expect to find those in a panel approach. So these are in infants, and this is the z-score of the probability that we would find missense variants in each of these groups of panels. And so the z-score is normalized to 0. The peak has to be at 0. That's what a z-score does. And then on each side of 0 is the normal distribution. And the housekeeping genes appear right around the tip of 0. So the housekeeping genes have no more rare protein altering variants than we would expect. By contrast, epilepsy genes and cardiomyopathy genes, cardiomyopathy and cardiorhythm genes, which are respectively in squares and circles, have a z-score of 8 to 15 on how much burden of rare deleterious variants they have. This is a quantitative way to look at that same heat map that I showed you, or a different quantification of the same heat map. In other words, what we see by using this big data approach is that there are encoded risk factors that we are not capturing by thinking about pathogenic and likely pathogenic variants. So this is where I started. I said I was going to talk about big data. I was going to talk about how we got data, whether or not we could analyze the data bigger and better. I want to talk a little bit about the genomic side of that as well. But now I just want to talk for a second about the foundation bedrock here. This was a holistic talk, and I think I would be remiss if I didn't talk about the elephant in the room. Big data is already here. It's just not being used in research in channelopathy. It's being used by hospital administration. That's where healthcare is most strongly impacted by big data right now. During COVID-19, the health analytics market had a 9% increase in revenue from 2019 to 2021. In other words, the analytics market bounded during COVID, not just in COVID-related items, but in healthcare across the board, as people realized we needed data. And supply chain management is extremely dependent on big data. RF coding for durable goods and consumables, automated Pyxis ordering, just-in-time delivery, a lot of us in our own hospitals are seeing the downsides of what happens when this big data management structure starts to go awry. All of a sudden, we are missing the things that we need to put into our patients. That is not necessarily a failure of Ed, my best friend who puts the stuff in the Pyxis system. That's a failure of big data, right? It's a failure to successfully deliver the end product into the hospitals for patient care. So this is another way that big data is impacting our day-to-day ability to take care of patients. This is based on data from Grandview Research, and this is the projected compound annual growth rate from 2020 to 2030 based on the consecutive data from 2017 to 2020. And as is true in almost every time you ask a data analysis firm to project the next 10 years, they tell you it's going to grow like crazy. What I find particularly interesting about this is not that it's going to grow like crazy, it's that the 2020 actual healthcare analytics market, big data in healthcare, was $10.1 billion in 2020 by measured numerics. So we are talking about the amount of money we are spending to understand big data in the research sphere is dwarfed by the amount of money that is being spent to consider big data analytics across healthcare. So I was asked to take a holistic approach. So I'm taking this last slide to say, if we think we've got the market cornered on trying to think about big data, it is nothing compared to the guys who are trying to get catheters into your catheter bill. You are what you eat. And in this case, what you are eating is data. And so this process that you learn in first year of medical school, first year of fellowship, first year of your MPH program, that how you get data matters, we are not going to entirely solve that just by using AI algorithms. AI algorithms are great. They are the future. We are interested as well. But nonetheless, if you can't get the data, there's a cap on how smart you can be by asking computers to analyze that data. Single center studies networked by people remain important, and the people part of PACES and the SADS collaboration with PACES has been an enormously strong piece of getting us to understand more about these diseases, and I see that continuing forward into the future, and I'm honored to be a small piece of it. Registry data, registries of registries, administrative data sets, those things will continue to be important, and I don't see them going away. Improved analytics, this is the future of analysis, and I think we will continue to see more of it. And then there will continue to be financial drivers of healthcare profit. I appreciate it, and I will sit up here and let my feet dangle while Dr. Cannon sits with his firmly planted on the ground.
Thank you, Greg. Great talk. Next, we have Dr. Dominic Abrams coming back again, and he's going to give us a talk on building a family-focused arrhythmia center of excellence.
Thank you again for the very kind invitation. It's great to be here. And my job is to tell you about my experience of building a family-focused arrhythmia center. And this is very much something that's been an evolution. I first gave this talk back in 2016, and when I looked back at the slides recently when I was writing this talk, they were very, very different to what I'm going to tell you today. So all these things evolve over time. But I think it's very important to note that all these things are very contextual and very much localized to any one place. So I'm going to tell you what we've done in Boston and how that's evolved and worked over time. But things work very differently in different cities and different countries. And certainly some of the things we did in Boston, I could never have done in London and vice versa. So it's all about sort of finding something that works for you and has contextual relevance in terms of building a center. No real relevant disclosures for this. So I thought I'd start with a little quote. And this was something that was said to me, I think around 2004, 2005. Bill McKenna was my boss at the time. I was working at UCL, and he said to me, "You can't just do long QT syndrome." I thought that's a bit unfair because I quite like long QT syndrome. It's really interesting. But he told me that's what you had to think beyond long QT syndrome. And Bill, as ever, was very right in that. Because if you think of what cardiovascular genetics has become, this is the sort of description I've used many times. This is a great document. It was published in 2009. It's not the most thrilling read in the world, but it's a very good framework for setting up centers. There's a lot of numerical statistical data in there. And it's extremely helpful. And it brought in multiple stakeholders around the UK, where, of course, we have a nationalized healthcare system and funded from a single source. So they define the different areas of cardiovascular genetic disorders into different groups and how we think about them. And that's something we've very much used as a framework. But if you think about what things look like now, if you take those 5 groups, Bill was absolutely right. You can't just do one little piece in isolation because these things are now so interrelated and so connected. Arrhythmogenic cardiomyopathies are now very much, many of them are hybrids between the 2 entities. We see, as we heard this morning, a lot of arrhythmia onset in the cardiomyopathies before we see the classic structural changes. And now, of course, we're seeing many cardiomyopathy genes being found in sudden death cases where there is no autopsy findings. And atrial fibrillation is increasingly known as a manifestation of many of these cardiomyopathy genes. Cardiomyopathy and congenital heart disease, again, overlap with many different genes implicated in both. We see cardiomyopathies in aortopathies, as well as arrhythmias. And again, we heard from Audrey this morning, from Audrey earlier, about mitral annular disjunction, mitral valve prolapse syndrome. And many, of course, I'm sure many of you have seen the patients in clinic where there's a sudden death in a 39-year-old male. He had some coronary artery disease. There's 3 kids. How do you relate that to everything else? Is this hypercholesterolemia? How does that sort of involve the whole system? So when you put it together, you have to sort of think about this very holistically, very broadly. So that's what we try to do. And obviously it started from very small beginnings. But in June of this year, we launched the Center for Cardiovascular Genetics at Boston Children's Hospital. And that was a wonderful thing to become because a center is a hospital recognized entity. So it means we had buy-in from the wider institution and they believed in what we were doing and believed this is an important area for them to invest in. I think it's very important to understand what's your mission. What are you trying to do? What are you trying to become? What value are you trying to deliver to the community that you serve? And then also sort of blue sky thinking, what is your vision? Where are you ultimately trying to take this? What ultimately are you trying to become? But as well as understanding those things, you really need to define what is your business model. And if you think of that relatively crudely, it's like, how are we going to make money here? Because ultimately, any clinical entity has to have a revenue-based thing to support itself. So this is what we came up with. 4 different features, and I'll go into those in different areas. A family-based center, I think, is fundamental. Personalized, cost-effective care. Defining the genetic and molecular basis of disease, and then ultimately developing new therapies and commercialization of those. So starting with a family-centered care, I think this is incredibly important. We're very, very fortunate that Children's and the Brigham are connected by a bridge, which is about 20 yards long. So we're very, very close to them. I do clinics in both. I'm dual trained, which is very nice, so I can see different members of the family. But we've really found that having that very close relationship and we discuss families together, we see them together, is incredibly helpful, not only in understanding the family, and also in using the family itself as a powerful tool to define the genetic findings, but also it's exactly what the families want. We've actually had people in tears. They were so happy in clinic because we were all in the same room together. And this again comes from that document I showed you earlier. And it was one thing that the family groups really, really pushed. They wanted to be treated as a single entity so the family becomes the unit of care. If you think about different reinforcing volume or reinforcing loops within a clinical entity, I think everything really derives from patient volume. So you want to get your patients together, build the volume as much as you can, because that drives many of these things. The more patients you see, the more your expertise goes up, your outcomes and your patient experience gets better. That leads to driving research. And obviously, when you become more expertise, you become more efficient in what you do. That drives down healthcare costs. And so all these things constantly reinforce. But I think the value proposition that we try to drive towards is that this is built on very high volume specialist clinics. And so we've really tried to work towards gathering the patients and making it attractive for patients to come and see us. When you think about defining the genetic and molecular basis, this can span, and these 2 examples work from our team, very much from the bench side and basic science through to more population-based. But I think it's extremely important when you're thinking about translational research to make sure that all your goals and aspirations and what you're doing, your strategies are very much aligned. Because if you've got a big population of long QT patients that you're seeing and all your research is in aortopathies, then you're definitely not going to be sort of maximizing your performance and outcome. So very much important to have communication. We have regular meetings between the scientists and the clinicians to really make sure we all understand what the other are doing and how we can move things forward. And then I think commercialization of new strategies is going to be increasingly important for multiple factors, but ultimately, this is how we're going to get new therapies out there that ultimately benefit patients. Many of you will know this story. This is Spark Therapeutics. It was a spin out of CHOP, and you can just see the timeline. It was first published in 2009, their initial results, and this is gene therapy for retinal disorders. And you can see over time how that evolved, and it was hugely to CHOP's credit that they sort of invested in many different ways. And then ultimately there was an FDA approved treatment which moved out very quickly. But I think that's going to be increasingly important, and finding ways that these wonderful scientific discoveries can be got out there and actually used to benefit patients is it going to be extremely important going forward. And I also think that we can't speak highly enough and importantly enough about the relationship between the patient community and those in working in both clinical medicine and translational science. And of course, we're here today with the SADS community, which is fantastic, and we can only hope that this continues and grows. This is an example from another entity, the Cystic Fibrosis Foundation, and you can see that this is a sort of summary of 20 years of their, of the last 20 years of their existence. But I think I just want to draw you to this box over here on the left, because really what drove all of this, what drove gene therapy and individualized therapies in CF, was that from the sort of 1950s and 60s onwards, the CF Foundation drove these registries that Greg was just speaking about. They got people on board, they drove centers of excellence, and that really was the absolute bedrock of driving these new therapies and giving them the funds to able to invest more and more and more. So I think that's really sort of very, very key to what we're trying to do ultimately. And I think it's really important to understand the ecosystem in which you exist and in which you work. There are many, many different stakeholders or players within that ecosystem, and it's really important to know who they are if you can. Easier said than done in many situations when you're in clinic at 6:30 in the evening. But try and get out there, meet them, understand them, because they will be really interested in what you're doing. People love to hear about this. They love to know about it. They read about it in the press and want to know what's happening in the hospitals that they can relate to because they're in their city or in their region. So sort of think about all the different players. So we're very lucky. We were very nicely funded by a philanthropist, and I've really sort of learned so much from him in so many ways, and just speaking to him, and I sort of put questions to him that we're trying to answer. And he just comes at them with a very, very different perspective. So there's huge value for me in learning from him just because he sees things in a very different way, and he's not medical at all. So, but he just asks us very challenging things, which is just, you know, a really great way to think about things. So know who that ecosystem is, go out there and get involved and be part of it. But ultimately, if you're going to build a center of excellence, you need the people in it to be excellent as well. And I think this is a really, really important component of it. If you think of any sporting outfit, you know, everything is gauged towards the performance and the skill set of those individuals to make the output of that team optimal. This is our team at the moment. There's, as you can see, a number of individuals which we sort of subdivided by the areas in which they work, and really making this center was just bringing all these individuals together. So it wasn't bringing in new people. It was just a logistics exercise to try and get everyone on the same page, aligned and working in the same way. So we obviously have regular meetings. Our clinic is all the same. We're all in the same place so we can interact, and patients can benefit hopefully from that. So different providers can be involved at different times. And again, of course, on the left of the screen, you can see we naturally interact with many other entities, both within cardiology, cardiac surgery, and beyond. But we like to sort of try and work towards creating a high-performance learning organization, and that's sort of a phrase that's used quite a lot now, and I think it's increasingly important because, again, if you want that excellence in your center, you really have to get the excellence out of the people. So just think about it. Organization has a higher purpose. Do the people in the organization know what that is? Can they define it? Does it align with their values? A culture of constant improvement by learning, high employee engagement, and then very importantly, leadership that sort of is also aligned with those values and behaves in that way. I think that's very important, and the sort of control and command days are well behind us. And then a practical approach to drive that behavior that enables people to feel valued, and that's again something I'll come back to in a minute. That leads to different things: psychological safety, self-determination theory, and positivity. Excuse me. And this was a really nice summary of this. This is a guy called Ed Hess. He works at Darden at UVA, and he sort of summarized this in this way. He said, these are the things: I feel safe with you, you care about me, I'm treated as a human being, I have autonomy, I have friends at work, and I have the chance to be all I can be. And then he said, 50 years says this is the secret formula. It's not rocket science. A really, really nice quote, which sort of sums it up, how important it is to get these things right for the people that you work with, because that's going to drive ultimately the performance and the output of your center. And positivity is really, really important as well. I, for reasons that I can't go into or really explain, I'm a Seahawks fan coming from London. But if you go to a Seahawks game and you watch Carroll, the coach, you can't really see it's him, but you can see it's him because he wears these ridiculous big white shoes. And you can see him bouncing up and down the team all the time, constantly talking to them, reinforcing things. And the positivity is almost, you can almost feel it. It's absolutely amazing. So instill that in the people, make them feel part of it. I think creating that environment where everyone can be of the best, everyone can maximize the performance and be the best they want to be. And you can define this in a multitude of different ways, and you could have a seminar on this alone going on for days. But the way we think about it is in these three areas: value, purpose, belonging. So if people feel values, if they think that you value what they have to say, they will speak. And great ideas do and can come from everywhere, and you will be amazed what comes. And I'm really always want to try and hear what people have to say, because people with very different perspectives, very different understandings will give you a very different ideas and may be the sort of key in trying to understand a particular area or strategy that you're trying to address. Give people purpose, make them feel that they're doing something purposeful and that each day they get up, they come to work and they're doing something that makes them feel good and aligns with the values of your organization. So this is a quote from a guy called, this is Greg Dyke. He was Director General of the BBC, and that's the quote he gave. And he ultimately had a bit of a spat with Tony Blair, who was the Prime Minister at the time, and resigned because he stood by one of his reporters and refused to back down. And when he left the BBC, 10,000 people lined the streets to wave him off for the final time. So when you saw that, and I'd heard this quote before that when I heard him speak, you thought, well, you actually did do what you said. Belonging, again, I think for me is fundamentally the key component of that, because if people feel like they belong, they really invest in the team and they will really want to be part of it. This is a synopsis of a very nice paper by Amy Edmondson and Melissa Valentine. And what they did is they went to a big emergency room. They didn't say where it was, but they put in some very basic frameworks of what they call teaming into the emergency room workers. And this was sort of one of the things that came out of it. There was a sense of belonging to a team, enhanced camaraderie and ownership, reducing the hierarchy, which ultimately acts as a barrier to communication. So just introducing that very, very simple metric, the belonging improved, added many other factors. And ultimately what they were measuring was clinical performance, and the patient throughput in that emergency room improved by 40%. So how many people wouldn't sort of die for that right now? Because obviously emergency rooms are absolutely chock-a-block. So there are very, very clear, tangible performance outputs that you can measure related to these concepts. If you're interested in it further, this is a fantastic book by a guy called Owen Eastwood, Belonging. He's a Kiwi, he's got a lot of Maori ancestry. It's a really, really fascinating book. He goes into it very, very deeply, quite a spiritual book in many respects. And I think the best story is of the gentleman there on the left, which I won't tell you. I don't want to spoil it for anyone who wants to read the book. But if you want belonging to be sort of really encapsulated in one single story, I would strongly recommend reading it. So conclusions, building your center of excellence. Well, start small, but try and think big. Think, what could we really become? What have we got at the moment? How can we sort of focus on that? I think if we think of the decade that we've just had as the decade of genetic discovery, I think the next 10 years are really how we're going to leverage that information for the patient benefit. And it's a really, really exciting field to be in. And I think the next few years is going to be really, really transformational. Know your own strengths, define them, understand what they are, and focus on them. But also understand your constraints. Don't worry about them. We all have them, of course, but really build on your strengths and know what they are. Create your vision, business model, and mission, and then work to define and interact with your local ecosystem. And ultimately build and invest in your team, because that really is the one thing that's going to drive you forward and promote you into a center of excellence. And of course, at the end of the day, it's all about the people. This is a picture that many of you may not recognize. This is a town called Everett in Boston. It's just north of the city. My son played Little League on these two pitches here, which is a Brit. Was all a bit alien to me, but anyway, he did. Don't know if he learned much baseball, but his language was certainly much more colourful afterwards. But the parking lot, as you can see, is just situated here. That's where you go in and park, and then he runs off and plays baseball. That building there is Best Buy. I drove in and remember looking at that in June 2020. So I was just delighted to be out the house, but looking at Best Buy thinking, how the hell is this organization still going? We've got Amazon, Apple, all these things. How did Best Buy survive? Well, the answer, if you're interested, is in this book. It's called The Heart of Business. And Hubert Joly was their CEO. He took over in 2012 when they were about to become insolvent, and he completely turned them around, and they became a very profitable and functional organization again by the time he stood down. And it really is, it's all about people. He fundamentally goes on about that. And of course, you can see the heart of business of the people there. I forgot to put this slide up in my first talk. I apologize. There's many, many people I work with. And of course, it's a pleasure and a privilege to work with them and be part of a much bigger team. I never really want to single anyone out, but I will single out these two people who are absolutely outstanding. And they give me the reason to get up in the morning and come to work. So thank you very much indeed. Look forward to the questions.
Thank you. We will now call up the first 4 speakers for a question and answer. I think Dr. Strasburger is on the line. Dr. Strasburger, can you hear us?
I sure can. How are you guys doing in Houston?
Maybe not. Or perhaps muted.
Hold on one second. I'll be right.
Hi, can you hear me now?
Dr. Strasburger?
Let's see.
Well, we'll check on that, Marshall.
Dr. Strasburger, can you hear us now?
Okay. Well, we'll try to get her online. I think she could hear us. We can't hear her. But we'll go ahead and start with questions if anyone has one. Yes.
Hi, I'm Ellis Rochelson. I'm just in my second year as an EP attendant. I have a question for you, Dr. Cannon. Could you share with me how you talk to coaches or staff at a school, for example? Let's say you've had the shared decision-making discussion with the family. How do you talk to a coach and you say, look, this kid actually, they have increased risk of sudden cardiac death, so please have defibrillators around, but I'm okay with them playing, but know that they've got risk of sudden death. I mean, aren't coaches going to say, no, I'm not putting that kid out there? How do those discussions go for you?
Yeah, I think that's a great question. It kind of brings in the whole community of people who take care of these patients, but having an emergency plan in place, AEDs available at all the places are actually very important. Usually the coaches are more interested in X's and O's than they are. And if you say as a physician that it's okay for this person to play, that's usually kind of the end of it. I mean, you may get some pushback. It's more team physicians and administrators rather than the coaches. So that's where you may actually get the most pushback is other organizations who's like, okay, we don't want this on our record. And so sometimes it does take some explaining that, gosh, this is low risk, but usually if you say, as a physician, I feel that it would be an acceptable risk to play. But it does come into play, particularly in college and pro, whenever that may be televised to hundreds of thousands of people. So you may run into problems with institutions or different organizations who don't want people to necessarily participate. But I think Dr. Ackerman has a ton of experience working with some big organizations around there, and basically saying this is what the pros and cons are, and this is what the data is that suggests it's okay to play. Therefore, nothing is for sure, but the risk is overall low. And I don't know, Mike, if you have any options.
No, Brian, that was great. I think the most important thing, single most important thing, is actually not the coaches, but the players and the families, so that in this whole journey, you have them well aware that what may be a successful shared decision-making experience at the high school level and the D2, D3 college level changes at the moment that athlete is good enough to be D1 or professional. So our batting average, as we've published, is at those other levels If Brian and I, in our approach, we permitted them to play, enabled them to play, 100% acceptance to play rate. At the D1 professional level, at best 50-50. So we say that shared decision-making changes from an SDM model to a BDM model or a TDM model. Business decision-making, their decision-making. And if you don't prep that family for that journey, they say, well, I had no idea this could possibly happen. And so they need to be very, very well versed that what's working so well as a model could come to a screeching halt at that tier of elite sport.
Yeah, and I think a lot of these institutions are looking for a no risk model. They want to have zero chance that something bad is going to happen. And if it can affect their program, because they may be getting paid millions of dollars for playing in a bowl game. If they have a bad event happen, it could affect their revenue. So I think a lot of time they're looking for the safest or the no risk option. And the easy thing to say from a physician and administrator standpoint is you can't play. And for them, one scholarship or anything else is a very small piece of their big puzzle, but that's clearly the easiest thing to do as a physician and as administrator, but it's not necessarily the right thing to do for the patient or the population.
But just like Brian pointed out, he was drafted for him. Without this lesion, he would have been drafted top 10, top 15. Value, so buyer beware. And that's what you just have to help them understand. Just like they did, it's interesting to know that they do a cardiac, they do an MRI on every basketball player. They have analytical data, big data, suggest what's the longevity of those needs. And they use that in their calculus. So it's at that level, it's completely different from baseball
Don, I never knew. There was a pitch. Milena, you have a question?
Yes. Hi, I'm Milena Gutierrez. I'm the fourth year EP fellow here at TCH. I have a question for you as well. Maybe not necessarily related to sports specifically, but in general, how do you usually approach the shared decision making, especially with families from a different background, different value system that potentially you're not necessarily very aware of or know very well, that tends to be a whatever you say. I don't want to tell you my opinion. It's whatever you tell me to do, I will do. And how do you get them to open up to that?
Yeah, I think that's a great question. And that's why I think shared decision making takes so long, is because it's not a one-way conversation. It's them giving you information, you giving them information. So I'll usually start out by saying, okay, tell me what you understand about this. What do you know about this? And then you get a gauge, okay, they've Googled every single article for the past 20 years, or like something's wrong with the heart. I mean, it kind of gives you an idea, but playing those value roles with different cultures and different religions and different value-based systems can be very, very challenging, but it's also very, very important to think about those kind of things. But the best way is just talking to the patients, but it takes a lot of time, which makes it a difficult part of this. But I think if you understand the patient and you understand the parents, you're likely to be able to figure out what the value system is. And at the end, asking them, say, tell me what we just talked about. And just having them recap it, I think, is a good way to say, okay, yes, they get it. Or, yeah, you said my kid can play basketball, so that's all I care about.
I'd advocate also that this is what Dominic's talking about your team also. Forget the varying expertise that every member of your team has. Families will often say something very different to the nurse, to the genetic counselor, to the social worker, will say very different things, not only to the different humans, but also to the different role that they're sitting in. And if you have myopic vision on what your opinion is about that balance, you're missing out on the opportunity to take care of what Dominic is saying in terms of integrating your team and what they know. And that's been a really fruitful method at our place. We have some, I think, very sensitive folks that have helped me learn and helped our whole team act better.
We have time for maybe one more question. Christina?
So this is a question for Dominic. I'm interested, integrating a lot of the different talks today, in particular Andrew's talk and variants and how they're changing over time, how we have a lot of VUSs. A couple of questions. Number one, when you think about a cardiovascular kind of genetics program, I know you have multiple different, many of us are in large centers where we have, for example, a group who may be doing a little bit more genetics, but really you can't really do EP without doing some genetics. How do you incorporate kind of your whole group in terms of getting the genetics counseling, getting the variant analysis in amongst everybody? Do you center it around a couple people in your program? Do you spread it around for all the EPs? So that's one question for the bigger centers, but also for the smaller centers who may not have access, who may not have that genetic counselor, but they're also seeing long QTs and CPVTs, genetic testing for them, counseling, that time. What do you see in the future as like the right, for example, kind of approach to all of this? I know it's a hard question, but just your thoughts.
It's a great question. So in terms of, we have a sort of a core team now, and we do most of the genetic work specifically. So variant analysis, all that sort of piece of it we would do. Other people may see a patient with long QT, they may send them to us. We will do the genetic testing, we'll do the family screening, whatever they want us to do. So that relationship is very dynamic, depending on the needs of the provider, the needs of the patient. Some people will come and see us once and go back. Some people will come and stay. There's all sorts of different ways of doing it. I think it's providing, what we found is the most helpful is just providing a very open, collaborative group of people who are very happy to work with others in whichever way they see best. I do personally believe, and there's a number of sort of documents from AHA, et cetera, coming out about this, that cardiovascular genetics is it's big enough now to become a specialty in its own right. And I hope that continues to grow. But I think bringing different people into the team with different areas of expertise, be it EP, be it imaging, be it, Dan Quiet in our group he's in the Seidman lab doing, all sorts of different things. And so having people with different expertise and different skill sets is really important. So it's sort of bringing that together, and that takes time to mold it together. But that's the way we've tried to approach it. Some people will say, this is all yours. Thanks very much. I don't see this. And others will have a different, and that's fine, whichever works best. In terms of the community beyond just our institution, we have the New England Congenital Cardiac Association, which was set up many years ago and long since predates us, but it's a very good scaffold for the community. And we've tried to build on that. So we sort of at meetings, we might give a talk about what's going on, how can we help, different sort of things, and just being very much a resource for people to phone us. And again, very different people have very different ideas of what they want. I think it's always good when people live 4 hours away that they do have good contacts with their local team. And so I think now with everyone becoming much more comfortable with Zoom, we can do joint, there's so many different ways you can do it now, and you can care for patients. So that's what we've tried to do, but having that scaffold in place was super helpful.
Thank you, everybody.
This is Jeanette. Can you hear me now?
We can, Dr. Strasburger. I apologize. The
I just
connection
had
didn't work.
No, I apologize too. I just wanted to comment about the prenatal aspect of bringing it all together. And I think we've integrated the electrophysiology with our adult congenital group. And so that's been very helpful in interfacing with our fetal care center and the prenatal genetics as well. So I just wanted to comment about the, sort of the concept of starting before the pregnancy. And again, as I mentioned in my talk, but I think, that having the right people there and speaking with each other is really important. So.
Great. Thank you. Thank you very much. We're going to move on. The next session is something I'm really excited about. It's a little bit different. It's going to be a quick panel discussion. So I'd like to call up Mike Ackerman, Charlie Berul, Bryn Decker, and Ron Cantor. And it's a little section we call Advice I'd Give My Younger Self, Wisdom for Career Development and Life. And so if y'all want to take a seat here, I know some of you have slides. And so, yes, we'll have Charlie start because he has slides. But as you listen to this, it's unusual that you have people that you look up to, that I look up to, like these people here. And so they're going to share a little bit about themselves and advice that they'd give to themselves if they were younger. And then we're going to open it up for a few questions if we have time. So be thinking about things you might want to know, advice, maybe outside of SCN5A and other things, So Charlie.
Yeah, I'm not going to spend a lot of time. I'm going to find the slides here. Is this me? Yeah. Yeah. So there. Okay. So yeah, we'll just start out as a team thing, just talking a little bit about some of the advice or wisdom for career development in life, which is a great thing. I had 3 things I wanted to say. Work hard, play hard, which is what a lot of the younger people call work-life balance. And I've heard when people looking for jobs, some of the chiefs say, if they ask me about work-life balance more than once, I'm not interested. But it's really important. And one of the things, Christina even brought it up to me earlier, one of the advice that I gave people is mix them together. So early on, maybe 20 years ago, I would bring one of my 3 kids to meetings like this. And Mike did the same thing without us talking to each other. And we ended up, I don't remember, I think it might have been Hong Kong. And our 2 boys were like 11 years old, sitting in the back coloring with crayons while Mike and I were lecturing. And I've done that continuously, bringing one of my kids to a meeting every year, whether it's small or big, and they're 30 years old and they still like to come with me. So that's part of the work hard, play hard, and mix them together. And I've heard people come up to me last week at AHA saying, I took your advice and here's my daughter's with me at AHA. So that's kind of cool. Be compassionate and empathetic, and they're different. Right? It's one is feelings and one is thought. And the patients aren't diseases. You hear that all the time. It's not the CPVT patient in room 55, right? And remember that bad stuff happens in EP, and you need to be resilient. EP is really a dirty business, as my old partner Ed Walsh used to say. Anytime something bad happened, he would try to console the younger attendings and the fellows when we had unexpected complications. And remember the Goldilocks effect. I think that's really important in EP. You all know the story of Goldilocks. If you don't want to do too little or too much. So if you think about catheter ablation as an example, do you put in a bonus lesion or not, right? If you do too little, you end up with a recurrence. If you do too much, you end up with heart blocks. You got to be like Goldilocks and do it just right. Same thing with like lead extraction. If you do too little, abandon the leads and kick the can down the road. That has bad issues. If you do too much, you pull out a little piece of my heart and can be complications from that. So you got to be just right. Take out the lead, maybe a little endocardium, but not the whole heart. This is one of my favorite slides that I put together. All these complex graphs that we've been looking at all day. This is a pie chart of all the patients I've seen in the past 30 years. I can name for you and picture their face. The ones in green that have had the complications, they live with me. And so this is about resiliency. You have to be resilient and not focus on the complications. You have to be compassionate and remember that it affects you as much as it affects them. All the yellow on this chart are all the patients I've taken care of that I don't remember most of them. Routine procedures, routine care, they come and have an ablation and they're gone, and I can't remember most of them. So just focus on that. There's a lot of good things that you do out there as well. I've talked about medical mistakes and errors in judgment. Just remember, these happen. You have to accept responsibility, discuss it with your colleagues. They can help you out and disclose and apologize to the patient, but don't be like Brittany and say, oops, I did it again. Mentorship is important. Someone else had a duckling slide up. I think it was Brian. So there's a couple of my ducklings in the back. The one in the middle is Greg. The little tiny duckling on the bottom, who's half Japanese, is Dr. Miyake. But I channel my past mentors and try to be as wise a mentor as they are. And I'm really proud to see that many of my mentees are now wise mentors. So advice I'd give my younger self: work hard and play hard, be compassionate, be resilient. And I wonder, when you ask the question, how young of my younger self, what would I tell this guy? So I've aged a lot over the years, and I got a lot of advice for my younger self. So thanks.
They're telling me I'm going next. My name is Bryn Deckard. I'm a nurse practitioner at University of Michigan. I have no idea how I'm on the panel with these amazing people up here, but I am, and I'm pleased to be here. I've been an EP for almost 20 years. It's a passion that I have and I love. I've worked with many of you in this room. To build on what Charlie was saying, I think mentorship is what I would say is the most important thing, and that's what I would tell my younger self. I was lucky to find a mentor at a very early age. As many of you know, Barb Deal was my first mentor and still my mentor. I had a decision to make last week, and guess what I called? Barb. She's the person that really got me started and someone I trust. I think that's important to find early on. And I think that you don't need just, there's not just one mentor out there for you. There's mentorship in many different ways. I have mentorship in research at University of Michigan with Martin LePage. Melissa Olin is a mentor of mine who's a nurse practitioner with Ron. And so you can take pieces of mentorship from many different people out there. And I think that's an important part of growing your career. And just like Charlie said too, it's really integrate your family life, your home life, your things that you love to do with your work life. Just like Charlie, my kids come to work with me sometimes. They loved, when they were little, they loved to come to get M&Ms that my colleagues would give them. So they love to know what I did every day, what happened, who did you take care of? They've met my patients, some of my favorite patients. So I think it's important to work hard and play hard, and also make sure that you take the time that you need to do your family things. This year, my son was in high school, he's a freshman in high school, and he was running cross country, and turns out he's pretty damn good, honestly. And I didn't know that he was going to be good. So my team helped me move mountains to get to all of his meets. I didn't miss one. Sometimes I was leaving at 2:00 in the afternoon, but I had colleagues and friends that I work with that really said, we will get you out of there so you don't miss this. And I'm very, very thankful for them and having them do that, push me out to get me to my family meetings and things like that. So that's what I would say is mentorship, and make sure you love what you do. If you don't love what you do, see if you can find something else, find another niche. But I love what I do. I love every part of EP. I love all the colleagues in this room today. And this is why I continue to do what I do every single day. You're up, Ron.
That was it was stunningly beautiful, Bryn, because Melissa Olin, who Bryn referenced, is our nurse practitioner extraordinaire, but she's junior to Bryn, and she's looked up to Bryn since the day I got there 8 years ago, and she's her.
Kind of, you can have a symbiotic mentor-mentee relationship, right?
There's a lot of information there, actually. So there's a lot of. Jeff was kind enough to kind of provide us a working list of questions that we should think about. And that sort of helped me because I need that kind of prompting sometimes. And I'd like to address it just from two different directions. Number one, I think it's really important to know yourself and to understand your temperament. Your temperament is that which you were given before you're even born, and which kind of determines your adaptability and your variety of other characteristics. And if you're kind of an amygdala-based person, which I am, you respond viscerally a lot. I think that you need to avoid shopping at the first store you come to. And I think you really need to do a proper amount of sampling. Even with NEP, you need to do a proper amount of sampling before you decide on your hook. You decide on what you want to concentrate on. On the other hand, if you're a frontal lobe based person, avoid making too many lists with pros and cons and getting paralyzed by that. And you know who you are out there. And I think that's really important. The other way I want to come at it is the fact that there's really nothing special or ordinary about me. I took advantage of opportunities, and if I could take advantage of the opportunities that I was provided, everybody here really can. So my story is I did my residency and most of my fellowship at University of Florida in Gainesville. I did do a year in Boston, and we had a fairly unique training program in that all of the pediatric fellows, all subspecialties, were under one umbrella by Bob Van Meerop, who was a famous cardiac anatomist. And he would bring in visiting professors quarterly. And one of the professors he brought in was Madison Spock, Maddie Spock, who was the chief of cardiology, pediatric cardiology at Duke. And he kind of took a liking to me. He was the a pioneer. He really discovered the concept of anisotropic conduction and is widely referenced for that. And he knew I didn't know any EP. I wanted to do EP because I had lost a couple of friends to the cocaine wars of Florida in the 1980s. And I knew it was cardiac, and I did a little bit of animal work with that. And he brought me to Duke to basically be an adult EP fellow for a year. Now, this was back when the only real established pediatric EP fellowships was University of Miami with Grace Wolf and Heinz Gelban, and of course Garson and Gillette here at Texas. And so I was an adult EP fellow, and I took those opportunities provided to me and took the next step. We were fortunate enough to get Tim Garson to be our chief for a few years, and he had me sub for him at a meeting in Sweden, and I took that opportunity. So my story isn't special. It just shows you that there's opportunities around every corner. Just make yourself available to them and know who you are.
Well, these three are so good. I'm trying to think what I could add as potentially a useful nugget. I'll do it in two directions. Noise. Academic cardiology is brutal, and there's a lot of noise. And by that I mean, so I would say find the mentor, take his or her advice, and then just ignore all the noise, because there's so much. And I'll give you the examples where the noise is. So there's a notion, right, that thou shalt do your training somewhere else every step of the way. And if you don't, that's not a good idea. So that got invented by somebody. And had I listened to that, that would have destroyed my career. Would have been the biggest colossal mistake. And so there's a key people in my life who said, well, why do you feel like you have to go to Boston because your PhD mentor went to Boston Children's? Therefore, you should go there and follow him. Who says you have to do that? And so, oh my goodness, I finally found the voice that I want to listen to. And once you lock in on somebody who's giving you wisdom, then block out the noise. I think there's a second layer of noise for those of you who want to do academics. And that for me went something like this: was the definition of your success is you need to progress to become a chief and a chair of something somewhere. And if you don't become a chief or a chair, you haven't quite made it all the way. Now, I don't know who invented that, but I thought that, I guess it's time for me to now do the chief search and the chair search. So the invites would come and I'd go look. And more recently had an opportunity. It was the final two for at Mayo, Executive Dean of Development. So I thought, I want that. I need that. I'm supposed to arrive to that. It's time to give back. And I look back, and for me, I was completely protected by the Lord on high, because had I been chosen for that, that would have been the biggest colossal mistake of my career, because it would have taken me away from what I know that I can do, what I'm good, well, hopefully what I'm good at, what I can do. And it would have been a complete distraction. And so I became content in what my competence is. And it's the patients that I love and wanting to get smarter about the patients that I love. And everything else was turning out to become a distractor. So there's so many distractions along the way. And then, so I would say, block out the noise, grab onto what you heard and said, that's it for me. And then I guess I have this vivid memory of Dr. Felt. So Dr. Felt is a pediatric cardiologist, I was in pediatrics. He meant the world to me, and he died, right? I'm a resident, so I go to his funeral, and guess what happened? Funeral's on Saturday. Guess what happened on Monday? Every single patient with a congenital heart disease at Mayo Clinic got seen without my most favorite person, Dr. Felt. So at that stage, that's now long ago, I became very, very grounded, and I'm comfortably grounded in my relative unimportance in this whole gig, and realize that I will never, ever sacrifice my family on the altar of this career pursuit. I want to be good at it. I'd like to be great at it. I hate losing, and I'm trying to become still, hopefully getting to become great at what I do, but I'm not going to do it at the cost. And it almost costed 3 years into this whole thing called marriage. I have a call from my dad, my father-in-law, saying, Mike, son, you're about to flush your life down the toilet, because I got so off track as to, is my wife with me on this bullet speed train, or is she kind of slowing me down? Because I'm going to get there. And December will be 34 years with her. So remember, just if you get grounded in how unimportant you and I actually are, and what real in our career path, that I'm 56, my life is 2/3 over statistically, my career is 2/3 over. When I'm done, every patient at Mayo is still going to get seen. And now I'm good with that, because I know I will stay focused on ultimately what really, really matters.
I know we're running a little short on time, but I don't want to lose this opportunity. So I'm going to ask to be able to push another 5 minutes or so, because I know there's probably some questions out there. You know, Bryn, my son played baseball, and it turns out he's pretty dang bad at it. But his baseball coach for a part of it was Lance Berkman. So he had the Astros come out and throw long toss with him. But none of the boys realized the opportunity there. So I just want to say, this is like playing long toss with the Houston Astros. So
We made it almost the whole day
without mentioning the
getting
Astros. Yeah, I know. I had to fulfill the bet. So Gaurav, you owe me $20.
So when I was at Boston, there were 2 of the attendings were Little League coaches of 11-year-olds. And we used to spot each other. If one of us had a Little League game, the other one would finish the ablation. If we were in the middle of the ablation, we'd go out and talk to the parents, and we'd say, we're doing this together, we're partners. And that attending, me or Ed Walsh, would leave at 4:30, because you can't disappoint, 15, 11-year-olds, right? Yeah. One of those actually kids is playing in the major leagues now, one of my 11-year-olds. So that was the best thing I ever did. Forget about EP.
Any questions from people in the crowd?
Hi to everyone, all of your opinions, especially about mentorship and how that kind of guides your career. I know a lot of it sometimes is just feeling who fits with you, who has similar priorities or mentality than you do. But I do think and hear of a lot of kind of younger people, and for myself as well in the career, it's almost like a checkbox. Oh, I have to find the mentor, and I have to, and how much do you balance? How do you even seek that unless it kind of shows up magically in front of you? And how do you balance that?
I would echo what Bryn said. It doesn't have to be one mentor. You can have a mentor for research. You can have a life coach mentor. You can have a buddy mentor, and it can be a whole bunch of people. It doesn't have to be one person. And you can do a speed dating for mentors and just talk to a lot of different people.
It shouldn't be forced either. And also, I would not always look for the people that are similar to you. Look for the people that challenge you. And I will tell you that Barb from day one challenged me, and I challenged her right back. And that's why we worked. So I think, because you want someone that you trust, but you also you want to make yourself better. So someone that challenges you, I think is important as well.
I think we're doing mentor-mentee completely wrong. Because I think we have this current notion, it's almost as if you'll walk up to somebody and say, will you be my mentor? And I don't think that's how it works. So like when I went into David Clapham's lab, he wasn't my mentor when I started my PhD with him. He was my boss. And over time, he became my mentor. When Andrew joined my lab, I wasn't yet his mentor. I hadn't earned that title. He wasn't yet my mentee. He chose my lab, and we worked together. And over time, this magical, beautiful, sacred thing called mentor-mentee emerged. And to where I watch him up here, and it's like This is my son that I'm watching. But it didn't start day one. Will you adopt me? Will you be my daddy? You know, it didn't start like that. And so I think we have the student body of today kind of thinking that you need to go to somebody and ask them, will you be my mentor? And I just think it's taken us in an incorrect path. It almost trivializes how beautiful it is when it actually emerges, because sometimes it doesn't.
Yeah, I think if, I don't know if there's statistics on this or data on this, but I think that if you looked at people's careers and you really could somehow define what that relationship is, I think you'd find that it's more organic. It's organic way more than it is institutionalized. And I also think, as has been alluded to by Charlie and Bryn, I think you have different epochs in your career where you have different, I'm not going to tell you my age, but I still have mentors. I'm old. And so that's okay. Don't, know who you are. And also, as part of knowing who you are, try to understand without overanalyzing it. We don't want to get all ridiculous about this, but also understand that if you are attracted to a person in this capacity, be sure that you're attracted for the right reasons, because it can be a dangerous world out there. And I'm not talking about really ugly stuff, but I am talking about possibly ending up unhappy with the decisions you've made because of the professional relationships that you might have made. It's happened more than once.
Anyone else? Maybe one more question. We'll have time if anyone has one. No. All right. Otherwise, yeah, I learned a lot. Thanks. For the last talk of the session, I'm going to invite Sam Sears up here. I try to invite him out as many times as we can. He knows that. But he's going to give us a talk on Comeback Kid.
Well, not only did this whole meeting feel like it was being part of an all-star team, but then following this group right here was is a treat. So thanks very much, and it's great to be here. As a psychologist embedded in cardiology for the last 27 years, now going on 28 years, it's clear to me my favorite thing about being a psychologist is the idea that people make comebacks. All this technology, all these things we talked about today is about how do we help our patients encounter one of the scariest things you could ever imagine for a family and for our patients and make a comeback. But the challenge, the problem is that so many of these situations start with a lightning strike, a medical lightning strike. They do nothing to necessarily precipitate what's happened. The risk comes out of nowhere, and it's severe. And they come to clinic feeling like they might scream. And the psychologic side of cardiology becomes a part that's really hard to integrate. Bless Dr. Abrams for trying to pull it together. He's got a psychologist hanging around. But it's tough. It's tough to produce these kinds of comprehensive outcomes that we seek. But comebacks are worth it, right? If in the midst of lightning, we can find a way through it, these comebacks are beautiful. They are everything. They are power in the sense of danger and in recovery. I mean, this stuff is poetry, right? I mean, it's just amazing. And we learned about athletes today that take risks and have to consider how can they come back? How can they play again? Comebacks are amazing, but they start with terrifying events. The events of our clinics that our patients follow on a regular basis, terrifying, right? Collapsing on an international stage, playing soccer. Seeing our peers terrified, uncertain about the future. Very interesting the way these, look at the guy on the far right. They know what's going on. They're not doctors. But the only way that we help our patients create a comeback is to create safety nets. Because we can't really take away the danger by itself. We can't say there's no risk. I think, Brian, you said organizations want no risk, but that's not how life is. We all have risk. We have risk getting to this meeting today. And I don't want to trivialize that risk, but rather to say even genetics can't give us exact ideas, but we can put safety nets in place that help our patients consider comebacks. And it's really this idea of what are the clinical hopes and dreams for our patients, helping them feel normal, have a normal childhood, to feel safe again in the context of threat, which is a psychological achievement, and to be active. Now, this turns out not to be so easy. This is this month's heart rhythm. This month's heart rhythm reviewed 20. This is an article just I pulled out. I hope everybody saw it. It's electronic gaming can trigger cardiac arrhythmias in some children. And the conclusion was, of these 22 handpicked children around the world, electronic gaming can precipitate lethal cardiac arrhythmias in susceptible children. We don't know who those are. We don't know what video games they are, but they just dropped dead. And thankfully, we've got some sane voices out there too. Dr. Ackerman's group, this is the paper from 2021, 20-year Mayo Clinic study suggests return to play is manageable. Safety nets. Because fundamentally, our patients have to decide to what extent do they pay attention to the scream, or to what extent do they pay attention to safety nets? That how do we help our patients identify the safety signals amongst the threat signals? Because threat signals get a lot more of our attention. Threat signals get a lot more of our attention. And so teaching our patients somehow to value what they have, even if it's got some strengths and weaknesses to it, some power. This guy's proud of his defibrillator, but he's got a tank on there at the same time. And when we look at psychological distress, I want to be sensitive to time, so I'm going to speed through a little bit of the adult data. But if you look at just what have we learned from doing research for almost 30 years in this area? Yeah, traditional psychiatric syndromes, those first three rows, right? Somewhere about 25 to 33% of our patients experiencing a traditional psychiatric syndrome. But look at the rows in yellow, where shock anxiety, an absolutely unique psychologic phenomenon for our ICD patients, occurring at rates that are much higher, avoiding activity at high rates. Now, it turns out most Americans avoid activity, but our patients actually avoid it out of fear. And then poor understanding of the ICD. It turns out most of the people in the hospital also have a poor understanding of the ICD, and I mean those are our peers. But in particular, not knowing about your ICD and the kinds of treatments. And we know, I'm summarizing massive amounts of literature here, we know that ICD shocks are generally faulted for anxiety, but it's actually way beyond that. I think Brian mentioned that often it's not so much exposure to shock, but the perception one might get shocked. We know that patients don't get all the things we're doing. We know distress is contagious. Families carry distress, not just patients. And we also know that good old psychosocial treatments really actually help these patients. They're just not very available. So when we start to turn now toward the pediatric group, which is really how I see this meeting today, is much more of a pediatric EP group in many ways, is of course we have multiple stressors like ambiguity, family stress, and medical stress. And I'll talk a little bit about ambiguity. And it's because there's so many changes that occur in our patients' families that are dealing with pediatric problems. We know about this age-inappropriate disease, grief. It's often occurring in the context of other losses in families. These families rarely come in without already some significant threats, but a lot of uncertainties, which are known to be psychologically toxic. Uncertainties drive people nuts. And when you look at the key issues around ICD patients, what do we know? I'm just summarizing massive literatures here too. Greg's work showing problematic anxiety about twofold in the ICD patient, high rates of activity avoidance we've shown, and then specific fears around being alone and worrying about shock and exertion in our kids. And more recently, we have great data about how this affects parents, and in particular, PTSD being quite problematic in our parents. 47% of parents of ICD kids reporting post-traumatic stress in a study that we just did in Heart Rhythm a couple of months ago. Prolonged grief, problematic, particularly in these families that have lost. And it's kind of a witch's brew of anxiety, depression, and grief. So it's not the case that we've got a bunch of victims here. I don't want to just describe that. I think it's the case that when we talk about comebacks, it's real. These patients, these families have a lot to overcome. And particularly when we look at this idea of feeling normal and feeling safe and being active again, this is pretty challenging. So far I've talked about the psychologic demands. I want to talk about the behavioral demands for just a few minutes, and then we'll talk about, well, how do we make a comeback? So when you look at the adult data, this has been a real focus of mine lately because I've been focused on accelerometers inside implantable devices, pacers and defibrillators, as a way to look at a proxy for essentially patients doing well. So using the accelerometer that's already in the EP printouts, how can we use that to understand what's going on with our patients? Since I don't see the day in which we're going to have innumerable numbers of cardiac psychologists ready to serve the way that I would like. So we got to start to figure out ways that we can make this work. Well, the bottom line here is that we've looked at this in this large pain-free SST study where we had almost 2,700 patients. And what we showed was, most importantly, that first, most adult ICD patients don't do very much every day because, you know, the accelerometer gives us minute by minute activity rates. And the data suggested that the average ICD patient in 21 nations around the world, followed for almost 2 years, the average activity level was 3 hours and 5 minutes a day, meaning that the average patient sits still or doesn't register a sizable enough amount of activity for 21 hours a day. So that's the starting point. And then if they get an ICD shock, it takes them almost 90 days to get back to that 3 hours and 5 minutes of activity. And this unique psychological phenomenon of shock anxiety persists almost 2 years. So problematic here is that when we start to talk about movement and benefit and quality of life and patients doing well and achieving the kinds of goals that all of us have, despite the complexity of every talk that came up here today, everybody in this room wants our patients to live normal and vibrant lives. It was said very explicitly in some talks, not so much in others, but that's why we do this work. And so when you look at kids, and we turn toward the largest sample of kids' activity levels that we've ever had, I mean, this is a sizable number of patients, kids, less than 18, with 1,900 device patients, average age of 14. Good news is their mean activity level was quite a bit more, and it was affected by things you'd expect. Pacemaker patients being more active than ICD and on down the line, shock history being associated with less activity. But here's the plot. And you have on one side 3-year-olds, then down here to 18-year-olds. And most of you can kind of look at this. Wow, you know, hey, 3-year-olds and 4-year-olds really, they're rocking, man. Their parents are like, wow, I can't keep track of those wild rascals. But notice how the plot changes as adolescence starts, as the development of fears starts, as the development of peer relationship starts, that it starts moving real close to our adult sample. By the time we get to around, what is it, about 13 down to 14, we start approaching our more adult levels of averages, meaning that perhaps, just a hypothesis, perhaps among the things that might be going on here is the development of fear. And that maybe taking a step toward movement is a step forward, but maybe sometimes we take steps backwards. And from a psychological standpoint, before we talk about how do we make these comebacks, it's really these 3 elements. That if I could put one idea in your mind about what could you take from a psychologist that's been studying EP their whole life, I would ask you to think about these 3 red boxes. That when our patients present avoiding activities or emotions, when our patients present with hypervigilance, excessive attention to their cardia device, or when they present themselves by saying, if my daughter faints again from POTS, I don't know what I'll do. That when our patients get to these extreme kinds of ideas, they're not being understood. They're not engaged anymore physically or emotionally or socially. We've got a problem. And it's there where I think psychologically, each one of you can exhibit a degree of psychological insight to help our patients be more engaged. So again, I'm sensitive to time, but I want to put myself on the hook a little bit. And that is, how do you make a comeback? Now think about the things in your life you've had to overcome. Each of us know or have some personal insights about how you overcome things that were disappointing or discouraging, or didn't go the way you wanted, or put yourself in danger, or got traumatized. Making a comeback's a fundamental life skill. But our kids with defibrillators and genetic conditions have to learn that kind of early. It's a pretty challenging deal. I mean, it's hard for grown-ups to make comebacks. But in my time with you, I'm just going to share with you, I think, 4 concepts that you can also be thinking about as you activate patients and engage them to overcome. We'll talk first about this idea of validation and cardiac safety. How do we create that? Comeback coping, so things people do that are associated with getting through something. We'll talk about ICD school, or I'll call it cardiac school for people without ICDs, and then avoiding avoidance. So let's start with the idea of validation. So when you look at general psychotherapies and you say, how do people overcome terrible things that happen to them? All psychotherapies essentially start with validation. They start with the idea that the human experience can be understood empathically by reflecting or identifying the emotion that someone puts to someone. Now, I can show it to you both ways. I think all of us have told a friend or a partner something that was really on their mind, and the person understood us, and we somehow got better as a result. The alternative is when your flight is canceled and you go to the airplane counter and they say, yeah, oh yeah, that's canceled. Well, why? I don't know. We'll get you on another flight. Yep, but I missed what I was trying to do. Yeah, whatever. And that's why you have, I don't know if I'm allowed to say the Karens or maybe Joes or whoever it is that people act up at counters because they don't feel validated, right? I mean, they just don't, it's not, we can't make a new airplane happen, but they don't feel validated, so they lose their mind, right? And so validation is the starting point. So I think most of our patients can benefit when we remind ourselves about the fundamental concepts about how people function. That while we need food, water, shelter, and Wi-Fi, we also have to have security. The idea that creating security is a fundamental building block. So a different way I always like to say this is this, right? So our patients with cardiac disease, right, prevent premature death. That's what we've been talking about all day. But I go over every single clinic with my fellows, my cardiology fellows. I say every single clinic, nobody should leave here without feeling safer from having walked in this clinic. And they say, but I'm just here to do the medicines. And I say, yeah. And at the end of the day, the consumer, the patient, the family needs to feel safer, because then we can achieve the other kinds of goals that I'm pretty sure that you have, which is quality of life. But there is a psychological exchange that's necessary to be able to achieve that. I mean, it's like these guys, right? I love this old picture. I don't even know if it actually happened, but I think it's a really cool picture in which you live together in peace of mind with both the threat and colleagues or support, and that fundamentally cardiac safety is so important. I think for SADS, I guess last year, maybe it was, I gave a talk called Safety Nets. And it was just about the idea, how do we create that? And I think, interestingly, as we move away from it, everybody gets a defibrillator that has anything that looks like an irregular heartbeat, we're going to need to be thinking about how our care still provides safety nets, with or without an implantable defibrillator. That safety nets are this idea that we have supportive care for our families and our patients that is both technical and validating. So emotional validation and feeling safe is, I think, the first step of a comeback. And I think that's pretty achievable in your clinics. Is that rain, or am I experiencing hallucinations? Wow, okay, yeah. So now you're really stuck here, right? Now you actually, all right. So let's talk about cardiac coping for just a minute, this idea. What are the keys about coping and why the safety net's so important? A lot of people say, well, I want my patients to be really informed, and I always wonder, like, why? You want them to pass a medical school exam or something? No, I want them to value value the care that we're providing, value the scope of what we're doing, technically so that patients understand and can trust both the care, the device, and start to build a future. See, I want our patients to have some swag, right? I want them to be like, yeah, this scar that I have that doesn't look so good in my bikini, my female patients or whoever, I think that's the best part of you. And somebody that doesn't love you because of that scar, you need to get rid of. And further, you need to have a little swag that you know more about life than everybody else your age. You know life's a lot more fragile. And you know that your family's a lot tougher than you ever could have imagined. And I wanted to be a football coach, and you're starting to feel that right now, right? You're like my ball club. I got a chance here to win. But that idea, right? Being a warrior and just saying, yeah, I gotta do this. You know, I don't know if you need to tattoo it. I didn't really recommend that, but you could. I want to speak just briefly about why this is comeback coping so important. You know, if I had to size up one of the biggest challenges in an EP clinic, it's ambiguity. Ambiguity is a toxin for our patients. The problem is, right, lots of our lives are ambiguous, but the stakes are so high. And the tendency to try to use information to cope is natural. So one of the things that I admire about a lot of what we talked about today is trying to minimize ambiguity, try to use information to do that. And I think we heard it over and over again, even when we were talking about, you know, pro athletes or something, that ambiguity must be addressed. You really can't leave things ambiguous. The research on ambiguity is such that if you leave things ambiguity, if you put human beings in situations where there's high stakes and they're not certain what it is that's going to happen or what they should do, they will make up causality. Okay, so it's the fundamental aspect to conspiracy theories. You take pieces of data that maybe don't go together and weave them together in a story, and now you have conspiracy stories. But there's many, many examples of this, and there's probably a very strong evolutionary value to taking disparate pieces of data and saying, well, there's these tracks in the ground here, and sometimes after I hear the bushes rustle, a saber-toothed tiger comes out. And so you have to put together information in ways to protect yourself. And that's why ambiguity is so important. And so much so that I even talk about VUSs in this, but I'll just simply say this, that threat detection is automatic, but safety detection must be deliberate. You must emphasize how security is being won, how security is being gained, because in the absence of that, threat detection will persist and win. And there's lots of examples of this. But the very idea is that threat detection is an evolved skill set, and reassuring yourself probably isn't. You know, and I tease our younger patients. I say, oh, you watch Naked and Afraid. All right, well, I don't want you to be on Implanted and Afraid, right? That would be a pretty bad show. And instead, I want you to really focus on how are you going to trust the future? Psychological well-being depends very much on what you believe about the future. So helping our patients understand that, yes, today's defibrillator is this. Yes, today's pacemaker is like this, but we're going to keep getting better. Today's medicines do this, but we're going to keep getting better. And the idea that the future can be desirable is an essential element to all of our mental health. In fact, the best single predictor of suicide amongst younger people is belief that the future won't matter. There are other predictors at other points in the lifespan, but hopelessness is a very important predictor of basically giving up. And so trust in the future is a really important idea. So coping with both unknowns and opportunities are part of comebacks. I won't spend much time talking about ICD school. I just think it's important that people learn as much as they can about their condition and their future. I love this quote from Steph Curry. He's in love with getting better. I want my patients to be in love with getting better. I want my patients to be in love with finding a way through the scariest things in life. I want them to love that. I want them to be powered by the very threats that other people see as diminishing to them to be powerful for them. Being in love with getting better. I just think that's a What a hell of a quote. I love that. I really hope that I do that. I hope that you do that. I won't spend time about this. This is just simply that ICD school works, that when we help our patients and as families build information and understanding, a shared understanding is a power that helps our patients also have knowledge and value. I want to spend the last part of my time just talking about avoidance. Avoid avoidance, right? So when you look at the most recent ideas about how do anxiety disorders develop, how do people become diminished or psychophysiologically aroused excessively, how does that happen? It does appear that avoidance is a massive component of it. So I have a colleague who says, I try to experience everything all the time because as soon as I avoid it, it builds in power. For heart patients, the tendency to avoid exertion, the tendency to avoid strong emotions can be a problem. And one of the things that we do then is we really talk about having standard operating procedures around activity, that all of our patients must have a plan. That is, what are you going to do to be on the right track when you leave here? How do you get back into the swing of things, right? So we're constantly talking about these different plans. And, you know, in a patient that's quite ill or debilitated, it might be, how do you find peace of mind? It might be, what are your specific activities you're going to do? You know, how will you manage an adverse event, let's say a shock in this case? Helping our patients have a specific set of plans is part of avoiding avoidance. Plan for some of the barriers rather than be surprised by them. And you know that the data on exercise is actually associated with highly desirable benefits. I'll just highlight this bottom part here, right? That when you look at the meta-analyses of ICD shocks, the natural thing for ICD patients is to withdraw. Boy, that must work. Maybe that'll protect me from getting shocked. No, it's actually the opposite. So it shows you that some of the natural ways people cope do not result in the outcomes they seek. So the final points about avoiding avoidance is that part of making a comeback is being flexible in how you might achieve that. We heard that in different ways today, even when Brian Cannon was talking about, well, just because you approve somebody to go back, you may negotiate how you might do that. And so this idea of the serenity prayer about recognizing, hey, some things we got to have a plan to address directly the problem. Some things we've got to have a plan to address the reaction to the problem, and we need to have the wisdom to know the difference, has to do with the idea that there are different kinds of coping strategies necessary to be successful. Sometimes we've got to get it done, and sometimes we've got to accept negative emotions. And that psychological concept of those two components is rather complex. I'll call it having little victories like Tour de France, where you can't win the Tour de France in one day. You can't win it in 2 days. It takes 17 days to win the Tour de France. But if you can put forward small wins over time, you build that kind of successive set of strategies and successive victories that help you win. So with that, I want to talk just finally about avoidance again, and that I'm so pleased that the science, the leadership, the clinical care of our patients is moving toward re-engaging them and not disqualifying them. And while disqualification may have felt great to the Bethesda conference in 1995, it produced two sets of problems. One had to do with the heart, the other had to do with the mind. And producing more comprehensive outcomes that involve patients who are engaged and empowered and care and achieve the kinds of things we want does require the stepwise re-engagement, because that's where they can feel normal, safe, and active. It reminds me back to my soccer player, right? I love this guy's quotes. Check this out. Christian Eriksen. My ICD is here for my protection. It's in me because if anything would happen to me, there's no need for a defibrillator because I will have my own. It is just really just extra security. I am more protected here than you guys. And that's how I feel. I feel protected by it. I feel normal. I don't feel it in any annoying way. Only going through the airport, I have to go around instead of going through a scanner. And as you know, part of that comeback for him and his medical condition I don't know him, I didn't take care of him, but Christian Eriksen has this opportunity to come back. And despite the significant experience that really traumatized the soccer world as he was there, he has this opportunity to make a comeback.
Back now with our play of the day in an emotional comeback. Last June, the soccer player Christian Eriksen collapsed from cardiac arrest at the European Championships. Medical personnel's quick response saved his life, but it was believed he would never play again. Well, take a look at Christian yesterday, leading the Danish national team out in the same stadium for the first time, just 291 days later. But it gets even better. Christian scoring a glorious goal, as we see there, and he was chosen as the man of the match. He told the press, quote, to lead the lads out was very emotional. It was a lovely feeling, and what a lovely comeback story.
That is. Thank you for sharing.
That's how you do it. That's how you do it, right? Great medical care, great grind and drive and desire. The opportunity to make a comeback might be more important than the sport he plays. Thanks very much.
Thanks, Sam. We have some time for a question or two, if anyone has one. Yes, Ron.
Thank you, Sam. It was wonderful. The elite athlete got there for a reason.
Yes.
And that is the person who's going to do what Eriksen did. It's through, I think, the efforts of SADS with its peer meetings that now occur online every month, I think.
Yeah.
That really is going to help those whose temperament does not put them in that self-motivated category.
Well said. Yeah, I think that's right. And I was thinking about that today with some of the data, right? Some of the athletes' physiology is actually in their favor. And I think their psychology is also in their favor, which is like kind of a great way of saying what you said. I think we can help though patients do that. I don't know that ordinary people do extraordinary things sometimes. And I think they can do that when we can validate them, show them the way, support them as they make successive approximations toward the goals. So I do think there is some eliteness about athletes, but I do think everyday people can actually demonstrate massive amounts of courageous returns and comebacks as well. So yeah, I think both things can be true.
Any other questions? No? Thank you.
Thank you.
Oh, there's one more here.
That was a great talk. Do you ever find trouble in balancing like the safety nets versus it holding them back? Say like we have kids with arrhythmias all the time that now wear the Apple Watch 24/7.
Yep.
And whenever the heart rate goes over 100, they just stop. And that's the safety net's supposed to be there to help them, but it could be holding them back.
Yeah, that's right. I would say, hey, sir, little guy, whatever. Hey, why are you wearing a watch? What do you want to get from this? Oh, I don't know. So control. Okay, possibly. It's not like my kids that are, in their 20s, they wear the watch and send me normal EKGs all the time. They're curious. That's not a good reason to wear that watch, right? So I think part of it is clarifying the motive of why are they monitoring at that rate? I think that's actually a sign of anxiety, not actually a sign of what they say it is. Although it can be a sense of grasping for control over uncontrollabilities, but one of the powers of coping with this disease is ultimately to accept what you can't control, because there's risk in our lives, and we can only dress that up so much. At some level, there's an acceptance or a tolerance for both negative emotions, a tolerance for some degree of medical risk, and a safety net to minimize it. That's how it works.
Mike.
Mike.
Beautiful, beautiful talk.
Thanks, dude.
You've had so much exposure to a variety of physician personalities, right? How do you start to have a conversation with the physician who is intrinsically paternalistic or maternalistic?
Yeah.
Where they bring to it their, I won't let my child do this.
Yeah.
My typical comment back to that physician is, well, he's not your child. Where they inject this notion in that way. And we've dealt with that style of medicine for a long, long time. In your conversations, what's your approach or what's your observations?
Well, I'm shaking my head because I think that can be really tough, because you're talking in a way, to use Ron Cantor's words, that's their temperament, to essentially be paternalistic or maternalistic. I don't know that I have magic beans on that one. I think the key is to sort of say, hey, are these your needs or the patient's needs? So I think some physicians need that to be sort of in control of the encounter and to be the expert in the room and sort of have the final decision. I would sort of say, hey, whose needs are we serving in this encounter? Because I think shared decision making should come from the idea that that it's a shared set of needs and dynamic interface rather than a one-way street. And I think being maternalistic or paternalistic is associated with a one-way street. So I would talk more about the idea of, hey, if you're somebody who tends to do that or a colleague, I might say, hey, let's make sure we talk about where do our needs stretch out and end, and where do the patients, and try to respect the patient having I'll say the final word, but that makes it more black and white. It's dynamic. And I think paternalism and maternalism, however you describe that, is not dynamic. It's really one way. Well, I could do this all night. Thanks very much, everybody. Love being here.
Well, thank you, everyone. I'm just going to quickly close us out. I just want to start by saying a few thank yous. I want to thank the EP team at Texas Children's, because I'm actually on service today. And so if you see people scurrying around, it's because they're answering calls for me. So thank you. I want to thank the SADS Foundation. These things don't happen without you and the engine behind it. So it's a great conference. And I want to thank all the speakers. I think everyone would agree it's a phenomenal group of talks. You know, I started the session with one word, and that was finally. And I think if I end the session with one word, it's going to be wow. And I think it's wow because of two things. One is I'm amazed, at the progress that's been made. It's not that long ago, maybe 20 years ago. I remember talking to Gaurav about this. I can go to a meeting one year, then the next year, and then the next year. And I would say, I don't think a lot has changed. But I feel like now you miss a year and there's so much going. The velocity of knowledge is so fast that it amazes me. The other thing is I'm amazed at commitment of the group, of everybody here. And that's commitment to each other, because we're all here to learn. And you could hear it in the questions and the discourse that humbly we want to learn from each other and get better. And also commitment to patients, families, and the community. And because the last part, which we didn't emphasize here in the title of the session, is patient-centered care in inherited arrhythmias. And everything we talked about, whether it's about SCN5A, big data, all those things, is all to put the patient and the families at the center. And so I think, and I'm hopeful that this conference accomplished some of that. And so I'm grateful for all of you coming, grateful for all the speakers. Logistical things. We're going to put up a CME tracker thing up here. So if you scan that, you can claim your CME, give us a little bit of reviews. There's some on paper here that you could scan. If you don't want your name tags and you give this to us, we'll recycle them for you. But thank you all for being here.